evaluate the nature of the chest pain and how it can differentiate from the ischemic and non-ischemic. Chest pain like nature, whether it is stabbing or a pleuritic chest pain, how it onset, it was a rapid onset, sudden onset, severe chest pain, or it was a gradual onset of 2 to 3 minutes and picking the location, it is a retrosternal, right side, left side, or any kind of radiation to the right shoulder, left side of the jaw or umbilicus, or radiation to the back, any kind of aggravating factor, that is whether it is increasing on exertion or relieving some medication, or whether it is associated with some kind of respiratory movement or body postural movement or tenderness, that will help in our diagnosis, localizing the diagnosis. It should be quickly, hardly 1 minute it takes, and the things can be easily localized. Then we should also have a risk factor association that also support our diagnosis. Apart from this, we should have a physical examination and further investigation as per requirement we should do to localize the diagnosis. In chest pain, initially we used to write typical or atypical. The recent 2021 we have published that the chest pain should be either defined as cardiac or possible cardiac or non-cardiac. Atypical word should be not used. It is actually atypical is a misinterpreted word. So how chest pain should be differentiated, which features a patient come with chest pain that includes ischemic in origin. If chest pain is central, pressure, having features of pressure, squeezing, having radiation to the shoulders or the jawline or up to umbilicus, exertional related, or it's relieved with some medication. So that group of the patient with chest pain have a high probability of ischemic origin rather than the patient which have a chest pain like fleeting type or pleuritic chest pain, positional variation. These kind of chest pains are more likely of non-ischemic. So according to this, we can differentiate that this group of the patient have a cardiac chest pain, ischemic origin, or possible cardiac or a non-cardiac. So apart from these symptoms, we should always have a physical examination. For example, a patient with chest pain coming with us to having diaphoresis, tachypnea, tachycardia, features of low blood pressure. Actually, this indicates that the probability of cardiac involvement is high. So apart from the patient which are coming with chest pain with a feature of emesis or having a features of decreased breath sound, pneumonia, this group of patients have a feature of less ischemic in origin. So physical examination and proper clinical history examination leads to differentiate that which group of the patient have a ischemic in origin and which group of the patient chest pain has a non-ischemic in origin. Apart from the cardiac origin, coronary artery disease, other cardiac problem also may present with chest pain like aortic stenosis or in this group, a proper physical examination help to localize our symptom. For example, in aortic stenosis, a typical murmur of pulses, tardus and power carotid pulses, low volume, slow picking pulses, which help to diagnose aortic stenosis. Features murmur of AR also help in diagnosis. The patient may have aortic regurgitation. If a patient with pericarditis, typical presentation with patient chest pain increases on inspiration and get relief in sitting position and aggravated on supine position, that indicates pericarditis. If the patient have a feature of chest pain along with symptoms of heart failure, it also indicates that the myocardium has been involved. There is some kind of valve motion abnormality. If there is epigastric tenderness or association of chest pain with food, it indicates GI involvement or the positive Murphy signs. In case of pneumonia, the features of fever or pleuritic chest pain or symptoms of on auscultation of pneumonic consolidating sounds indicates pneumonia. Pneumothorax, we will get features of acute sudden hypotension or decreased breath sound in that area. It's in pneumothorax. Herpes zoster, particular dermatol tenderness indicates a herpes zoster involvement. So a particularly important, I think, in particularly comment on the chest pain, not only chest pain, patient with omen, particularly female patient. These are the group of the patient which we missed as in emergency for MI, because in females, particularly diabetic or elderly females, there is a presentation of associated symptom. They come with associated symptom more than the particular typical like chest pain. Associated symptom like they may have a feature of fatigue, they have feature of giddiness, syncope, shortness of breath. These symptoms should be more precise, more common in female group of the patient. So females, apart from chest pain, we should evaluate these symptoms also to rule out acute chest pain. Further, in elderly patient, the features, ACS should be considered if elderly patients are presenting with the features of shortness of breath, syncope, or acute delirium. In this scenario also ACS should be ruled out. What investigation? Apart from the clinical testing, what investigation? It is dictum. If a patient with chest pain coming to us in emergency or any OPD patient, the first step is to do an ECG as early as possible within 10 minutes, unless you are 100% confirmed that this chest pain is non-cardiac. Sure, the ECG is a prior criteria. If you suspect, if ECG is giving the diagnosis, or if it is giving some confusion, we should go for cardiac marker, high sensitive cardiac marker. So it's more or less it give you the chances of ruling out of or ruling in of cardiac origin chest pain. So all these are cardiac class 1 recommendations. So delay in transfer is not to be done. If a physician's getting patient of chest pain acute, it should be early doing ECG or etc. It should transfer to the higher center as early as possible. Similarly, I was just saying that after chest pain history physical examination, we do an ECG and we will classify the group of the patient accordingly. Whether it is STEMI or with a STEMI, we will do treatment accordingly, according to that group diagnosis, whether it is a pericarditis, myocarditis, or anything else, or any kind of arrhythmia, we can treat the patient accordingly. Further, if after ECG, cardiac Doppler or echo, further what should diagnosis should be done, what for further investigation can be done. This is a criteria which has been recently explained by ESC and SEC guidelines both, that a patient coming with sudden onset acute chest pain with a feature of high risk criteria, there is a particular guidelines how to classify high risk ACS, we may directly go to the invasive coronary angiography to rule out the CAD. Or otherwise, if a patient has an intermediate risk, then we can go for further functional testing, stress echo, stress imaging, further to or CT coronary angiography to rule out coronary artery disease. However, in case of stable chest pain, whether a high risk or intermediate risk, we can go for functional testing priority. The most important thing is that if a patient presenting with acute chest pain and they are on low risk category, in that group of the patient, if you are ruling out with ECG, cardiac Doppler, echo, then further testing is not required. This is the most important. That low risk patient with acute or stable chest pain, further investigation apart from ECG or echo are not required. Dealing with a few cases scenario. Case 1. A 60-year-old male coming to us with whose risk factor of type 2 diabetes mellitus, complained with acute retrosternal chest pain with radiation to jaw for 8 hours. ECG shows, ECG was done, we saw ST elevation in the anterior leads, it's QRBB. Echo was done. It clearly showing the regional wall motion abnormality in the LAD region. Thus, the diagnosis is clear cut. It is an anterior wall MI, and the diagnosis and the treatment should be as per protocol. As it should be.
Dr. Pathak, can you summarize?
Yeah.
Can you quickly summarize?
Yes, sir. This is second scenario, was acute retrosternal chest pain. The symptoms. The most important thing is the patient has a patient with have a history of left calf pain. We showed the ECG showing T-wave inversion in the anterior leads of right side anterior leads. Echo was done, which shows RARV dilated along with the thrombus in the RPA. That indicates the acute pulmonary embolism, which leads to ultimately to the chest pain and hypotension. Further specific investigations was done. Third case, I have just understood that patient presented with acute ocean with typical feature of increase on inspiration and supine position, more suggestive of pericarditis. This is what the ECG showing concavity upwards, more suggestive of acute pericarditis. Last case, just a patient with smoker suddenly present with severe onset acute chest pain with radiation to back with a differential blood pressure. ECG was done. It was showing SCT changes in inferior leads. Echo was done. It's showing a flap in the anterior wall. This is the acute aortic dissection type A, Stanford classification. So it is emergency situation and it's an CTBS intervention as early as possible. This is a further CT autogram done, which showing dissection flap in the aortic valve, ascending aorta involving the aortic valve also. Take home motion for just last slide, 2 slides. What should the take-home motion? Chest pain doesn't mean only a chest pain. It should have an accompaniment. If we are dealing with chest pain, we should always search for accompanying symptoms so that the 2 to 3% of the cases which are missed in regularly in emergency of MI, ischemic pain, should be further bring down. Secondly, the high sensitivity troponin preferred, because now the guidelines from 2 times, it has been recently upgraded to 3 times level to more the increase the specificity. Thirdly, care is the early care for acute symptom. If patient with acute chest pain with specific diagnosis, if life-threatening situation is there, it should be urgently referred to the higher hospitals to where that specific treatment can be given to that group of the patient whose life is saved. Decision making, of course, whether to progress further for any investigation or not. The criteria is that we have to classify the patient into high risk, intermediate risk, or low risk. Low risk needs no further investigation. It can be safely discharged to the home. For high risk and low intermediate risk, specific guidelines are there to progress further. Secondly, accompanying already sent. Non-cardiac term is in and atypical is out, because atypical is a misleading concept, misleading term, so it is already now should be discouraged. Thank you.
Thank you for your excellent deliberation, Dr. Pathak. Any question? Okay. So can we move on to the next topic by Dr. Vinit Kumar? And he will be speaking on evaluation of acute breathlessness. Over to you, Dr. Vinit.
Good morning, all my respected seniors and dear friends. Thank you, CSI, for giving me the opportunity. My topic is acute onset breathlessness. I want to start with one simple case. Young male, he came with severe breathlessness in emergency. That is, sudden onset started during some sport activity. He was very lean, thin, hyperflexible joint in the hand, high arch palate, BP is toward the lower side. On examination, cyanosis was there, hyperresonant percussion note is there on the right side of the chest, absent air entry, and that trachea is deviated to the left side. So we'll see the case later after some discussion. Dyspnea, it's a broad term including variety of unpleasant sensation related to the breathing, including air hunger, sense of work or effort, or something is feeling very heavy. Usually we all are breathing and we are not usually sensing that we are breathing, but when we start sensing, that means we are breathing, that is actually that dyspnea. Every breath they are usually feeling, they are usually sensing it. So effortless breathing is normal. Whenever there is some effort in breathing, that usually we can say that is dyspnea. Dyspnea can vary in intensity, quality, depending on the underlying pathophysiological mechanism. Acute dyspnea is one of the main reasons for the admission in emergency department, and we need to identify the seriousness. And we have to categorize according to that. The respiratory system that maintain a homeostasis with respect to the gas exchange in acid-base status. Derangement in oxygenations or in acidemia can lead to dyspnea by a complex pathway, generally involving stimulation of variety of mechanoreceptor that is there in the upper airways, lung, as well as in the wall also. If we broadly categorize cardiac causes, respiratory, some anatomical causes, metabolic causes, and there is some other causes. If you want to see some serious issue that we want to identify early, pulmonary edema, massive embolisms, acute severe asthma or acute exacerbations of COPD, pneumonia, pneumothorax, metabolic acidosis, or some psychogenic etiology is also there. We need to see the associated symptom. If it is just like anginal pain, palpitation, sweating, that is usually indicate something toward the severe symptoms. For the respiratory, we will get some symptom related to them. Cough, wheezing, hemoptysis, stridor. If all these things is there, that will definitely narrow our diagnosis. A small S group, we have to consider one unusual entity. Foreign body inhalations is one common reason, especially in very young small children. Kusumal breathing that we can identify after seeing, because it's a deep labored breathing pattern, often associated with severe metabolic acidosis. There is something called life-threatening conditions that we need to identify early so that we can act early, like if level of consciousness is not good, central cyanosis is there, work of breathing if it is very fast, adequacy of oxygenation, that means oxygen levels, ability to speak, that means single word or sentence, cardiovascular status like heart rate, rhythm, blood pressure. Pulmonary edema is one entity that is usually very life-threatening and sometimes, so that we can identify that jugular venous pressure is elevated. If we auscultate basal cleft, or it might be more, it may be extending up to the apex part also. COPD and asthma, that is wheezing and prolonged expirations will be there. Pneumothorax, hyperresonant and absent air sound will be there. And again, it's a very life-threatening scenario. Severe breathlessness and the normal breath sound, it might be pulmonary embolisms. Especially if it is associated with the unilateral leg swellings, that might be more favoring for the unilateral embolisms. Initial investigation, as in every diseases, that's history and examination, especially if that individual is very sick, we have to stick in a short history and narrow physical examination so that we can able to identify the underlying etiology. Arterial blood gas analysis, definitely it has some role, especially that individual is drowsy, delirium, or if you are suspecting respiratory failure, especially in severe COPD or asthma, and in metabolic disorder for identifying acidosis. Psychogenic also ABG will definitely help because it will be normal in spite of all these dyspnea. To differentiate from our cardiac from respiratory causes, we have some investigation that is very much helpful. Echo, cardiac enzyme, and NT-proBNP. Because that heart failure with normal ejection fractions is one entity where the echo will be normal, dyspnea is there. But if we see the NT-proBNP or BNP level, that will be very much elevated. That will again help us to identify this group of individuals. Now we come back to our cases. Definitely after this discussion, we can easily identify this is a pneumothorax, and that individual is look like Marfanoid feature. Aspirations or drainage of that side of the chest will give the answers. If you see the stepwise approach, it is similar whatever we have discussed in the last slides. History and physical examination, X-ray, spirometry, and oxygen level will definitely need to assess early. After that, if we get something from that, we have to go according to that, like the ECG and echocardiography, if we are thinking something toward that cardiac side. And initial rapid assessment and stabilizations, especially in case of some danger sign, like depressed mental status, inability to maintain the respiratory effort, cyanosis, retractions of the accessory muscles, brief fragmented speech, inability to lie supines. Emergency stabilizations of the individuals with the danger sign, general measures, like giving the supplemental oxygens if the oxygen is very low, establishing the IV lines, and monitorings, that is essential for everyone. And in the same time, we need to identify the underlying etiology, that is more important. Obtaining airway management equipment and continue with the history and examinations, and we have to try to get some etiology based on whatever the history and examination we got there. And we can ask for some blood marker also that will definitely able to help us in some way. Breath sound during audible and lung auscultations, that will usually favor for the respiratory, and something is there that will favor for the heart side, like the irregular heart rhythm, heart murmur, heart failure sound is there, third and fourth heart sound. Distant or muffled heart sound, as in we are seeing in tamponade. Jugular venous pressure distension will be there. There is some symptom that will usually help us in diagnosing, like wheezing and cough for respiratory causes. Orthopnea will indicate toward the heart failure. Fever, hemoptysis will definitely go toward the respiratory side more. And pulmonary edema will ask for some acute and chronic heart failure, and as well as in some end-stage renal disease, liver disease, and sometime in severe respiratory distress syndrome also. Here for the lung to maintain properly, we have some controller, one ventilatory pump is there, and third is gas exchanger. Any difficulty in all these three will lead to dyspnea. And we need to classify according to that. Like the controller, even the metabolic acidosis and anxiety that is responsible. Neuromuscular problem like the Guillain-Barré syndrome, pneumothorax or ventilatory pump has some issue. There is some investigation that will definitely help us in identifying the etiology. Finally, we will summarize. There is some etiology already we have discussed earlier that is responsible for the dyspnea. Always we have to go for the history and physical examination first, and it should be short and precise, not long, and based on that we have to ask for some investigation that will confirm our diagnosis. Very much thank you. Thank you for
Now we will discuss after the end of this session. The question.
Thank you, sir.
I will call the next speaker, Dr. Nirav Kumar. He will speak on the evaluation of syncope. Dr. Nirav, please.
Good morning, everybody. After evaluation of dyspnea and chest pain, my job is to evaluation for syncope. So, syncope is sudden temporary loss of consciousness. It occurs when fall of blood pressure causes disruption in sustained blood supply of the brain. It's come quickly, does not last long. A spontaneous recovery is the rule, and there is no resuscitation is needed. In all the cases, there is cerebral hypoperfusion. The blood supply of brain is compromised. That is the rule, and that is the definition of syncope. So there may be several types of syncope like vasovagal syncope, situational syncope, postural syncope, cardiac, neurological syncope, psychogenic syncope. So there is carotid sinus syncope also. Syncope related to head turning, shaving, wearing a tight collar. So pathophysiology is carotid sinus pressure causes reflex decrease in heart rate and blood pressure, and this exaggerated response to leading to syncope. There is vasodepression as well as the decrease in heart rate also. So when we see the cause of syncope, the most common cause is vasovagal syncope. Large portion is still unexplained, and the cardiac cause is also important. Almost 9.5% of cases syncope is because of cardiac cause. So when we see by the age, if age is less, the neurocardiogenic syncope is more common. And as the age increases, orthostatic hypotension, cardiac cause increases. So that is the rule. As the age increases, the cardiac cause increases. So we can roughly classify syncope in neural reflex mediated, orthostatic, that is because of hypotension. It could be because of cardiac arrhythmia. It can be because of structural cardiopulmonary disease. So in pathophysiological wise, when we see why syncope takes place, it is because of decreased cerebral perfusion is common to all cause of syncope. Cessation of cerebral perfusion for a little as 3 to 5 seconds can result in syncope, and decreased cerebral perfusion may occur as a result of decreased cardiac output or decreased systemic vascular resistance. So when we see the epidemiology, almost 6% of hospital visit is because of syncope. So this is important chart to understand syncope. It is because of the center of all is low BP and cerebral hyperperfusion. So it can be because of low cardiac output, or BP depend upon cardiac output as well as peripheral resistance. So if there is fall in the cardiac output, like in arrhythmia, structural heart disease, cardiopulmonary causes, it will cause syncope. Or if there is fall in peripheral resistance, it may be because of primary or secondary autonomic failure, the peripheral resistance will fall, and that can cause syncope. The reflex syncope can be because of vasodepressor as well as cardiac inhibitory response. That causes syncope. So these are the cause, but the root cause is the low peripheral resistance or low cardiac output. So how we should evaluate the syncope? First we define whether it is syncope or not. Is there etiology is clear, or there are any high risk features? This is important to understand the syncope. So we should define whether it is traumatic. If total loss of consciousness is because trauma, it is not syncope. If it is non-traumatic loss of consciousness, it can be because of syncope. Epileptic seizure, psychogenic and rare causes are the differential diagnosis of syncope. So when we classify the syncope, it can be because of vasovagal, that is most common cause. The orthostatic vasovagal syncope, that is very common in standing in parade ground and there is fall. Fall is because of the condition which cause the fall in blood pressure leading to extra contraction of the left ventricle that lead to stimulation of C receptor, and that cause vagal overwhelming vagal response and bradycardia and hypotension. That is the cause of syncope. Other than reflex syncope is of maturation, gastrointestinal condition, cough and seizure, post-exertion, and several other conditions like carotid sinus syncope. It can be because of orthostatic hypotension. It can be because of drug induced like vasodilator, diuretics, phenothiazine, antidepressant can cause hypotension like alpha-1 blocker can cause. If there is volume depletion like hemorrhage, diarrhea, vomiting, it can cause. And primary and secondary the other important cause is cardiac syncope. It can be because of arrhythmia, it can be because of bradycardia, it can be because of tachycardia like supraventricular and ventricular tachycardia. So these are the three important classification of syncope. So when we start evaluating the syncope, we should ask from the history. History is very important, often forgotten art. We should ask regarding how it takes place, because if syncope takes place in daytime in standing, it is benign in nature. But if syncope is because of the started with the palpitation and there is syncope, if there is history of cardiac disease and there is syncope, it is of ominous sign. So it is always we should ask for the history. We should do the physical examination. We should always examine the blood pressure. If blood pressure is less than 90, it can be because of hypotension. If there is fall on blood pressure in standing more than 20 and diastolic more than 10, it can be because of postural hypotension. And we should do the ECG, and that will give us a lot of, then other specific investigation is needed. So syncope on standing may be one of the important etiologies. So we should always look for the blood pressure in lying down posture and a standing posture. If blood pressure fall is more than 20 in systole, more than 10 in diastole, or if mean blood or if blood pressure is less than 90 of mmHg, it can cause syncope. ECG give us a tremendous clue. There are several clues that syncope can be because of long QT syndrome, short QT syndrome. It can be give you the clue regarding the ARVD. It can give you the clue regarding the HOCM. It can give you the clue regarding the CAD, trifascicular, bifascicular block. Absolutely normal ECG put the patient in less intensive group. So if ECG not giving the clue and syncope is frequent, if it is very frequent, then we can go for the Holter. The other is ILR implantation devices are there, and so important thing is if symptom is frequent, we can do the Holter monitoring. If it is infrequent, then extended Holter, external loop recorder, patch monitor can be done. If it is very infrequent, then we can do the insertable cardiac monitor that can monitor almost 3 year the period. So it depends upon the symptom how frequent it is. So according to the guideline, this is the latest guideline, ESC guideline. Immediate hospital monitoring is indicated in high-risk patient. Holter monitor, similarly external loop recorder, ILR are indicated. These indications are in class 1 or 2A level. So it depends upon the symptom, how frequent is the symptom. Echo is also very helpful, particularly if structural heart disease is there. If aortic stenosis, HOCM, ARVD, echo can give you the clue. If coronary artery disease is there, LV dysfunction is there, that will give you the clue. So echo is important. It is almost class 1 indication, particularly if suspected cardiac disease is there. So this is the most talked test, the head up tilt test. This is protocol varies several places. Patient is used to incline in 60 to 80 degree, and if result is not there in NTG, in oral inhalation or isoproterenol infusion can be given to accelerate the result. So if similar symptom is produced during the test, and if hypotension and asystole is there, that is helpful. So tilt table test is also a good test. Almost it is indication is around 2A. So we should do the carotid massage, particularly if age is more than 40, we can do the carotid massage. And if typical symptom is produced, if asystole is bradycardia and hypotension is there, this very easy test can be done bedside. So it can be done easily, and it is indicated. This is class 1 indication. Carotid sinus massage is class 1 indication. It can be done bedside, so it should be done. If it is positive, then it is very helpful in diagnosing the condition. TMT is also very helpful. If some patient developing symptom during TMT, if some patient develops syncope during exercise, or there are several conditions which can produce syncope, like in CPVT, it can be produced with the TMT. If heart block is produced during TMT, it is helpful in diagnosis. There are certain conditions in which EP study is also required. If there are indication for EP study, if patient with syncope and previous MI or other SCAR-related condition, EPS is indicated when syncope remain unexplained after non-invasive evaluation. In EPS study, we can study the HV interval. We can induce the VT inside the lab. So particularly in bifascicular block, the confusion is there. So EPS study is indicated in some of the condition, not in all the condition. So if ECG documented bradycardia is there, if symptomatic sinus nodal disease is there, it is class 1 indication. If it is even acyanotic sinus nodal disease, it is pacemaker is indicated. In class almost the second advanced AV block and third degree AV block, EPS is indicated. If bifascicular block is there, in that condition, this is the controversial condition. We can go for EPS study or ILR. So, if cardiac tachyarrhythmia is the cause, SVT and VT the indicated, and particularly if EF is less than 35 and if there is syncope, better to straightforward we should go for the ICD. If AF is more than 35, in that condition we can go for EPS study, we can induce the VT. If VT is there, then ICD is required. So in presentation we should rule out the whether it is syncope or not. If it is syncope, then we should do the initial syncope evaluation, the ECG, supine and standing blood pressure, and the other specific tests which is required. The important thing is we should classify the patient whether it is high risk or low risk. If it is high risk, then admission is required. What are the patient who is under high risk? If new chest discomfort and breathlessness and abdominal pain or headache is associated, if syncope during exertion or when supine. So if it is syncope takes place during supine, it is important that it is high risk, sudden onset palpitation immediately followed by syncope. It is high risk if there is no warning symptom or short duration of prodrome, family history of sudden disease at a young age, syncope in sitting posture. So if syncope takes place with this sign, these are the high risk sign. And several structural and coronary artery disease high risk. If coronary artery disease is there and syncope takes place, then it is of high risk. So in physical examination, unexplained systolic blood pressure or in emergency department less than 90 mmHg, suggestive of gastrointestinal bleeding or rectal bleeding, persistent bradycardia in awake state and absence of physical training, undiagnosed systolic murmur. So these are the high risk. If some patient presented with high risk, in ECG there are certain signs of high risk. If ECG presented with acute ischemia, if Mobis type 2 block is there, slow AF, persistent sinus bradycardia, bundle branch block, sustained or non-sustained VT, dysfunction of ICD implantation, type 1 Brugada, ST segment elevation, QTC more than 460. So these are the important sign. So we should classify the patient according to low risk, high risk, and then if it is high risk, patient should get admitted. If low risk, can be discharged from the hospital. So these are the important differentiating point from syncope and epileptic seizure, and we all know regarding this. So in summary, we should classify the patient in high risk and low risk. High risk should be admitted and further investigation is needed. These are the high risk patient indicated several structural heart disease or coronary artery disease. If syncope associated with exertion or supine palpitation at the time of syncope, heart failure, NSBT, bundle branch block, sinus bradycardia, AV block, WPW syndrome, these are the high risk patients. So we should admit the high risk patient.
Session is open for question and answer. Any question from audience?
I think we are 15 minutes late. If no questions, we can go ahead with the next session.
Good morning, sir. It was a great presentation. Thus, just a simple question, sir. So, what do you think, sir? Which ECG finding is more appropriate for deciding whether this is due to syncope or it's not? A single ECG finding.
Yeah, ECG.
Suppose I have to do a study that the syncope is related to this ECG finding. What would you suggest, sir?
So if you go for the single ECG finding, if it is normal ECG, then it is of low risk patient. But there are several signs. ECG is often.
No, that what I mean to say, sir. Single ECG sign. What ECG sign?
So there is no single ECG sign. It can be because of trachyarrhythmia, it can be because of bradyarrhythmia. And there are several signs like long QT syndrome, short QT syndrome, Brugada syndrome, epsilon wave may be there. It can be because there are indications for HOCM also. So there is no single ECG sign, but there may be indication that there is problem. Yeah, bradyarrhythmia, it can be because of advanced AV block, complete AV block.
Patient
it
is
can
a
be because of
complete profile. One, I mean, I don't know, like if you can point out single ECG thing, if you're talking or something, thinking about short QT or long QT, even again, like you have to profile the patient. I don't think like any single sign.
Yeah, there is no single sign.
Any such studies, sir, which give any idea about a single sign? See, complete heart block is definitely a sign. This is the last sign. What we can find in the previous symptoms? A preventive measure, what we can take? That ECG which can predict that the patient is going to have syncope or not. A predictive kind of thing.
There are different causes of syncope.
Sir, this I know, sir.
But not any single sign in ECG that can predict. Even in the normal ECG, there cause the cardiac for the syncope. If there is normal, and previously there is the bradycardia. In that condition, there is the role of the EPS study. We have to calculate the SNRT or CSNRT. In that condition, if previous there is the bradycardia, or at the time of the admission, maybe heart rate 55, 56, 58, but you will find the significant value of the sinus node recovery time or corrected sinus node.
So there is no single sign?
Okay. Yes, sir. That I could not get it.
Your experience. Even every possible test, 30%.
Sir,
you can't diagnose.
I got the permission to attach this Cardicon to get an idea to develop a project only. So my wife has said that ठीक है आप जा रहे हैं लेकिन एक कोई आइडिया सोच के आइएगा प्रोजेक्ट का. So मैं ये सोच रहा था सर कि क्या कोई ऐसा ECG फाइंडिंग है जिससे हम ये प्रेडिक्ट कर सकें कि पेशेंट को सिनकोप हो सकता है या नहीं, एक या दो. कोई एसोसिएशन ऐसी स्टडी नहीं हुई है अभी तक. लॉट का क्वेश्चन नहीं है सर. आप लोग कार्डियोलॉजिस्ट
Thank you so much, and it was such an interactive session. Thank you so much, all the speakers. May I now request all the chairperson to felicitate our speaker with shawl. For that, I request all the speakers kindly come up on stage. I would request Dr. Sushant Kumar Pathak. Sir, please come. Dr. Vineet Kumar, sir, please do come on stage. Dr. Neeraj Kumar, sir, please do come. And our next session is Potpourri, and our chairpersons are Dr. V.K. Thakur sir, Dr. P.K. Ojha sir, Dr. Devendu Bhushan sir, Dr. Ashok Kumar sir, Dr. A.K. Thakur, Dr. Anil Singh sir, Dr. Shravan Kumar, and Dr. Javed Anwar. I would request all of you. Again, I repeat, Dr. V.K. Thakur sir, Dr. P.K. Ojha, Dr. Devendu Bhushan sir, Dr. Ashok Kumar, Dr. A.K. Thakur, Dr. Anil Singh sir, Dr. Shravan Kumar, and Dr. Javed Anwar sir. I request you all to join us for our next session. Thank you so much, everyone. Thank you so much. Doctors?
Dr. S.B. Prasad from Delhi also.
Dr. S.B. Prasad from Dairy On Zone. Sir, I request all of you, kindly join us for next session. And our next session is Porpori.
Dr. UN Singh.
Dr. UN Singh. I would request Dr. UN Singh. And our next, first of all, I would request for the speaker, Dr. Nitish Kumar Ranjan. Sir. Dr. Shyam Narayan sir, sir, please join us. Our chairpersons are on dais. And today we have as a speaker Dr. Sushant Kumar sir.
Hello, respected seniors, dear colleague, and ladies and gentlemen. Good morning to all of you, and I am Dr. Nitish from IGSC. And topic for today is pulmonary embolism, when to suspect and how to manage. Very common topic, and basically I am covering here the acute phenomena here. So point to be discussed, signs and symptoms, risk factors and differential diagnosis, diagnostic tools, management, and some newer guidelines. So what are the symptoms? So in 85% of cases, dyspnea is the commonest things we get. Chest pain we can get, that can be either a pleuritic or positional type. Anxiety, hemoptysis, cough, and some prodromes like leg swelling and pain sort of things we'll get. What are the signs? Signs will be tachypnea, tachycardia, low-grade fever can be there. There will be signs of right-sided heart failure, jugular venous distension, tricuspid agitation, accentuated P2. We can get leg edema, arrhythmia, and tenderness over the peripheries. So coming to the risk factors, we have there will be history of prior DVT or pulmonary embolism. Patient can be in congestive heart failure previously. There can be sign of malignancy, obesity, smoking. There will be history of estrogen or OCP intake, long HRT. Pregnancy is another cause, lower limb injury. Surgery of more than 30 minutes of duration. Age more than 40. There can be history of SLE, APS, or some recurrent loss of pregnancy. High homocysteine level, so catheters somewhere, especially the central venous catheters, and can be a sign of sepsis also. So what are the differential diagnoses that comes in our mind while diagnosing a case of pulmonary embolism or suspecting a case of pulmonary embolism? We can think of, it can overlap with the signs and symptoms of acute coronary syndrome. It can mimic with AECOP, acute exacerbation of COPD, aortic dissection, pneumothorax, or some musculoskeletal pain can also present like that. So we have to rule out step by step. Coming to the diagnostic tools, very well known, Wells criteria and imaging diagnostic tools and some imaging diagnostic modalities. So very common, the Wells criteria, where we have different scores for different symptoms. For DBT, we have 3 alternative diagnosis, less likely 3, heart rate more than 100, 1.5. Previously DVT 1.5, hemoptysis, and the cancer treated within 6 months will carry a score of 1. So less than 0 and less than 1 is low risk, 1 to 3 is moderate, more than 4 is the severe. Other the tools we are utilizing in our day-to-day practice is plasma D-dimer level. So in suspected embolism cases, and if there is no coexisting acute systemic illness, the upper limit we can, the more than 500 nanogram per ml is most sort of confirmatory. And the age, in cases of patient with more than 50 years of age, the value should be more than 10 multiplied by age. It works as a diagnostic tool for the case of acute pulmonary embolism. And very common in ECG, we can get sinus tachycardia or RV stent pattern, new onset RBBV, or we can get T-wave inversion in V1 to V4. The commonest pattern S1, Q3, T3 is very common. Coming to diagnostic modalities, with imaging diagnostic modality, we have chest radiography, near normal chest X-ray in severe respiratory distress is highly suggestive of pulmonary embolism. Western mark sign, the focal allogemia and Hubton hum, the waist shape density of the diaphragm are the other things to confirm the things. Lung ultrasound can be helpful. showing some subpleural parenchymal consolidation. CT pulmonary angiography, especially the contrast-enhanced CT pulmonary angiography, is a gold standard for diagnosing this pulmonary embolism. And we can utilize echocardiography. We can see the McConnell sign, the RV free wall hypokinesia, along with dilatation of RB, severe TR. Sometimes we can get clot floating into RA and RV also. The venous ultrasound, venous Doppler ultrasound, we can get the signs of DVT or loss of compressibility. In this way, we often miss the upper limb clots because there is very scant site for doing this compressibility test, because the bone is overlying this SBC. So we can't diagnose the case very frequently with the help of Doppler in cases of upper limb clots. So, but this is quite helpful in lower limb DVT. In the patient which are having the contraindication with contrast, where we can't utilize that, we can utilize this ventilation perfusion mismatch test. Coming to the risk stratification, we can do the clinical evaluation, we can assess the RV size and function, we can get the reports of cardiac biomarkers. So there is one scoring system is there, that PACE scoring system. And on the basis of all these things, we can diagnose this case in cases of, as per the different guidelines like ESC 2019, AHA 2011, on the basis of hemodynamic scale, PACE scale. So we can categorize them as a massive, submassive, or low risk cases, and we can decide their treatment modality on the basis of their risk severity. So here is the PACE criteria: less than 65, in between 65 to 85, 85 to 120, and the severest will be the more than 125, carrying a score of more than 125 will be in the severest category. So coming to treatment modality, the anticoagulation is the main workhorse, and unfractionated heparin, the things to be utilized, the first thing to be utilized. So we can start with IV bolus of 80 unit per kg, followed by continuous infusion of 18 unit per kg per hour. We can titrate with one APTT score, and the target APTT should be kept between 1.5 to 2.5. We can utilize low molecular weight heparin also, especially in cancer subset of patient, and we can assess their severity, their safety with the anti-TNA level assessment, but very hard to get this thing. Commonest thing we are utilizing in our day-to-day practice, warfarin. Target should be the same. Newer oral anticoagulants also can be utilized, like dabigatran, rivaroxaban, apixaban. So what should be the duration of anticoagulation? Earlier it was the different guidelines were there for provoked and unprovoked embolism, but that things has been withdrawn after ESC 2019 guidelines. And the only in patient with estimated recurrence rate of less than 3% per year should we receive the time-limited anticoagulation therapy. Otherwise, in other cases, we can continue lifelong, seeing the severity of the cases. So what are the advanced therapy for acute PT? We can do the full dose systemic thrombolysis. We can consider half dose systemic thrombolysis, seeing the tolerance and the age subset of the patient, and other risk factors we have to keep in our mind. Other option is low dose catheter directed therapy. So very good result. FDA is approved with LT pledge for high risk cases in a dose of 100 milligram over 2 hours. So we are getting good results with catheter directed thrombolysis also, because it is minimizing the risk of systemic hemorrhage. In 1 to 3% of cases, we are getting acute major hemorrhagic bleeds in brain and GI. So in those cases, we can consider this catheter-directed thrombolysis. In Seattle-2 trial, they have utilized 24 milligram of tenecteplase on 150 patient and has shown the improvement in RV function. Hence, FDA has approved this treatment since 2014. So other option is mechanical catheter embolectomy, and they have developed the flow Trevier and indigo thrombectomy system. They have utilized that nitinol based some thrombus occluder. With the help of that, we can retrieve that clot out of the system. So hardly we are utilizing here. There is big data in US studies also. So the best option we have is surgical embolectomy in cases of massive pulmonary embolism, in refractory embolism also. This is safe and the most effective mode of treatment. IVC filter, they consider in cases of VT with contraindication to anticoagulation or with recurrent pulmonary thromboembolism, and appears to reduce the short-term risk of subsequent pulmonary embolism. They increases the long-term risk of DVT and has no impact on overall mortality also. So coming to DVT intervention, they have one Canvan study is there. They have compared with catheter-directed thrombolysis with low molecular heparin, and there is not much difference between the outcomes, long-term outcomes with these two modalities. Coming to other subset, the cancer patient, we are utilizing low molecular weight heparin very commonly, and they are giving good results. They have done several trials, and this one important is SELECT-D trial and Hokusai VTE trial, and they have compared low molecular weight heparin with knee or oral anticoagulants, but they have found that LMWH is overall good outcome. Coming to prophylaxis part, and we have one score for that, and considering the different subsets, we have advised the different regimens for all these subsets. So patient with prolonged hospitalization, we can utilize with unfractionated heparin, enoxaparin or dalteparin. Fondaparin also we can consider. In patient going prolonged surgery, general surgery, we can utilize all these things with different dosage. And in major orthopedic surgery, especially carrying more than 30 minutes, so we have enoxaparin, in single dose we can give it. Fondaparinox, newer oral anticoagulants, they are also giving good results. Still some big trials are still awaited. So this is the end to the topic. Thank you for your patient listening.
Thank you, Dr. Nitish, for a wonderful presentation. We can take a few questions from the audience. Okay, there is no question from audience. Many of the patients, sometimes they have paradoxical embolism also, along with the pulmonary embolism. That can be severe in the form. In these patients, are those who have contraindication for thrombolysis at that time. One of the patient of mine have massive pulmonary embolism, along with cerebellar infarct, along with hemorrhagic conversion also. So what are the options in such type of patients?
So definitely it's a gray area. There is no clear-cut guidelines. We have to wait for risk factor and the benefits also. So oral anticoagulation or heparin infusion is the good thing, I think.
Can we have options of mechanical thrombectomy devices in this type of patients?
Yes, we can do it, but we need that type of backup and the things available.
Okay. Right. So I don't have I don't have the mechanical thrombolectomy devices at that time. I did a thrombectomy with these catheters, a pictal catheter. Yeah. And the patient, I could survive the patient.
So to some extent, it can be helpful also by doing this thrombosuction with our conventional PTCA, hardwares.
Okay.
We can get some benefit.
Thank you.
And prolonged anticoagulation is the key set.
Any more questions?
Go ahead.
So we can invite our next speaker, that is Dr. Sudhir Kumar. Dr. Sudhir Kumar, sir. Is he present here? Yes, sir. Okay, thank you. He will speak on obstructive sleep apnea, when to suspect and how to manage. He needs no introduction. He's our...
Good morning, everybody. Today my topic is on obstructive sleep apnea. And before I begin, I just want to say why this topic is important for us as a cardiologist. And here we see a very landmark study which shows that untreated severe obstructive sleep apnea over a period of 10 years leads to 3 times more risk of higher fatal cardiovascular consequences. And there are several cardiovascular consequences of OSA, of which hypertension is the commonest, and in which those patients who are resistant hypertension on triple drug therapy, they have got 80% association of OSA or prevalence. And in patients with stroke and atrial fibrillation, it is almost more than 50%. whereas they have got higher risk in men for CHF and CAD. So with this opening here, now we come to when to suspect. As a clinician, we must suspect when these associated conditions are present to us in our clinic, and in this, especially the cardiovascular and then some of the chronic lung diseases, gastroesophageal reflux, fibromyalgia, these have got higher prevalences of OSA, and in these type of patients, we should suspect OSA. Also, there are conditions which would increase the risk of OSA, like acromegaly or myxedema, whereas there are conditions because of OSA, the risk of developing a particular clinical condition or aggravation of the clinical condition is there. So it's vice versa, and we must suspect OSA in these group of patients. Now, before we go ahead, we all know what is apnea, that is temporary cessation of breathing, but for obstruction, it is with continued respiratory effect, and for central sleep apnea, there is no respiratory muscle effort, which is more common in CHF and stroke. What we need to understand is what is hypopnea, because it has been found that hypopnea also have got similar consequences, and in this there is decrease in the airflow, and it must be associated either with EEG evidence of arousal or sleep fragmentation, and or decrease in SpO2 by at least 4%. So, and we will understand why these terms are important when we come ahead. Now, what are the cardinal symptoms of obstructive sleep apnea? The first 5 symptoms which are mentioned here, they are the main cardinal symptoms. Almost 90% of patients will oppose to you with these symptoms, or at least their family member will tell you. And then you have to ask for other symptoms, like whether they have got vivid dreams, nocturia, change in mood and cognitive deficits and lack of concentration, and some sort of impotency in male. Once we have got these symptoms, then we have to examine the patient based on three or 4 parameters. One is obesity, we check for BMI. Then we see for neck circumference. If the neck circumference is more than 17 inches male and more than 16 inches female. And we also check for narrow or crowded oropharynx. As well as we try to find for any craniofacial abnormality like retrognathia, which can predispose a patient to OSA. So regarding narrow or crowded oropharynx, we can have these 2 simple examinations, Friedman tongue position, where you can visualize entire uvula, tonsillar, pillars, and soft palate. But in stage 3 and stage 4, you can't visualize in stage 4, you can't visualize any of these. So in stage 3 and 4, you can be definite that these patients are likely to have moderate or severe OSA. Same is with this examination. Here you see that we don't have to protrude the tongue, simply ask to open the mouth. And here we see that we have to ask the patient to protrude the tongue. And then same thing we visualize. And in class 3 and class 4, these are the patients who are at higher risk of OSA. Then we have got certain scoring system to assess whether there is more likelihood of patient having OSA. And one of them very common is Ipsworth Sleepiness Scale. And here we have got set of 8 questions. We give marking that if they would never dose, that is 0, or there is high chances of dosing, that is 3. So the highest score is 24. So if we have at least 10, then we say that, yes, this patient is likely, there is mild to moderate, at least moderate risk of having obstructive sleep apnea. Another one which has taken into account other things apart from sleepiness is stop bang questionnaire. And in this, stop begins with snoring, tiredness, observed apnea, choking or gasping, and higher blood pressure. So this is stop, and bang is body mass index, age older than 50 years, neck size more than 16 or 17 inches, and then gender. So we, based on this, we say yes or no. And if the scoring is 3 to 4, then there is the intermediate risk. If it is higher, then there is higher risk of OSA. Then we have got sleep apnea clinical score also. In this, we just have 3 parameters. One is neck circumference, Another is whether the patient is hypertensive or not, and that is why it is important, because in cardiology the commonest symptoms that the patient comes with is hypertension. So another is whether the patient has got hypertension or not, and third point is whether they have got historical features of sleep related disorder in the form of loud snoring and or witnessed apneas or choking sensation. So if we can see here that higher the neck circumference, the more the chances. Lower the neck circumference, then we have to see whether those points are there or not. We can visualize here that even if the neck circumference is less than 16, and if the patient has got both hypertensive and other historical features, then still they can have obstructive sleep apnea. And this is a very simple score. One can do it in the routine way in the clinic also. Now, once we have decided that these patients are at a higher risk of having OSA clinically, then we go for diagnostic testing. Now, the gold standard is in-house polysomnography, in which we have got in-house means that we have got at least 7 channels: EEG, EOG, EMG, ECG, respiratory effort, airflow, oxygen saturation, and it should be video monitored along with a sleep professional person who is present there during the test. So this is the gold standard, but nowadays out of center testing is also being done, which is called home ambulatory study, and in that the most common is level 3, where we have got, because level 7 is usually not practical, so it is level 3 which is being done with minimum 4 channels, which includes ECG, heart rate, oxygen saturation, at least 2 channels which measures respiratory movement as well as airflow. Now, when we should, what is the indication for in-house lab? Now, if the patient has got low clinical probability, then you straightway go for in-house PSG, because the ambulatory ones are less sensitive and they can miss mild obstructive sleep apnea at least. So you straightway go for in-house. But if the patient has got higher probability, clinical probability, then we ask 2 questions where there are comorbid medical disorders and whether they have got comorbid sleep disorders. Now in sleep disorders, comorbid sleep disorders means they may have, parasomnia, insomnia and choking sensations, witness apneas and daytime sleepiness. If all these things are there, then it is better to go for in-lab PSG test. But if they have got moderate to high probability and these 2 signs and symptoms are not present, then we may still go for out of lab sleep testing. Now, what is the diagnostic criteria on polysomnography or home sleep apnea device? That is, we measure the total of apnea and hypopnea per hour of sleep. Now, sleep can only be assessed by EEG monitoring, and therefore a EEG is must to understand the per hour time of sleep. So once AHI is at least 15 or more, then it is a clear-cut case of obstructive sleep apnea and we go for treatment. Now if it lies between 5 to 14, then we should have at least 1 sleep associated conditions like hypertension or loud snoring, habitual snoring or witnessed apneas, choking and gasping. And if it is less than 5, then it is normal. Now, these are the sleep associated conditions because this is to be considered when patient has got AHI between 5 to 15. So this is a typical polysomnograph where we can see the paradoxical effort of chest and abdomen in the downwards. And okay, so now where is the obstruction site? That is very important when we have to decide whether we need to go for surgical management or not. This is a typical MRI where we can see that Where's the pointer? Okay. So we have got three major places of obstruction. One is so either it is in the nasal area like DNS, and then or it is a retropalatal or it is retroglossal. Now why this is important? Because this is important when we think of considering surgical treatment. You can see a normal patient where there is normal retropalatal and retroglossal area, whereas in an apneic patient they will have a narrowed space. It is very important to assess for tongue size because it is one of the most important factor of obstructive sleep apnea. You can see here both patients are obese. Both are having the same BMI. But here you can see the tongue volume and the fat composition is more in patients of obstructive sleep apnea, apneic patient. So once we have decided what is the management, the commonest management is positive airway pressure therapy, which can be done by either fixed CPAP, auto CPAP or bilevel PAP. And the indications are as here. The CPAP splits the airway, and you can see with every increase in size, the lateral diameter of the airway increases, where the AP diameter does not change much. Now, when to select for auto CPAP, some of the patients are intolerant to fixed CPAP, and some of the patients on PSG shows variable pressure requirement in positional sleep apnea or REM related sleep apnea. Bilevel is considered when the patient is not tolerant to CPAP, or when the patient has got hypercarbia, or the patient is having coexistent condition of COPD or obesity hypoventilation syndrome.
Thank you, Dr. Sudhir sir, for
thank
such an enlightening talk on obstructive sleep apnea. If there is not any question, then we will invite the next speaker. Is there any question from the audience side? Okay.
No, it's okay.
Okay.
Okay. No. So, okay. So there are alternatives to CPAP therapy, what is called intraoral devices. And these are the three common devices in which the mandibular advancing devices are actually the most practiced. And it has to be done by maxillofacial surgeons, and it is a multidisciplinary approach. You can see one of the models, and this one is a device inside, how it is, the mandible is advanced. And then there are various surgical treatments, which again will depend on the site of obstruction, whether the patient is not tolerating or accepting CPAP, and it all depends on how do we select the site. It is on the MRI as well as on the drug-induced sleep endoscopy, where we select, and usually surgeries are in two phases. The first phase includes surgery for nasal, palatal and lingual level, and in second phase one can go for maxillomandibular advancement. There are implants also, like hypoglossal nerve stimulator implantation, which stimulates genioglossus muscle, which is a commonest airway dilator muscle, and that can also be done. And there are other surgeries in which this laser assisted palatoplasty is not actually recommended because of very poor results. And UPP, which is most commonly done, is actually never recommended as a standalone treatment because of the higher rate of relapse. Radiofrequency ablation of base of the tongue is now recommended in some of the patients. And there can be other implants like soft palatal implant which stiffen the soft palate, and then there are different type of surgeries which can be done. And finally, in medication, one is combination of atomoxetine and oxybutynin, which enhances genioglossus muscle responsiveness and it reduces AHI and sleepiness. Modafinil is reserved for only those patients who have got residual sleepiness in patients who are on CPAP therapy. And then there would be certain drugs which are now being used as a reduction of obesity. So these drugs may be tried, in which liraglutide has been found to have some decrease in AHI. And obviously there would be certain other precautions like weight reduction, positional changes during sleep, avoidance of hypnotics, sleep medicines, alcohol in the night. So with this, I would like to conclude that OSA is a common disorder, which leads to a lot of cardiovascular complications, and that should be suspected and treated appropriately so that the fatality rate of cardiovascular disorders are reversed. Thank you very much.
Now I invite our next speaker, Dr. J.P. Khan from Darbhanga, for his talk on primary pulmonary hypertension update.
Good morning. Thank you, CSI Bihar chapter, for giving me opportunity for talk on this topic. My today topic of discussion is update on management of pulmonary arterial hypertension. Now, pulmonary circulation is low pressure and high flow circulation, and pulmonary hypertension is defined as a mean pulmonary artery pressure of more than 20 mm of mercury as assessed by right heart catheterization. Then there is slight change in this guideline now. Previously, it used to be 25 mm of mercury mean pulmonary arterial pressure, but in 6th Symposium on Pulmonary Hypertension, World Symposium on Pulmonary Hypertension, it decreased to 20 mm of mercury recently. And pulmonary hypertension is a progressive disease, and ultimately it leads to right heart failure and death. And we do have a lot of new information, understanding of pathogenesis in the pulmonary arterial hypertension, and we have a lot of targeted approach. So now, most of the patient can have prolonged life due to this targeted approach. Now coming on classification, pulmonary hypertension is classified on 6 groups. It was an old Dana Point classification given in 2008. It has been classified in 5 groups. Group 1 is pulmonary arterial hypertension. Group 2 is pulmonary arterial hypertension associated with left heart disease. Group 3 is pulmonary hypertension associated with lung disease. 4 is pulmonary hypertension associated with pulmonary artery obstruction or thromboembolic pulmonary hypertension. And 5th one is pulmonary hypertension with multifactorial mechanism. Now, the group 2 and group 3 is more common, and group 1 is very rare, although rare, but most of the targeted approach has been applied in this group only, and as today's discussion will be concentrated on this group 1 hypertension only. So now coming to group 1 hypertension, that is pulmonary arterial hypertension. It is defined as mean pulmonary arterial pressure of more than 20 mm of mercury, pulmonary arterial wedge pressure of less than 50 mm of mercury, and pulmonary vascular resistance of more than 2 Woods unit, as assessed by right heart catheterization. There is slight change I already discussed. Previously it was 25, now it decreased to 20. And second change has been pulmonary vascular resistance. Previously it was more than 3, now it's decreased to 2 Woods unit. And it has been classified into 6 classes, idiopathic, into responder, non-responder, heritable, associated with drugs and toxin, some connective tissue disorders, HIV, portal hypertension, congenital heart disease, schistosomiasis, and other is PH associated with PVOD or persistent primary hypertension of newborns. So this is a class 1, also known as pulmonary arterial hypertension. Now this is the diagnostic modalities. We have a number of diagnoses. Echocardiogram is the backbone of this diagnosis, and we can diagnose pulmonary hypertension and classify it based on echocardiography. For differentiating types, we have ventilator provision scan, computer CT angiography, CT pulmonary angiography, and of course cardiovascular exercise testing. Now, right heart catheterization is the gold standard for diagnosis and classifying pulmonary arterial hypertension. And in this, Swan gauge, most probably Swan gauge catheter advanced into RA to RV to pulmonary artery, and catheter is wedged, and we have a lot of parameters can be measured or calculated based on this finding. We can calculate right arterial pressure, pulmonary arterial pressure, mean systolic and diastolic, cardiac output, saturations, and after this we can calculate pulmonary vascular resistance, cardiac index, stroke volume, and a lot of parameters can be calculated. So this should be done in almost all the patients having pulmonary arterial hypertension, suspected pulmonary hypertension. And in right heart catheterization we also do vasoreactivity testing, because it has been shown that in patient is vasoreactive, then there is a high chances of responding to calcium channel blockers. High doses of calcium channel blockers are should be given, but only 5 to 10% of patients with PH have actually a vasoreactive testing. And the most commonly used agents for this testing is inhaled nitric oxide, inhaled iloprost, or previously it was adenosine also, but nowadays adenosine, IV adenosine is not recommended, and also IV ibuprostanol is less commonly used. So most common agent in today's era is inhaled nitric oxide or inhaled iloprost. And response is defined as reduction in mean PAP by more than 10 mm of mercury to reach an absolute value of less than 40 mm of mercury with increased or unchanged cardiac output. So this is about vasoreactivity testing. Now after this diagnosis, we have to assess the risk of the patient, and in recent guideline, that is 2022 ESC European guidelines, it has been different parameters are given, like signs of right heart failure, progression of symptoms, presence or absence of syncope, WHO functional class, 6-minute walking distance, cardiopulmonary exercise testing, biomarkers like NT-PNP and BNP, echocardiography, CMRI, and hemodynamics. Based on this, this data, we can assess the risk in individual patient. It can be low risk with less than 5% mortality, intermediate risk with 5 to 20% mortality, and high risk with more than 20% mortality. So this is the 3-strata risk model of European guidelines. And other is the 4-strata model. We can, in this 4-strata model, 3 parameters are assessed. That is WHO functional class, 6-minute walking distance, and BNP or pro-BNP level. Each this variable have given certain point, and risk is calculated by dividing the sum of all the 3 grades by the number of variables and rounding to the next integer. So this 3-strata model is used for initial risk assessment and initiating the therapy, and this 4-strata model is employed for follow-up the patient on treatment. So to just summarize this thing, first we have to suspicious of pulmonary hypertension by different symptoms and screening process. Then pulmonary hypertension is confirmed. Then we have to identify which class of pulmonary hypertension is this, class 1, class 2, class 3. And ultimately, if patient has class 1, then we have to assess the risk and do this right heart catheterization exercise testing to assess the risk and for starting treatment. Now, what are the goals of treatment? As we all know, pulmonary arterial hypertension is not curable. We can only delay the mortality of the patient. So the goals of treatment is improve the cardiopulmonary hemodynamics, alleviate symptoms, improve the quality of life, delay time of clinical worsening, or reduce morbidity and mortality. So these are the goals of treatment. And we should start with first is general measures. This is a class 1 recommendation. First one is exercise has been highly emphasized in the recent guidelines. And class 1 recommendation is supervised exercise training is recommended in all patients with PH. Similarly, class 1 recommendation is psychological support, immunization with COVID, influenza, and pneumococci. And diuretic treatment is recommended in patients with PH with signs of RD failure and fluid retention. If oxygen saturation is less than 60 mm of mercury, then oxygen therapy is recommended. And iron deficiency anemia and iron levels should be corrected. Previously, anticoagulation are given in the most of the patients with PH, but it is not generally recommended. But if there is evidence of thrombus or any thrombotic condition, that it should be given, the class 2B recommendation. And if not required, then ACE inhibitor, ARB, ARNI, and SH2 inhibitors, beta blockers, ivabradine are not recommended. It should be not used in patients having pulmonary arterial hypertension if not required. So now coming to targeted approach, there are 3 pathways: endothelin pathways, nitric oxide pathways, and prostacyclin pathways. The main pathways of vasoconstriction and vascular proliferation. And we have agents against all these criteria. This is in endothelin receptor antagonist, bosentan, irbesartan, macitentan, the newer drug, PDE5, sildenafil, tadalafil. Soluble glomerular cyclic stimulator is riociguat, and in prostacyclin, different intravenous oral. And the newer one is Lexipec, that is prostacyclin receptor agonist. So we can consider only newer molecules. One is macitentan. This is analog of, this is developed by modifying the structure of bosentan, because we all know bosentan has a lot of complications like anemia and toxicity. So it has been developed macitentan, and it is characterized by sustained receptor binding and enhanced tissue penetration. It has prolonged half-life and less adversity compared to macitentan. And the landmark trial of this macitentan is Seraphin trial, published in 2013. And it has been shown to decrease all the primary endpoint and secondary endpoints compared to placebo, both 3 mg and 10 mg, and 10 mg is more effective compared to 3 milligrams. So macitentan, this is the Seraphine trial of macitentan. Second one is riociguat. This is a soluble guanylate cyclase stimulator. Guanylate cyclase converts GMP, and GMP causes vasodilatation. So it stimulates the cyclic, riociguat stimulates the cyclic soluble guanylate cyclase. It has a dual mode of action. It increases sensitivity of SGC to endogenous nitric oxide and also directly stimulate the receptor to mimic the action of NO. And it is only approved medical treatment for group 1. Apart from group 1, it also approved in group 4 pulmonary arterial hypertension. This is the landmark study of this riociguat published in 2030, and it shown to be beneficial compared to placebo in almost all the parameters, primary endpoint and secondary endpoints. So next one is Lexipag. It is a prostacyclin receptor agonist, orally available. It stimulates the prostacyclin receptor. And the Griffon trial is the landmark trial of this pulmonary arterial hypertension, and it shown benefit compared to placebo. So now this is the main trials of pulmonary arterial hypertension monotherapy and some dual therapy. You can see that initial trials have in blue. Initial trials have shorter duration because of increased mortality, and now trials in red one is having long durations trial and having increased thing. So now coming to combination therapy, we can see monotherapy could improve mortality, exercise capacity, functional class, and hemodynamic status compared to placebo conventional therapy. But it is frequently inadequate because 1 year survival is 58%, after monotherapy 2 years is 41%, and 3 years is only 24%. So this is not a very good alternative. So we are coming to combination therapy because we have several pathways involving pathophysiology, and there is potential of synergistic effect. So combination therapy is recommended now, and now we have sequential combination to upfront combination. And upfront combination we start 2 or 3 drugs simultaneously. So there is evolving paradigm of this upfront combination. So this is the ambition clinical trial of landmark trials of this combination therapy, tadalafil and irbesartan, and showing all the benefits. And why not to go for triple drug therapy? Triple drug therapy, when one trial, this is Triton trial, and it failed to show superiority compared to dual drug therapy. So triple drug therapy is not recommended currently. This is the randomized control trials of monotherapy versus combination therapy, and there is no proven effect on monotherapy compared to mortality compared to monotherapy. So now coming to doses of different drugs used, calcium channel blockers are used in high doses compared to used in hypertension. Amlodipine in 30 mg can be used. Similarly, irbesartan 10 mg OD is the target dose. Sildenafil 20 mg twice a day, tadalafil 40 mg OD. So this is the dosing of patients having pulmonary arterial hypertension. Now coming to recent guideline of treatment approach, we have if patient having this pulmonary arterial hypertension, the first one is general measures, as I have already discussed, and then after general measure, if patient is vasoreactive, then go for high dose calcium channel blockers. Then we classify into 2 groups, patient without coronary pulmonary comorbidities or patient with coronary pulmonary comorbidities. As patient without comorbidities, if patient is having low risk, then start with dual therapy, initial endothelin receptor antagonist or phosphodiesterase inhibitor. And if patient is high risk, then start with these 2 plus add IV or SC prostacyclin analogs. And regular follow-up is given. If patient remains in low group, then continue initial therapy. If patient is in intermediate low, then add prostacyclin receptor analogs or switch from prostacyclin phosphodiesterase inhibitor to riociguat. And patient is remain in high dose, then go for lung transplantation or add another drug. So this is some emerging therapies of PAH. These are disease-modifying therapies like imatinib, certain pathway inhibitor like rotatristat, sirolimus, sotatercept. These all molecules are in different phases of trials and currently not approved. Similarly, pulmonary arterial denervation is also in different phases of trial, and we might see some of these molecules in the guidelines in near future. So this is the history of one side. Now, for conclusion, there is significant advances have occurred in the field of PAH, and risk stratification, combination therapy, and escalation of therapy is the current management of PAH. Despite multiple options available, outcomes remain suboptimal. And pulmonary vasodilator therapy is the main mechanism of current medical therapy. Pulmonary vascular remodeling plays a major role in disease progression, and many therapies are currently under development targeting vascular wall remodeling, which may become the next cornerstone of therapy. Thank you.
Thank you, Dr. J.P. Kern, for your illustrative talk over PPH. Now we can invite a few questions concerning from house.
What is the longest surviving patient on medical therapy?
Sir, in older data, the mean survival is around...
Not only, I'm talking about your practice, current practice.
Sir, I have seen patients up to 5 or 7 years of follow-up in pulmonary hypertension in my practice. We most commonly use sildenafil or tadalafil or bosentan, not using these newer drugs till now, but a good survival compared to older.
In fact, with dual therapy, just this old sildenafil and newer either Pulmonext or Mezitantan, people are surviving, my patients are surviving for quite some time. And 2 of them were just dying patients. From my Paras days, the lady who is a teacher in Jharkhand, she came dying, like she was not having money to be in CCU. I requested the management to give some concession and all. And the second patient is mother of a technician working with us, who was again referred by Dr. Hai to me. And both the patients are pioneer, like they are with me for 10 years, almost like 10 years now. And the one whose teacher, her pulmonary pressure has come down to, seen to be believed, 30, 35 now. She is absolutely fine, no symptom at all. So we don't know which patient is going to respond which way. We are not very sure about it. So pH was 120, something like, you are dying, like, you cannot believe. And all the institutions of the country they have visited. From CMC, SGPGI, Lucknow and all. It's simple as you prescribe. There's nothing great about it. See, Mezitantan, as he was telling, is a very good drug. It's a very good drug. And today, Tadalafil is available. So combine Tadalafil with Mezitantan. And
recent guidelines says combination therapy. If patient is affordable, then go for combination therapy. Tadalafil plus Mezitantan. One of the phosphodiesterase or one of the combined with one of the 3 receptor antagonists. If patient is tolerated, then continue with this 2 molecule. And if patient is reaching to higher stage, then we can combine intravenous prostaglandins.
Sorry, we are going to conclude this question.
Absolutely.
Thank you.
Can I make just one line comment?
Okay. Sure, sir.
That anecdotal cases, like Dr. Sinha is saying, I think we must have seen in the practice. We don't know what is the mechanism, but majority cases do not do well on overall these 2 dual therapy. That's why new drugs have come up very well. And oral prostaglandin, which we could never imagine, is available now in India. But they are expensive. That is the limitation of the therapy.
Thank you. So we should conclude.
Thank you so much, sir. So please stay back. May I now request all the chairperson to felicitate our speakers. For that, I would request our speaker, Dr. Nitish Kumar Ranjan. Sir, please come up on stage. Dr. Sudhir Kumar, sir. Dr. J.P. Kern. I request all the chairperson to present this shawl to all the speakers. And our next session is Heart Failure Symposium. For that, our chairpersons are Dr. U.S. Samal, Dr. Vijay Achari, Dr. Ajay Kumar Sinha, NMCH, Dr. Shaima, Dr. M.K. Chaudhary, Dr. Purushottam Kumar, Dr. Rajiv Ranjan Gopalganj, Dr. M.F. Faizi, Dr. M.F. Faizi. I would request all the chairperson to join us. Thank you so much. Thank you so much, doctors. Thank you so much, everyone. And I would request Dr. Shreyas as well to join us in this session. Dr. J.P. Kern, Dr. Bhaskar Bhushan, after COVID-19, challenges related to heart diseases have increased. And to discuss this topic in more details, we have our eminent speakers today. Today we have Dr. Ravi Vishnu sir. I would request you to kindly come up on stage and share your insight with us. And we are running out of time, so it's a request.
Welcome you all in this session, a very important session. Good morning to everybody. We know that the prevalence of this deadly disease is increasing because of many reasons, heart failure. But the spectrum of the heart failure have also changed. For the last few years, from heart failure to the reduced ejection fraction to mid-range ejection fraction to the preserved ejection fraction. So there are a lot of types of heart failure have come up, and with a lot of the changes in the landscapes. So 10 years before, the treatment was different, but after many of the good studies, in 2023, newer guidelines are coming, and I'm sure that in next year, some new will emerge. So the drugs which was used previously, the digoxin, having the narrow therapeutic range, has gone down. Coming at the highest position, the SGLT2 inhibitor. So to solve all those things, I invite the learned speaker, the HOD of the IGMS Cardiology, Dr. Ravi Vishnu. Over to Ravi Vishnu. Thank you.
Good afternoon, respected chairpersons, faculties, delegates. First of all, I would thank the scientific committee of Cardicon 2023 for giving me this talk on heart failure with preserved ejection fraction. As you all know, there is a universal definition of heart failure, which is basically the complex clinical syndrome with symptom and size caused by the structural and functional impairment or any abnormality in the ejection of the blood. And it is associated, correlated with at least one of the following. Either there may be the elevated natriuretic peptide levels, or there must be the objective evidence of pulmonary or systemic congestion. So based upon the EF, there is a classified, my topic is heart failure with preserved ejection fraction. It has the equal to or more than 50% of the ejection fraction should be there, with the sign and symptoms and with all the objectives of either the elevated NP, elevated natriuretic peptide, or the evidence of this congestion is there. So this syndrome is oftenly under-recognized, and it occurs mostly in the older and the female population, and the atrial fibrillation, CKD, and the non-CV comorbidity conditions are more common. And if you compare with the men, the women have the more significant symptoms of dyspnea and worse health status, that is, they are more symptomatic as compared to the male counterpart. If you go through the epidemiology of the heart failure, the incidence is increasing over the time, and prevalence is also increasing over the time. And the females are predominant over the males. And if you see the clinical outcomes, the 5-year mortality, the 30-day all-cause readmission rate, and the rate of heart failure hospitalization and the CV deaths are more common as compared to the heart failure with reduced ejection fraction. Now coming to the pathophysiology, When there is an insult, either in the form of primary myocardial diseases or when they are associated with the comorbid condition, then there is the systemic macrovascular endothelial dysfunction, and which leads to the myocardial injury, and this leads to the LV concentric remodeling in the form of hypertrophy, fibrosis, and which leads to the increased LV pressure, which ultimately leads to the increased LV pressure, atrial fibrillation, resting pulmonary hypertension, and then leads to the RV dysfunction, and then to the systemic congestion. And initially, the symptoms usually occurs at the exercise, and as the pressure goes in the LA pressure, there is a decreased LA compliance. Then it may cause the intermittent AFM, later on leading to the permanent AF, and we get all the symptoms at the rest, and ultimately the right-sided and the pulmonary vasculature is involved, leading to the RV dysfunction and the increase in the tricuspid regurgitation, and leading to the right heart failure and systemic congestion. This is in the nutshell the mechanism of hemodynamic changes in this group. There is intrinsic atrial and ventricular myocardial dysfunction. There is a hypervolemia. This is more common in the obesity groups. There is increased stress blood volume. There is increased ventricular interaction and pericardial restraint because there is an increase in the epicardial fat, and this leads to the mismatch between afterload and the preload. This is the spectrum of all the comorbid conditions in the heart failure with ejection fraction fraction, hypertension, obesity, chronic kidney disease, sleep apnea. Everyone has a role in this syndrome. Although the diagnosis is not easy, because the echo may not be demonstrate the obvious the structural and the functional cardiac abnormalities, and the natriuretic peptides may be normal, especially in the obesity. So there are some clinical scorings are available. The first clinical score is the S2F PF score, in which the S2 is for the obese patient when the BMI is more than 30, and second H is for the hypertension when the patient is taking the antihypertensive more equal to or more than 2 antihypertensive. They are given for obese the 2 points, and for hypertensive they are given the 1 point. F is for the atrial fibrillation where the score 3 is given, and the P is for the pulmonary hypertension, and E is for the elder age group more than 60 years, 1 point is given, and the F is for the filling pressure when the E by E dash ratio is more than 9 on the Doppler echocardiography, and more than 6 or equal to 6 is diagnostic of heart failure with ejection fraction. Second is the HFA PEF score, in which the P stands for the pre-test assessment. You diagnose the case, symptoms and signs, comorbid condition, and do the routine echocardiography. And after doing the echocardiography, the E is for you do the detailed echocardiography and measure the natriuretic peptide score. They are divided into functional group and the morphological group, and each points are given for each point. And if the diagnosis is not confirmed by these echo and natriuretic peptide, then you go for the functional testing in the form of diastolic stress test, or even do the invasive hemodynamic monitoring. Similarly, if there is a diagnosis is still uncertain, do the special imaging, CMR, CT, PET scan, even you do the biopsies and the genetic score. More than 5 is diagnostic of HEF score, which includes the 2 points, and the minor criteria are for the 1 point. Now coming to the management focuses on the 3 main groups. One is you risk stratify and manage the comorbid condition like hypertension, diabetes, CKD, atrial fibrillation. And the second is the non-pharmacological management in the form of exercise, weight reduction, and implantable pulmonary artery monitors. And the third one is symptom management and disease-modifying therapy. We should always, before diagnosing this syndrome, always be aware of these non-cardiac mimics like kidney disease, liver disease, chronic venous insufficiency, and also rule out the infiltratory cardiomyopathy, hypertrophic cardiomyopathy, pericardial disease, valvular disease, and high output states before diagnosing this case. Until now, the various clinical trials have been generally hospitalization. There were no randomized clinical trial till 2021. So it was empirically it was managed this condition. In 2022, the ACC has recommended this drug diuretics. This is a class 1 indication, and SGLT2, the 2A indicator for this group. And while the ARNI and MRA and the ARBs are the 2B. In 2021, the one trial empagliflozin in the heart failure with preserved ejection fraction, that is the patients, around 6,000 patients were taken and EF was more than 40%. They were given empagliflozin 10 mg OD versus the placebo group, and they have shown in the primary outcome in the form of composite of cardiovascular death or the hospitalization. These were quite significant, and also the hospitalization for the heart failure was reduced, but there was no significant reduction in the CV death. Similarly, the DELIVER trial was published in 2022 in NEJM, in which dapagliflozin was used in patients with this subgroup, and around 6,200 patients were taken, and dapagliflozin was compared 10 mg versus placebo, and also they saw the reduction in the primary outcome in the form of worsening heart failure or the cardiovascular death, and they were decreased in the worsening heart failure, but no reduction in the CV death. And this was the meta-analysis which shows between the DELIVER and the EMPEROR preserve, there was significant p-value significant in the heart failure hospitalization or the CV death, but no significant difference in the CV death. And this was shown in all across the reduction in primary endpoint, all across the LVEF ejection fraction. So in 2023, this year, the ESC has changed in the focus update has published that they have changed the 2021 ESC guideline that SGLT2 inhibitor either in the dapagliflozin or empagliflozin 10 mg per day is recommended for heart failure with preserved ejection factor to reduce the heart failure hospitalization or the CV death. This is the class 1A indication. And also the diuretics, when the patient is having the fluid retention, it is the class 1 indication, dapagliflozin class 1, and also the treatment for etiology, CV and non-CV comorbidities should be treated. It should be it come under the class 1 indication. So any patient you confirm the diagnosis, start the SGLT2 inhibitor. If the patient is having volume overload, then you treat with the diuretic, and also same time you treat the comorbid conditions. And depending upon the situation, you can add the MRA, ARNI or the ARB, although it is the 2B indications. Along with this condition, we have to treat the comorbid condition in the form of rate control should be there in the atrial fibrillation, hypertension should be controlled, CAD should be well managed, type 2 diabetes, CKD and sleep apnea and obesity should be managed. So if you see the SGLT2 inhibitor, it is recommended all across the stages and the types of the heart failure. And when we have to refer this patient to the advanced heart failure specialist, there is an acronym known as the INHALE. INHALE means I means for when there is a need for diagnosis. N is a non-responsive, H for hospitalized patient, A for acute or chronic end organ is there, L for low pressure, and E for evidence of heart failure mimics. So there is a recommendation of wireless wearable monitoring of PA pressure, because PA pressure increases 2 to 3 weeks before the symptom present. This is a class 2B indication, and one trial which is there is the GUIDE HF trial, in which the cardio-MEMS was used. Basically, it has 2 parts. Pre-COVID, it showed the better result, and post-COVID showed the equivocal result. So the ACC had recommended this wireless loop when the patient has experienced more than one hospitalization, when they have suffering from the cardiorenal syndrome, and when they have a comorbid condition, especially the obesity, when you cannot differentiate the heart failure symptom from the dyspnea. The future is that many more, around 25 to 30 trials are going on in the heart failure with preserved ejection fraction. And the one trial which published this year is the STEP trial. Semaglutide was used in the heart failure with preserved ejection fraction with obesity, and it showed that there is a quite reduction in the symptom as well as the weight reduction. Also the Paraglide HF trial, in which the ARNI was used compared with the valsartan, there was reduction in the neuropeptide levels. Similarly, the Monitor HF trial, in which the pulmonary arterial pressure monitoring was used, and it showed that it reduces the reduction of the hospitalization. Another trial which is going on, the Fine Heart HF trial, in which the finerenone trial is used, is going to used, and it is fully enrolled, and soon we will get their results. Now there are some medical devices with the preserved ejection fraction which are catchy. One is the atrial shunt. Since you know there is a there is high LA pressure is there, so we have to shunt is created between the LA and the RA. The LV is poor, so we need the LV expander, we need the MCS, and also there is the autonomic imbalance is there. We need the stimulation to stimulate the autonomic nervous system. This is a reduced lab HF trial design in which this atrial shunt was used, and they have showed the heart failure events reduction was there and quality of life was improved. So the approach to this syndrome is that we require this is basically the teamwork. We require the primary care clinician when they refer to the cardiology specialist and when they refer to the heart failure specialist and when the multidisciplinary specialist act, they have the same group. Now this is the last slide. This is the diagnose the heart failure congestion, diagnose it, treat the congestion, use the loop diuretics and add the SGLT2 inhibitor and add the ARNI MRA according to the treatment. So take home message is that approximately more than 50% of heart failure have preserved ejection fraction, and the outcomes in the heart failure with preserved ejection fraction are now at par with the reduced ejection fraction. So the accurate diagnosis and the prompt diagnosis is critical. SGLT2 inhibitors should be initiated in all the patients, and when the patient is having the fluid overload, and the diuretics should be given and the associated comorbid condition must be treated. The field of therapies is heating up with the more and more data is emerging soon. Thank you for patience hearing.
Thank you, Dr. Professor Ravi Vishnu, for your wonderful coverage of the big topic in a short period of 12 minutes of time. You have covered almost all the controversial area. You have given the idea that how to diagnose heart failure with preserved ejection fraction based on not only the echo and the BNP, but also on the risk scoring system, which you have given us. So thank you once again. And you have covered almost all the controversial area of the heart failure with preserved ejection fraction. So thank you very much for your wonderful coverage of this subject.
It's a humble request to all the speakers. We are running out. We are running late and we are running out of time. So kindly complete your topic in your allotted time. Thank you so much.
Thank you, the learned chairpersons, the audience. Thank you. Learned chairpersons and colleagues in the audience. I am extremely thankful to the organizing committee for allowing me to speak on this subject on which probably nobody would like to speak. I have selected this topic very purposefully because I feel this drug is being dumped and forgotten, especially by the newer generation of physicians and cardiologists who are coming. I still feel, I don't have anything against 4 pillars. We all use 4 pillars, the 4 drugs for class 2 patients. But there are a group of patients who are in class 3 who come to us initially in a class 3 stage or a class 4 stage with a blood pressure of 80 to 90 millimeter of mercury, and then if you start the 4 pillars, start one by one or simultaneously, they do not give you the good result. And that is where I want to emphasize the role of digoxin. So, this is the standard position of digoxin by different associations. I will not deal with this. Now coming to the heart failure with reduced ejection fraction, the main pathology is myocardial systolic dysfunction of this category at least. And when we started our career in early 80s, we had only 2 drugs. One, which used to increase the contractibility, and second, because of this decreased contractibility, there used to be pulmonary and systemic congestion and the diuretics. This persisted for almost 5-6 years, or for a pretty long time, till we realized that this myocardial systolic dysfunction leads to neurohumoral changes affecting the autonomic nervous system, the RAS system, and others. And then the newer drugs started coming, and they changed the scenario of the management of the heart failure. It's not moving. Yeah. So this is how the treatment of heart failure evolved. The first trial that came in our presence in 1987 is the Consensus, then the SOLVE trial, then the RAILS trial, then the major trials with beta blockers, the US Cardilogocsl study in 1996 and Copernicus in 2011, followed by the SWIFT trial, which has got a different paradigm, and then the paradigm heart failure trial, the game changer, and then of course the upper heart failure trial. Now if you see, the blue lines indicate the number of patients who were on digoxin. So till paradigm heart failure trial, all these trials, means the trials in which ACE inhibitors and beta blockers were used, digoxin was used in 50 to 70% of all these patients in these trials. Paradigm heart failure trial, only 30% of the patients were on digoxin, and almost 30% of the patients were in atrial fibrillation as well. I will come to this again. Now, I will not go on detail this. Now, these are the hemodynamic, electrophysiological, and neurohumoral effects of digoxin, and I want to emphasize that this is the only drug known till now which increases the contractibility, means dP by dt, and decreases the heart rate. All other inotropic agents, they do increase the contractibility, but they also produce tachycardia. Now, these are the RADIANCE and PROVE trials, which has clearly shown that if you take out digoxin in combination with diuretic and ACE inhibitors only, beta blockers were not there at that time, that the removal of digoxin leads to deterioration of the patients. And this is the same thing is shown over here, that the triple therapy was supposed to be the best till beta blockers came in picture. Then I must go in details about the DIS trial, and I think this is one very important trial, and which I want to emphasize in this also, that this trial was sponsored by NHLBI. It was not sponsored by any pharmaceutical industry. Only Glaxo had supplied the digoxin tablets and the placebo tablets. So, and these were the the patient profile. And if you see, this is what I want to emphasize. Sorry, it's going in. Yeah, about 70% of the patients. If you see the last one, about 70% of the patients were given at 0.25 milligram, whereas now the full tablet of digoxin every day, whereas nowadays we are using only a half tablet. Now, as you can see, the mortality was not reduced but not increased as well. So the mortality was neither reduced nor increased in this particular trial, and this is a long-term trial. This is a 4 years trial. And then in the worsening heart failure patient, it does reduce the worsening of the heart failure, and in the incidence of death or hospitalization due to worsening heart failure in the digoxin group, you can see that if you combine these two endpoints, they were, of course, when this trial was present, we didn't have beta blocker, we didn't have ARNI at that time. That point must be kept in mind. After that, another retrospective analysis of this trial was done, and it was found that when the serum digoxin was kept 0.5 to 0.9 milligram per ml in the trial, the group of patients who had a serum digoxin concentration of this much, because the therapeutic concentration is supposed to be 0.5 to 2, But this, when this concentration was kept in this particular group, if you can see, for all patients in the serum concentration group of this, the mortality is reduced, combined endpoint is reduced, and the hospital stay for worsening heart failure is reduced. I'll again come to this point. Then, of course, this the game changer trial, paradigm heart failure trial. I have told that atrial fibrillation was present in 36% of the patient, and digoxin was used in around 30% of the patient. And when the treatment chart was given, I mean this result chart was given, where the subgroup analysis was done, in this particular subgroup, they had one group of prior use of ACE inhibitors, yes or no. They had a prior use of aldosterone antagonist, yes or no, but there was no mention of digoxin. What happened to those 30% of the patients who were on digoxin, whether it was beneficial or deteriorating, we do not know. This is not available in the result. In fact, I asked this question to one of the ESC members when he was delivering a lecture on this recently, about a few months back, and then I was given a very diplomatic reply. Because the raw data are not available, you cannot know what really happened during that. And all these drugs are, trials are sponsored by pharmaceutical industry. They have got their own limitations. Now, coming to others. After 15, this is 2019, digoxin discontinuation outcomes in patients with heart failure with reduced ejection fraction. And this is taken from a large cohort of 48,000 optimized heart failure hospitalization patients. They were grouped in around 3,000 patients who were on digoxin, and they were again had a propensity score matching, and after that equal number of patients were taken with digoxin or without digoxin, means those who had a digoxin continued or digoxin discontinued. This is in 2019. And if you can see that digoxin discontinuation leads to increased heart failure readmission. And same thing about the mortality, there was not much of change, but if you see the 6-month mortality, the early mortality was reduced in this particular group of patients. Then there's I must present those which are against digoxin. This is a very important article which was produced in Heart Failure, European Society of Cardiology in 2020 from China. Digoxin is associated with worse outcomes in patients with heart failure with reduced ejection fraction, and the conclusion was that digoxin use is independently associated with increased risk of all-cause mortality and all-cause rehospitalization in heart failure patients. But there are certain drawbacks. This was a study where the patients were taken from 45 different hospitals, and they had a heterogeneous group of patients, and different treatment plans were used in different hospitals, and they were using many territorial Chinese medications, certain medications along with the usual medications, and these medications included ginseng, licorice, and calcium-containing preparations, which definitely increase the adverse effects of digoxin. Then this is one interesting trial in Indian Heart Journal, and in this trial, after ARNI, those patients who were on usual treatment of heart failure, ARNI was added to this, and when the ARNI was added, they were all on these drugs, including digoxin, in around 50% of the patients. And then ARNI was added, and in the 6-month follow-up, all three, the NYHA class, KCCQ, score, and ejection fraction, all improved. What I want to emphasize in this is that continuation of digoxin in presence of ARNI does not hamper the result in the patient. Then in the Swedish Heart Failure Registry, published recently, not very recently, in 2022, it's not a very old, the great majority of digoxin users had a history of atrial fibrillation, and digoxin use was associated with lower mortality and morbidity in patients with atrial fibrillation, but with a higher mortality and morbidity in patients without atrial fibrillation. And this is the same The lower one is the digoxin users. Then in 23, this is the effect of digoxin use on long-term prognosis in patients with heart failure with reduced resistance. And this is the conclusion is our results show that digoxin use does not affect mortality in heart failure patients. However, rehospitalization decreased in patients taking digoxin in patients with heart failure with reduced ejection fraction. And this is the details of those investigations. And you can see outcomes. The rehospitalization is definitely reduced significantly. Of course, there was not significant improvement in mortality. Then evidence-based medical therapy in patients. I will take another 1 minute. Yeah, closing the digitalist device back to basics. This is 23. And the conclusion is, and this is published in Cardiovascular Drugs and Therapy in 23, as the risk of confounding factors are minimized by the study design, the likelihood that the positive outcomes were identified with digoxin when the digoxin used increased. And this is a summary of study design. You see there is a meta-analysis and other study designs. There is meta-analysis of RCTs and the RCTs. And you can see RCTs have got a positive result. Meta-analysis of RCTs have got a neutral effect, and other studies have got a negative study. And so this was the conclusion after this study. So we need, in fact, after the use of ARNI, we do not have any recent randomized trials with digoxin in patients. So now they are going for 2 trials are in pipeline. One is DIGIT heart failure trial, digitoxin to improve outcomes in patients with advanced chronic heart failure with all 4 pillars in position, and a decision trial. Decision trial is to investigate whether low-level digoxin, because in this trial we have seen that the low level of serum digoxin is associated with a better outcome. So in this particular trial, to investigate whether the low-level digoxin aiming for a serum concentration of 0.5 to 0.9 nanogram per ml is beneficial in a wide spectrum of patients of heart failure. And the important thing that they are including 1/3 of the patients with atrial fibrillation, 1/3 of the patients with are women in whom the results are usually wrong. So summarize, heart failure is a syndrome having heterogeneous group of diseases with variable pathological and electrophysiological properties. A fixed and common approach is unlikely to deal with all variables. 4 pillars can sustain a small structure, but for the management of this huge entity, you require more pillars. And digoxin is probably, and I feel certainly, one additional pillar, especially those patients who are in class 3 to class 4, who have got cardiomegaly, who have got an ejection fraction of less than 25%, and those who are having significant MR, and possibly those who are having atrial fibrillation. Thank you.
Thank you, sir, for covering on another controversial topic, because many of the cardiologists were saying that the life of digoxin has reached more than 250 years. So it's the time to say goodbye. But you have said, you have covered the subject very well, and you have said not only in atrial fibrillation for rate control, there are many other subtypes, because this is a heterogeneous group of disorder, heart failure. So there are many occasions, subtypes. Still there is a role of digoxin. Only thing we need to have some good trial comparing one to another.
Only one thing I want to add, that digoxin has been approved by FDA in 1954 only. Previously it used to be used as digoxin plant, some preparation of the plant. But digoxin in the pure form was available and has been approved by FDA in 1954. Thank you.
So, to cover this important topic, I invite the wonderful speaker of the town of the state, Dr. Vikas. He will take us through the value of the 4 pillars. So, based on the guidelines, what is the importance of the 4 pillars and how to take these drugs into the armamentarium of the heart failure with reduced ejection fraction. Over to Dr. Vikas.
So thank you for that introduction, sir. A very good morning, everyone. I'm sure most of you would have been able to identify this building. This is Antilia, the home of the Ambanis. But do you think this massive building would have been possible without real strong pillars? No. No ways, in fact. So over next 10 minutes, I would be taking you through the 4 molecules which are very important when we talk about dealing with HFrEF patients, and which are rightly called the foundational therapy or the pillars in HFrEF management. So the heart failure patients, they face many problems in terms of reduced exercise capacity, poor quality of life, but the 2 that bother us as physicians most are probably the increased risk of hospitalization and increased all-cause and cardiovascular mortality. Now, this slide we have seen time and again, but this becomes very important because this highlights the importance of hospitalization and the rehospitalization part that keeps on coming with every heart failure patient. Each episode of heart failure hospitalization leads to disease progression and increases risk of death beside compromising the quality of life of the patient. So when you talk about the goals of therapy in heart failure management, yes, improving survival becomes paramount, reducing hospitalization, and then increasing functional capacity, taking care of the symptoms, and improving quality of life. So if you look at the evolution of heart failure treatment, every decade, starting from 80s, has given us one good pillar of therapy. 1980s saw the emergence of ACE inhibitors, the RAS blockers. 1990s saw the emergence of beta blockers. Then around 2010, we had ARNI in our armamentarium. And of late, SGLT2 has been added in the 4 wonderful drug list. So heart failure, we know, causes overactivation of the RAS and the sympathetic nervous system. And that was the reason why RAS blockers and beta blockers, they occupied a central position in managing heart failure patients. But sooner we realized that there is another group, the natriuretic peptides, which have potential beneficial actions in heart failure. And that was how ARNI came into picture, taking care of the neprilysin, inhibiting the neprilysin, and enhancing the ANP, BNP, CNP, the natriuretic peptides part, which added more value to just taking care of the RAS system. So we discussed it in our previous discussions also, the Paradigm Heart Failure trial, how it happened to be a game changer. Look at the data that came out in the Paradigm Heart Failure trial, the massive amount of benefit that it showed to the heart failure with reduced ejection fraction patients. And there was to the tune of 38% relative risk reduction in 30-day heart failure readmission compared to enalapril, not compared to placebo, it was compared to enalapril. So just to give you an idea how much beneficial this ARNI was, when you talk about ARBs, they offered a benefit of 15%. ACE inhibitors offered a benefit of around 18%. But to look at ARNI, over and above ACE inhibitors, there was a huge 20% benefit in terms of decrease in mortality. And that is the reason why we talk so high about ARNIs every now and then in HFrEF patient management. So this ARNI takes care of many things: worsening heart failure, disease progression, recurrent heart failure hospitalization, and that has been established beyond doubt now. We also realize with time that discharge is not the end of journey for the heart failure patients. And so before discharge only, we should be aiming at introducing the molecules, particularly ARNI, so that maximum benefits could be passed on to these patients. And so there were trials to initiate therapies during hospitalization. I wouldn't be taking you through the details of all these trials, but ARNI has grown in stature slowly, not just in ambulatory or the OPD patients, but also in hospitalized patients. So with any molecule, the question that next comes is this molecule safe? So the same question also came with ARNI, and it was very good to see that ARNI has a comparable safety profile with enalapril. In fact, if you look at serum potassium values, ARNI fared much better compared to enalapril. The risk of hyperkalemia was lower with ARNI compared to enalapril. The practical points then, how to use them in practice. So the basic rule remains the same. They should be started in low dose, and one should go on escalating the doses as per the patient's tolerability. One should not stop at a dose. We should always aim to go up till the time the maximum tolerated dose is achieved or the maximum recommended dose is achieved. It is possible that you may need to reshuffle some doses of diuretics during escalation. And there are certain areas you should be wary about: the blood pressure, the renal functions, potassium levels, and you should be keeping a watch on these areas. I would just like to highlight that chronic kidney disease is not a contraindication for RAS inhibitors. Many a times you see prescriptions where it is not being prescribed only because the creatinine levels are slightly on the higher side. So that should not stop you from using a molecule like ARNI or any RAS inhibitor. Now moving ahead to beta-adrenergic blockers. They again are a backbone of the heart failure therapy and have been there for a long period of time. When given in concert with ACE inhibitors, beta blockers reverse the process of LV remodeling, improve patient symptoms, prevent hospitalization, and also prolong life. So there have been some landmark trials of beta blockers which have established 3 molecules in particular in HFrEF patients: carvedilol, extended release metoprolol, and bisoprolol. So there are some basic rules with beta blockers also. They should again be titrated. You shouldn't be stopping by just initiating the drug. Again, you should be starting this drug in minimum doses and should go on building up the dose till the patient tolerates, and should be watchful about the volume status. The good part is it can be used in both sinus rhythm and atrial fibrillation, so that's a plus point. Abrupt withdrawal should always be discouraged because many a times that leads to clinical deterioration. Moving to the third drug in the class, the mineralocorticoid receptor antagonists. So you basically have a choice between spironolactone and eplerenone. Because of better side effect profile, eplerenone is the preferred molecule. Cost remains a concern, but if that is not a concern, eplerenone should be chosen. And there have been many trials which have established MRAs as a foundational therapy in HFrEF, RAILS, FSS, Emphasis, to name a few. And mind you, this is not a drug for its diuretic properties. It's a very weak diuretic, but that has profound effect on the RAS inhibitor system, and that is the reason why it gives so much of mortality and morbidity benefit and should always be a part of your prescription. Yes, you should be monitoring potassium and renal functions frequently, particularly when you are starting with the therapy, and also when you are changing the doses of the RAS inhibitors. You should be checking the potassium levels and the creatinine levels. Now, this slide, I think no points for guessing. This is for SGLT2 inhibitors. They have been a molecule of this sort which came and which have conquered the area entirely of heart failure management. So it all started with the EMPA-REG outcome, which was supposed to be, it was initially thought to be an anti-diabetic molecule. But very soon we realized it has potential much beyond that. And then came EMPEROR reduced, which also incorporated non-diabetic patient population in heart failure. And we found that it was offering a huge benefit in terms of not only reduced hospitalization, but also prolonging life. The TAPA heart failure added to the data that was available to us. And it is the right time that we start using now SGLT2 inhibitors as a heart failure molecule rather than any anti-diabetic molecule. The good part is SGLT2 inhibitors also enable tolerance of one another. So because it decreases risk of hyperkalemia, you have more chances of going ahead with ARNI and MRAs, which makes it all the more attractive. It slows progression of renal dysfunction, so you can use again ARNI and MRAs in wide range of patients. So if you look at the guideline recommendations for quadruple therapy across heart failure types, both the ESC 2021 and the ACC 2022, they have given class 1 recommendation to all the 4 foundational therapy that we have just discussed. The idea is to convey that it's not only initiation but also optimization of the 4 pillars. So you should be going ahead till the maximum tolerated doses of the patient or the maximum recommended doses of these molecules. So prescription for heart patients should ideally include an ARNI, MRA, beta blocker, Diuretics if there are signs of congestion, and SGLT2 inhibitors not only if diabetic. Even if not diabetic, it should be used. So that has been purposefully written. It's not true. SGLT2 inhibitors in all patients, irrespective of their diabetes status. And there has to be a reason if we are not using any of these molecules. So a lot has been discussed about how we should be going ahead with all these 4 molecules, conventional sequencing, rapid sequencing. It's like asking which pillar should be made first. We are concerned that all 4 pillars should be there in the therapy as soon as possible, and then we should go about optimizing the doses. The recent guidelines, they also say that for newly diagnosed stage C HFrEF, a beta blocker and a RAS inhibitor should be started in any order, because there cannot be a fixed rule for all heart failure patients. You'll come across patients where RAS inhibitors should be started first, where beta blockers should be started first. But the idea is to get all these 4 drugs in the prescription as soon as possible. So thank you so much for that patient hearing. Thank you.
Thank you, Dr. Vikas Singh, for your wonderful presentation. And what I have learned from your talk, that once we have diagnosed the patient as a heart failure with reduced ejection fraction, we have to give all the 4 drugs if there is no contraindication. So you have given green flag to start all the drugs. But you have given also liberty to the clinician that they have to build as per their choice, as per their class of patient, as per their situation. Maybe in 3 months or 6 months, you have not fixed the timing, but you have given liberty. That's what I have understood.
Absolutely true, sir. But ideally, 4 drugs within 4 weeks. So get them as soon as possible on board. That was an older way of going about taking 3 months, 4 months, 6 months time. The idea is to get them now as soon as possible. If you can do it within 1 to 2 weeks, nothing better than that.
Thank you once again. And due to paucity of time, I will ask only single question to our learned speaker, if you have. Dr. Ajay Bose or any other.
Why don't we have the fifth or sixth pillar as IV iron? 50% patient, be it a diastolic heart failure, be it a systolic heart failure, across the globe. I'm not talking about India. If you take the data from across the globe, around 50% have got iron deficiency, not hemoglobin deficiency. I mean iron deficiency. And why not? We should have an iron profile for all our patients of heart failure. And why not we make it 5th or 6th? If Dr. Chatterjee has made 5th pillar, I'd like to make the 6th pillar. Thank you.
Thank you, sir. I think
we would like to
pillars will remain 4. These are additional therapies. Pillars will remain.
Thank you all the speakers and chairperson. Please conclude the session, madam.
Thank you so much, all the speakers and our chairperson. May I now request our chairperson to felicitate our speaker. For that, I would request Dr. Ravi Vishnu, sir, kindly come up on stage. Dr. S.S. Chatterjee is on stage itself. May I now request Dr. Ravi Vishnu, sir, kindly come up on stage. And I would request all the chairperson to felicitate our speakers with shawl. A huge round of applause for this beautiful moment. Ladies and gentlemen. It's an absolute honor for us to have you all here. So, okay.
Now the time has come for the most prestigious talk oration of this Cardicon 2023, that is late Dr. A.K. Thakur Memorial Orations. And for this, I would like to invite our chairpersons, Dr. S.S. Chatterjee, past President CSI, Dr. Hendra Kumar, past President CSI Bihar Chapter, Dr. V.P. Sinha, past President CSI Bihar Chapter. Is he there? Dr. Ajay Kumar Sinha, past Executive Committee Member, National CSI. Dr. B.B. Bharti, past President CSI Bihar Chapter and present National Executive Committee member. Dr. K.K. Varun sir, Chairman Organizing Committee of Cardicon 2023, and myself. And then I'd request our guest speaker, National President, Professor Dr. Vijay Bang from Mumbai, to please come, sir. Please give him a big hand of applause. And Dr. K.K. Varun, Dr. B.B. Bharti, Dr. Virendra Prasad Sinha. Okay. And I would request Dr. S.S. Chatterjee to please say words about late Dr. A.K. Thakur memorial orations.
I've been given this responsibility of speaking something about late Dr. A.K. Thakur. I think in this audience, I am his oldest student or student colleague, you can say, of Dr. Ashok Thakur, whom I knew since 1978 when I was a house physician. So we had interaction since then. Dr. A.K. Thakur was born on 15th of October 1937 at Akaur village in Madhubani. He had his primary education and secondary education at Khirhar High School, and then he did his MD, MBBS and MD from Patna Medical College, MD in 1967. After that, he joined Indira Gandhi Institute of Cardiology, and then subsequently he went to England, did his MRCP in 1977, got his FRCP in 1983. He was a fellow of American College of Cardiology, Indian College of Cardiology, Indian Academy of Echocardiography, and fellow of Asia Pacific Society of Cardiology. He was trained in cardiology at Manchester Royal Infirmary and National Heart Hospital, London. He had numerous publications and book chapters to his credit, but his main contribution, as I feel, it was establishing a premier cardiac center in Bihar and Jharkhand, which he built from scratch, the Indira Gandhi Institute of Cardiology, which is organizing this conference at the moment. And this he started in 80s. It was in early 80s that he started with a non-invasive facility like echo, TMT, and then certain invasive pacemaker, closed heart surgery facility, and a very vibrant CCU. After superannuation from IGIC, he started his own cardiac center, Heart Hospital, Patna, which was the first private cardiac center in Bihar and Jharkhand. And this hospital again had a non-invasive facility and CCU facility, and the first color Doppler echocardiography was started at Heart Hospital, Patna in 1994. He subsequently added cath lab and open heart facility at his own center and started the first DNV cardiology training program in Bihar. He himself, he was selected as the inspector by the National Board of Examination for inspecting Zaslow Hospital, Bombay, as well as Batra Hospital, Delhi. He was given numerous lifetime achievement awards by CSI, by Chetna Samiti, and other social organization. I will give you just one example of his sincerity to his patients and to his work. Because I was associated with Indira Gandhi Institute of Cardiology since 1983, and I was a medical officer doing the night duty at that time, and one of our senior colleagues came with acute inferior MI. At that time there was nothing, we had only streptokinase. That was also being given not very frequently. So when he came, was a very senior doctor. I was little nervous with it because we used to get certain complications during giving intravenous streptokinase. So I gave a phone call at around 2:30 in the night, and he took up the phone on first note, came immediately. He said, you just prepare it, I'm coming. He came in 15-20 minutes time, and at that time at Indira Gandhi Institute of Cardiology we did not have infusion syringes. So what we used to do is to take that streptokinase, dissolve it in 20 ml of normal saline, and then sit by the side of the patient for 1 hour to give that 20 ml of saline. Dr. Thakur sat for full 1 hour. Then after that, he sat there for half an hour till we realized that nothing wrong is going to happen now, and then he left. So that is what Dr. A.K. Thakur was, and that is why we still remember him. Thank you.
I'm extremely privileged to introduce our guest orator, Professor Dr. Bijay Bang. He is our national president, under whose guidance next month, in the month of December, our Platinum Jubilee annual conference of CSI is going to be held at Calcutta under his guidance. Dr. Bang is a senior intervention cardiologist, Lilavati Hospital and Research Center, Mumbai. He is a professor and head Grant Medical College and Sir J.J. Hospitals of Mumbai from 1985 to 2050. He is founding president, Cardiovascular Academic Research Foundation, and running founding course director, Indian ACT conferences. He is founding director and moderator, International Cardiology CME. And he has so many publications and book chapter in his credit. He is an excellent clinician, intervention cardiologist, great researcher, and a great orator. May I request Professor Bang to please honor us to give the prestigious late Dr. A.K. Thakur Memorial Oration. Thank you, sir.
Thank you very much for these kind words. I am pleased and honored to be here to deliver this oration, this prestigious oration, Dr. A.K. Thakur oration. May I have my slides? Okay. Yeah, sure. So friends, we have a very interesting topic, secondary prevention. Secondary prevention, we know, is more challenging. Yeah. PPT was a did huh? I have given it in the morning. So we know that the secondary prevention is more challenging than the primary prevention, because here patient is already in ASCVD risk of high risk category. They already have existing coronary artery disease. Either they have undergone intervention or they are on medical treatment or both. So these patients require particular attention because second event is a serious issue that we must keep in mind. So that's how secondary prevention becomes a primary goal for all of us, particularly for those youngsters who are taking deep interest in intervention, coronary intervention. They should be knowing more about secondary prevention. They're very, very important if you know intervention, but first you should learn how to do secondary prevention. That is a must. Okay. I will change the slide. Okay. So, what is the goal? Goal is give a guideline-directed therapy to prevent morbidity, mortality, and improve quality of life and well-being of a person for secondary prevention of ASCVD. Now there are pharmacological intervention and non-pharmacological intervention and specific preventive strategies. All these are extremely important. Today, in the limitation of time, I would cover only pharmacological intervention, and the risk of the secondary prevention is more risky, more challenging than primary prevention, the reason being the residual cardiovascular risk. One is inflammation. Clinically, we all recognize inflammation with level of HSCRP. And accordingly, we have to target our treatment. That is a very important aspect. Second is a residual metabolic risk. Increase in LPA, increase in triglycerides, and diabetic or pre-diabetic patients. They pose real challenge of residual metabolic risk. And third is thrombotic risk, which is we have to balance ischemic and bleeding risk in appropriate way. Apart from this antithrombotic and antilipid treatment, we also have several other goals of secondary prevention, that is S inhibitor for LV remodeling, and also the beta blocker therapy, which prolongs the life, particularly after post-myocardial infarction. So what problem we have in India is that this peculiar type of dyslipidemia, which is increase in triglyceride, reduced HDL, and normal LDL-C. LDL-C, though looking normal, but it is predominantly small, dense LDL, which is highly atherogenic, and reason being insulin resistance. Insulin resistance activates the CATP pathway and converts large LDL into small, dense LDL, which is highly atherogenic. It's not only LDL. We have to look at non-HDL-C entire gamut. Unless we control non-HDL-C equally, so we have two goals. Goal is target the LDL therapy at the LDL level to get it in the level where it can prevent secondary events, and also target non-HDL cholesterol. That is very important. What is non-HDL cholesterol? It is also called as ApoB. ApoB and non-HDL cholesterol, they are identical, alternately used terms. So what it includes? It includes ApoB or non-HDL cholesterol, includes LDL, LPA, IDL, VLDL, and chylomicrons. So why it is important to know that non-HDL cholesterol is equally important to target? Because if you don't target it, once the non-HDL cholesterol crosses 130, the hazard ratio increases, which is reflected over 30 years of follow-up, that it increases slowly the risk of coronary artery disease more and more as the non-HDL cholesterol level rises. So treatment goals have been identified by various research that this very high risk patient, how do we target it? LDL-C less than 50 and non-HDL-C less than 80. This is a very, very important aspect. Unless we achieve this goal on our patient who have already coronary artery disease, and we don't achieve this, the secondary prevention can never be achieved. Lipid Association of India has added another category because in India, the premature coronary artery disease is extensively known. And South Asians, India is a part of it, the risk of coronary artery disease is very high. So category B, that means LDL-C level less than 30, not less than 50, target it to less than 30. Now, of course, the new research has come out that the lowering cholesterol doesn't harm. So lower it as much as possible, lower the better. Now coming to HDL cholesterol, we know low HDL cholesterol is independent risk factor. But high HDL cholesterol, we thought it is protective, but not above the level of 60. Above the level of 60, it is not protective at all. It can cause infectious disease, autoimmune disease, lung disease, cancer, type 2 diabetes mellitus, and kidney disease. How do we treat? Same statin we need to use and control it. So statin is our foundational therapy for secondary prevention in terms of lipid lowering. And how do we use? How does it act? It acts through inhibiting HMG-CoA reductase. By acting there, it reduces LDL-C and thereby delipidates the plaque, which converts the vulnerable plaque into a stable plaque. And that is the reason that we need to use, and various investigations, follow-up investigation, non-invasive investigation, like MRI, SPECT scan, have shown that hot plugs can be converted to a non-hot plugs or stable plug after giving statin therapy. So what it causes, after it converts from the high lipid content plug, it becomes calcified plug with statin therapy. And statin are not only control LDL-C, but it has a pleiotropic effect. We all know that the improvement in endothelial function, reduce inflammatory response, stabilization of atherosclerotic plaque, reduce thrombogenic response, and inhibit vascular smooth muscle cell proliferation, and inhibit cardiac myopathy. See, particularly when we use lipid-lowering agent like statin, post-PCI, post-intervention, we need to reduce smooth muscle cell proliferation. And that is where statin role or secondary prevention role is very important. Another very important aspect which I would like to emphasize is it reduces the thrombogenicity. So suppose a patient having a statin therapy going on and he develops MI, he will do fair or better than person who is not on statin therapy. And this, it stabilizes the plaque, vulnerable plaque, and Voskop's trial has shown a legacy effect. When statin continued more than 20 years, it reduces the chance of secondary event highly. And Braunwald had said that if you maintain your LDL-C level less than 70 after the age of 20 years, you can live up to 100 years without developing coronary artery disease. So it stabilizes the plaque, universally accepted statin therapy. Statin therapy reverses the plaque. It is clearly shown by a reversal trial that it does reduce plaque burden, and it shrinks the plaque as suggested by Glogov trial when it was compared with statin versus statin plus evolocumab. But can it disappear the plaque? We are not sure about that. So statin has multiple roles. How do we get the best benefit of statin therapy? We get a best benefit of statin therapy only when we continue for a long term. More than 2.5 years, at least minimum, or longer. Longer you continue, you get a sustained benefit of cumulative event-free survival with coronary artery disease. So outcome trials have revealed that it reduces the MACE by 50% over a period of 3 to 5 years. It reduces the mortality both in men and women, and whether you have low LDL or normal LDL doesn't matter, high LDL-C doesn't matter. You need to give statin to all these patients who have CAD, irrespective of whether they have high cholesterol or no high cholesterol. And this is an important aspect. It is inexpensive and very safe to consider. Now we have another drug which has come up in secondary prevention very well, bempedoic acid. It has a more or less similar profile as that of statin. And advantage is if statin alone cannot control the desired goal of LDL-C, we can add bempedoic acid in combination with statin. And it does reduce more 15% of LDL-C. Second, most important thing, if patient is statin intolerant, we can use bempedoic acid. Along with ezetimibe, it controls 35% LDL-C. It also reduces hsCRP, like statin also reduces hsCRP, which is an important inflammatory marker. And we all know that unless we control inflammation, we cannot have achieved secondary prevention in any way. So a patient is not controlled. To achieve the target, we need to give sometime a triple oral combination therapy, bempedoic acid, ezetimibe, and atorvastatin.
This combination gives 90% patient will achieve LDL-C level of less than 70 and 58% patient achieve LDL-C level of less than 55. And overall LDL-C reduction is 63%. It's a cheaper combination compared to using the PCSK9 IV therapy, which is cumbersome. So statin intolerance 9%, but in clinical practice we don't see 9% intolerance, at least not in my practice. What I have noticed that those patients who complain of myalgia, we must check vitamin D level. If you correct the vitamin D level, the myalgia will disappear. So it is not a statin intolerance. It is in a patient who's got deficiency of vitamin D along with the CAD. Second thing is hypothyroid. If patient has a hypothyroid, if complains of myalgia, check for thyroid and vitamin D level. If hypothyroid is there, correct it, and the myalgia disappears. So this is very important that we need to check. So statin intolerance, never discontinue the statin immediately. Never. Change the form of the statin, lower the dose, and give alternate dose. I'll tell you something very important about the alternate dose. It's the same effect that daily dose gives. Same, no difference at all. Science has proven that, and it is reported in the literature. Now, if you discontinue statin all of a sudden for any reason, then you have a chance of developing the rebound effect and more secondary events. So never stop statin suddenly. Slowly change the form of the statin, reduce the dose, make it alternate day, never stop it suddenly unless it is absolutely mandatory to do it. So then no statin and statin, if you see, no statin also has higher secondary events. So statin is a must. All patients who have known case of ACAD, statin is a must for them. So if statin, the safest statin to avoid intolerance is pitavastatin. It's available in India. If you combine pitavastatin, ezetimibe, and bemperoic acid, it's called as triple combo. It is very good, and you can avoid expensive drug like PCSK9, which many patients of ours cannot afford it. Now, statin in elderly, it's almost sure that statin in elderly should not be stopped at all because it gives both non-fatal and non-fatal cardiovascular outcome benefit. Never stop statin in elderly above the age of 81 years. Never stop it, because many people report that there is more myalgia after the age of 81, and many people, many physicians, cardiologists control or they stop the statin. It should not be done. We can reduce the dose of statin and change the form of the statin, but never stop it in elderly also. So all these trials, what they have shown in terms of secondary prevention, lower the better. Lower the better. So both for primary and secondary prevention. Statin in pregnancy, it is safe. It doesn't cause any congenital abnormality, but it can cause preterm birth and low birth weight of the baby. Another drug which is remarkably important is icosapent. It is available in India as Cosatil, and it is very, very good. All the trials have shown that it is very good for reducing triglyceride, which is typically seen in our Indian patient, the increase in triglyceride level. And you can see the difference with icosapent, the difference, you can see the graph separating, and p-value is highly significant. So icosapent, don't forget it. It is much better and much cheaper and very good drug for reducing triglyceride in our patient, and it reduces first event by 25%, second event by 32%, and fourth event by 48%. So then PCSK9, no doubt, PCSK9, there is a controversy about whether outcome benefit is there or not there. But in acute MI, where LDL is high, we can certainly use PCSK9. It does give an outcome benefit as shown by this trial. Then this remarkable drug, inclisiran. It is a metabolic vaccine. Once in 6 months, 284 milligram, and reduces LDL-C level less than 55 and continue to reduce 2 doses for 510 days. So compliance-wise, there is nothing to beat the inclisiran. This is the best if the patient can afford. And all the 3 trials, if full data shown that Orion 9, 10, 11 trial checking the inclisiran effectiveness, and it is US FDA and CE approved for use. So first dose 284 milligram, next dose after 3 months 284 milligram subcut, 1.5 ml pre-filled injections are available, and then second dose after 6 months. It takes care of your LDL-C goals very well without any question of non-adherence to the drug. Then another thing is LPA. It's the most dreaded. At the moment, we don't have any effective drug to control LPA level, and it has a genetic disposition. Inclisiran does reduce, PCSK9 reduce, but niacin I use in my practice, and niacin 1 gram per day, it is not that unsafe. It doesn't cause that much of hot flushes or itching. At least I have not experienced that. There is NF kind of variety which is extremely good and very good to use. And I think we should use this. But there are now newer drugs coming. It is called as pelacarsen and olpasiran. These 2 new drugs are coming. Phase 3 trials are going on at the moment. And olpasiran reduces LPA by 95%. Once in 3 months, 75 milligram subcut dose of these drugs are translational. They are 100% they will be approved by US FDA, they will be approved by CE, and they will be available in market in short time. They are very safe and very effective in reducing LPA. Particularly, it will reduce premature coronary artery disease or premature coronary artery disease death in our patient. Then non-HDL goals also very important. I said less than 80 milligram. And sometimes whatever drug, oral therapy, statin, bempedoic acid, ezetimibe, we cannot control non-HDL-C. Then vupanorsen is available. It is the latest drug, and I'm sure it is US FDA approved. And it's available as a 15 milligram per kg once a month via intravenous infusion. And this drug is supposed to be highly beneficial. It has minimal side effects, but they are all very well tolerated. But as you increase the dose of vupanorsen, more and more targets are achieved very well in terms of non-HDL-C levels. Now, another drug which has come up is HLT2, another pleiotropic drug, in addition to statin in our armamentarium, and 3 trials have been done: EMPA-RAISE, CANVAS, and DECLARE trial. All these trials have suggested that secondary events are reduced over a period of significant numbers of events are reduced using HLT2, and very good drug. Most of our patients are diabetic, so use HLT2. Now they are affordable also. Another drug that is very good is glucagon-like peptide, 1 receptor agonist. In combination with HLT2, it reduces all-cause mortality in patients with coronary artery disease. Extremely important to use these drugs, particularly if patient has a diabetes, and you can use even without diabetes HLT2. So all these drugs in combination we can use HLT2 and GLP-RA1, and they all give excellent secondary prevention benefit. Then, of course, if Jupiter trial has shown statin controls inflammatory marker very well, But if you have not achieved the inflammatory marker alone with the statin, you can add this new drug, colchicine, which is available and very cheap, and we can use it. Then CANTOS trial has shown that canakinumab can be used. Now, lately, there is a gene editing therapy which is trial has been started. It's called as HEART-1 trial in New Zealand, and one patient has been declared successfully being treated. Once done and done forever. That's all we need to do, particularly good for homozygous and heterozygous familial hyperlipidemia. Now coming to antithrombotic treatment, what we have to do is, before we start, if we want to reduce intracranial cerebral bleed, which is dreaded complication, if we should not have it on any patient. Therefore, we should do precise DAPT score, clinical score it is, and DAPT score to assess and balance the bleeding and ischemic risk by using various clinical parameters and these scores. And we know that stable coronary artery disease, we can shorten the duration of DAPT to 6 months, and even we can reduce ultra short 1 month and short 3 to 6 months. And we can use clopidogrel in stable, but in acute coronary syndrome, we need to use either clopidogrel or ticagrelor. But the length of the therapy has to be 1 year. Various trials have shown that antithrombotic treatment of short and ultra-short DAPT trial have been beneficial, and mono compared the ticagrelor alone in twilight trial result in complex PCI, where ischemic burden is high. And in that also it is shown to be highly beneficial, and in the multiple stents that are used up to multivessel disease, 60, the length of the stent more than 60 millimeter, and these trials have shown a particular benefit, and then when compared clopidogrel and ticagrelor meta-analysis, very clearly showed aggregated result that there is no increase in major bleeding rate if we compare clopidogrel with ticagrelor, but benefit of reducing MI is highly there. And we can see that the platelet aggregation is least with ticagrelor. Between the ticagrelor and prasugrel, ticagrelor is superior. The most revealing finding come from COMPASS trial. COMPASS trial, particularly for high ischemic burden patient, if they have atrial fibrillation, and even if they don't have atrial fibrillation, that is combination of the rivaroxaban with the aspirin. And it has shown to reduce, if you see compare the results, 24% with this combination. And rest is S inhibitor, the BP lowering medication, and lipid lowering medication. So it becomes very imperative. Many times we have this ticagrelor problem. We load the patient, but patient angiography shows that he needs to go for urgent CABG. Then we need to reverse the effect of ticagrelor, and this antidote for ticagrelor is available, though it is not available in India, but I am sure it will come in India. So evolving therapy, what it suggests that we need to look at what clinical status patient has. Stable coronary artery disease, acute coronary syndrome, or high ischemic burden. Stable, we can reduce the DAPT duration of 3 to 6 months, but for ACS, we need to keep DAPT duration of 12 months minimum. And high ischemic burden, we can think of using, as per the COMPASS trial result, rivaroxaban with aspirin. This is supposed to be very good in complex PCI and ACS and all other aspects of the secondary prevention. So in conclusion, short duration of DAPT as a routine therapy should be considered, an aspirin-free therapy, because 30% of intracranial cerebral bleed spontaneous aspirin is supposed to be a most incriminating factor. So aspirin-free therapy is a new angle which is evolving. And for complex PCI, we follow the precise DAPT score and balance the ischemic and the bleeding risk, because we need to use DAPT for a longer duration in this subset of patients. So ticagrelor monotherapy is excellent. And guideline also says whatever I said today is based on this guideline which is proposed by ESC. Thank you very much for kind attention.
Since this is presidential oration, questions will not be taken up. And I profusely thank Professor Dr. Vijay Bang, who has come all the way from, he is our national president, he has come all the way from Mumbai. And let us give him a big hand. Thank you very much, sir, for coming here.
Thank you very much.
Thank you so much, sir, sharing your insight with us. May I now request Dr. Arvind to felicitate our eminent speaker, our eminent guest, Dr. Bang. A token of love, a beautiful gesture, this memento is presenting to our eminent guest. Ladies and gentlemen, a huge round of applause for this beautiful moment. It's an absolute honor for us to have you here, sir. And our next session is congenital heart diseases. For that, our speaker are, our chairperson are, I would request all the chairperson to chair, Dr. P.K. Singh, Dr. Sushil Kumar Singh from Khagol, Dr. B.K. Singh, NMCH, Dr. N.K. Agrawal, Dr. B.K. Singh, IGIC, Dr. Anupam Bambani, Dr. Vipin Kumar, Dr. Smita Singh. I would request all the chairperson kindly come up on stage. And our first speaker of this session is Dr. Radhakrishnan, sir. He's from Delhi.
Good afternoon, everybody, and I want to thank the Bihar chapter of the CSI for having given me this invitation.
I would like our respected delegates, please maintain silence. Please maintain in the honor of our guest speakers. It will disturb his concentration. Please make silence.
I want to thank the organizers of the Bihar CSI for having invited me. After all this talk about adult heart diseases, we, I think, move on to some pediatric topics to discuss the reversible causes of pediatric heart failure. Recently, I had given a talk to a group of pediatricians in Patna itself, and this is a repetition for some of the adult cardiologists who continue to see patients of heart failure, and especially some pediatric patients. So, I come from Amrita Institute of Medical Sciences, which has recently come up in the city of Faridabad. I was initially working at the Fortis Escort Heart Institute. It's a part of a women's and children's hospital with all the pediatric subspecialties. And it's a futuristic 2,500 bed state-of-the-art facilities which has recently come up. Now, we all know the definition of heart failure. It is defined as a heart muscle disorder unexplained by coronary artery disease, hypertension, and valvular heart disease or congenital heart disease. It could be primary which could be genetic, non-genetic or acquired, solely or predominantly confined to the heart muscle. And secondary myocardial involvement is a part of variety of generalized systemic disorder. The true incidence of various reversible cardiomyopathies in the pediatric population is not well understood or known. There are recent large trials which suggest that their proportion to range from about 20 to 50%, which is a huge number. It is very important to diagnose the etiology of heart failure early and precisely in order to determine the prognosis and also start the effective treatment. What I did was I broadly classified these group of reversible heart failures into two groups, one with normal ventricular function and the second group is heart failures with decreased ventricular function. If you talk about patients with heart failure of normal ventricular function, the commonest cause that we encounter on a day-to-day practice are patients with shunt lesions, especially the post-tricuspid shunt lesions like VST, PDA, and some pre-tricuspid lesions like total anomalous pulmonary venous connection. They typically manifest after 8 weeks of birth and earlier if they are preterm or have multiple levels of shunt. The mechanism of heart failure in these group of patients is complex. It relates to increased demand on the left ventricle to maintain the systemic output, and the greater the shunt, the higher the demand, and this mismatch leads to congestive symptoms. What about the prognosis in these group of patients? There is an immediate reversal of heart failure when we correct this lesion. The ventricular function, if you look at the echo, previously we wouldn't look at the echo, but now when we see the echoes of these patients, we realize that the ejection fraction may actually fall transiently in spite of correction of the syndrome of heart failure, and heart failure signs will regress spontaneously if the defect reduces in size or pulmonary vascular obstructive disease develop. So in some of these patients, if the VST reduces in size, the heart failure signs will also regress. Or if we correct the lesion, then also the heart failure signs completely regresses. There are a group of patients with structural heart disease with left ventricular dysfunction. Some of them are the stenotic lesions like critical aortic stenosis, severe coarctation of aorta, coronary anomalies like the anomalous origin of the left coronary artery from pulmonary artery. All of them, if you correct it, there is an improvement in left ventricular function within a matter of 1 to 3 months. So this is another group of lesions wherein the heart failure can regress completely. Here is an example of a newborn baby who had critical aortic stenosis. You notice how poorly the heart is functioning. We went ahead and did a balloon aortic valvotomy, and you can actually see the immediate improvement in day 1 of life itself. The left ventricular function has picked up, and by about day 2 it has almost normalized. So extremely gratifying results in these group of patients. L-Kappa, which is a very life-threatening disease, wherein the left coronary artery actually originates from the pulmonary artery. The moment you correct it, you notice that the heart function has already started improving. You notice that this is the heart function just before the start of therapy. After the surgical correction was performed, you can see that within 3 months, the heart function has already picked up. We have a group of patients who have so-called secondary dilated cardiomyopathies, secondary to metabolic disorders like hypothyroidism, carnitine deficiencies, nutritional deficiencies like deficiencies of calcium and thiamine, and then certain storage disorders. In all these group of patients, there is a reversal of normal cardiac function occurs after treatment of the incriminating causes. There are some storage disorders now, like the Pompe's disease, where we have therapy available. Previously it was not available. All these children used to die. But now we have therapy for Pompe's disease, and it has started showing beneficial effect after treatment of therapy, provided, of course, it is quickly diagnosed after birth and the treatment started early. We have group of patients with severe hypocalcemia, which can cause severe left ventricular dysfunction. There have been group of patients who actually present to us in a state of shock. But if you recognize them quickly, start the therapy, all these patients actually improve to normal left ventricular function. We all heard of carnitine deficiency. It is not uncommon for you to hear all children with dilated cardiomyopathy be given carnitine. It just doesn't make sense. You have to prove that this cardiomyopathy is related to carnitine deficiency. And then once you give carnitine, within a matter of 0 to 6 months, the left ventricular function actually improves. These babies actually present very early in life, and if you can do the routine test for evaluation, we can also show the improvement. There is a group of patients where we call tachycardiomyopathy, which is basically arrhythmia-induced cardiomyopathy. It refers to the presence of a reversible left ventricular dysfunction solely due to increase in ventricular rate, regardless of the tachycardia origin. It is most important to differentiate this tachycardia from tachycardia which is caused by left ventricular dysfunction, and a simple investigation which is neglected nowadays is to do an ECG, define the arrhythmia, quickly treat it, and we will notice immediate improvement in heart function. Within a matter of weeks to months, the heart function improves. In the pediatric population, the paroxysmal junctional reciprocating tachycardia is one of the most common cause of arrhythmia-induced cardiomyopathy. Treatment consists of suppression of the tachycardia with antiarrhythmics or doing an RF ablation if it is feasible. Cessation of tachycardia results in significant recovery of left ventricular heart ejection fraction and cardiac output by 48 hours, and full normalization of about 1 to 2 weeks, and some might take a few months to improve completely. A drop of pro-BNP levels within a week of elimination of tachycardia is supportive of the diagnosis. Here is an example of a newborn who presented to us with atrial flutter with very poor left ventricular function. We immediately cardioverted this, and this was the rhythm which was present at the time of presentation. And you notice that immediately after the correction of the tachycardia, the left ventricular function has already started improving. Another example of a PJRT, the permanent reciprocating tachycardia, you can see the inverted P waves in 2-3 and AVF. And we did an RF ablation because this child was about 8 years old, and post-ablation almost restored to normal sinus rhythm, and the heart function improved. This is another group of disorder which we frequently encounter on a day-to-day practice. Basically, it's called acute myocarditis, which is an inflammatory disease caused by infection, immune system, or exposure to drugs. And the commonest cause is a virus, which is the Coxsackie virus, which is responsible for it. Of course, there are multiple causes of this. One of the things which we encountered recently was a post-COVID myocarditis, especially when COVID was at its peak. How do you diagnose them? MRI investigation is now the investigation of choice as a substitute. In fact, we now call it a non-invasive biopsy. We have certain definition criteria in order to define it. Biopsy in these group of pediatric patients is difficult, and the risk associated with newborns and infants and children. So now, if you suspect myocarditis, MRI is an investigation of choice. There are various criteria for diagnosis. I'm not going into the details. And then, of course, we have to prove whether it is virus negative or virus positive, because the treatment differs. It has a variable prognosis. The best prognosis seems to appear in the patients, or the group of patients who suffer myocarditis post-COVID. They always seem to improve over a period of time. So how does one sort out the etiology? It's a huge list of conditions causing ventricular dysfunction. The etiology of some of them are very obvious. History, time of presentation, and associated non-cardiac features also help. In some, Extensive investigations are required like metabolic, genetic, MRI, etc. And how do we predict recovery in these group of patients with left ventricular dysfunction? It's a difficult question to answer to parents, but there are clues which can indicate good prognosis. One is early recovery of function after treatment. It may actually be the best investigation, and reciprocatingly, no or poor recovery within a matter of 1 year indicates a bad prognosis. No scarring seen on the LGE scan and MRI may indicate better chances of recovery. There are certain subsets like genetic DCM, mitochondrial DCM, etc., which indicates a bad prognosis. Viral myocarditis has a much better prognosis in infants rather than children and in adolescents. Post-COVID, there are better chances of recovery. Hypocalcemia, carnitine deficiencies, and probably now Pompe's disease also has a good prognosis. So in summary, pediatric heart failure has a myriad of causes. Heart failure with normal ventricular function has the best prognosis, for example, treating the VST or a PDA. Tachycardiomyopathies also has excellent prognosis if it is diagnosed early and treatment started early. Heart failure with low ejection fraction and structural heart disease like aortic stenosis, coarctation, etc. recover very well when treated early in the natural history. Extensive and sometimes expensive workup is necessary in the absence of the above causes. Sometimes we have to do an MRI, biopsy, genetic study, etc. In these subset of patients, myocarditis and specific enzyme deficiency may have a better prognosis. Thank you very much for your...
You may start your second topic, sir.
Yes. I was asked to give this topic, do all ventricular septal defects need closure? We all know ventricular septal defect is one of the commonest lesions which we see in congenital heart lesions. The reported incidence of isolated ventricular septal defect ranges from 0.3 to 3.3 per thousand live births, which is a large number. And almost 20% of ventricular septal defects are associated with almost any form of congenital heart disease. The symptoms of ventricular septal defect depends upon the size of the ventricular septal defect. These symptoms are typically present for large and moderate defects, feeding difficulty, tachypnea, frequent lower respiratory tract infection, failure to thrive. And you realize that they are all non-specific. It can be present in multiple lesions, it can be present in pneumonia, it can be present in any form of infection. So they are basically non-specific. If you look at the classification of ventricular septal defect, which we anatomically classify, it has a lot of importance. For example, perimembranous defect, which constitute the majority of ventricular septal defect, has a 50% chance of reduction in size. Doubly committed VSTs, which form about 5 to 7%, never reduce in size. Defects like the inlet VST and muscular VST also have a higher incidence of closure because they lie within the muscular septum. So it is very important to classify by echo the type of ventricular septal defect when we give the report to the family. What is the natural history of these ventricular septal defect? This study was done when we didn't know what, and it contains a mixture of mild, moderate, and large ventricular septal defect. Even then you see that the prognosis was dismal, and when we compare it to the normal population, if you don't treat these ventricular septal defect. So the autopsy series and the survival series all show a bad prognosis if you don't treat ventricular septal defect. Now, of course, the outlook has changed. We tend to classify ventricular septal defect into various groups and then offer the treatment. The natural history of ventricular septal defect may take various pathways. You can have spontaneous diminution in size or closure. You can have development of right ventricular outflow tract obstruction, development of aortic regurgitation, development of left ventricular outflow tract obstruction, development of pulmonary vascular disease, and also some of them may develop infective endocarditis. If you look at the unnatural history, you can see the excellent prognosis. This is also a very old site. Now probably the risk of closing any ventricular septal defect is not more than 2%, and the survival almost matches that of the normal population. So this was a very old natural history study which was seen, and clearly you can see the difference between not treating and treating these group of children with this heart defect. So non-restrictive ventricular septal defect have early symptoms. They have shunts which are typically defined as more than 2:1, LALV volume overload, and all these features which define it as a large VSD. The moderate defects are in between the two. The shunt is defined as between 1.5 to 2:1 by clinical X-ray and echo means. They have moderate LV to LV volume overload, which is defined by echo and X-ray, and increase in RV pressure, which is not as bad as that of a large ventricular septal defect, somewhere in the moderate level. So in non-restrictive VSD, they have poor growth, they have congestive symptoms, and which is not controlled by medication. We advise closure as soon as possible. Control the heart failure, and the moment you do that, the heart failure improves. In the moderate size defect, we tend to wait till about 2 to 5 years of age, provided they are not failing to thrive, and the medications try to control the heart failure. And if it still remains a moderate size defect, we would go ahead and close it by about 1 to 2 years of age. The contentious issues is always with a small VSD. What do we do with it? Do we have to close it? Does it affect the natural history? So what is a small VSD? It is typically defined in terms of hemodynamics, normal pulmonary artery pressure, normal heart dimensions by echo, normal ECG, normal X-ray, no symptoms, and a shunt which is less than 1.5:1. We avoid the use of size on the echo because there is so much of variability between the same operator and different operators. The measurements are only important while choosing the size of a device when we decide to close it with a device. So what are the issues? Will this VSD close? There are some difficult anatomies like a perimembranous defect with an aortic valve prolapse, a doubly committed VSD with aortic valve prolapse but no aortic regurgitation, a group of VSD which causes LV to RA shunt. Will infective endocarditis occur in these group of patients? Should we close it in order to prevent infective endocarditis? Can symptoms be attributed to the ventricular septal defect? Then the issue of cardiac arrhythmia, especially if left untreated, and other issues like employment, marriage, and insurance all come into question when we see a small ventricular septal defect and have to take a decision whether to close it or not. So let's look at this one by one. There are multiple small studies are available as far as the incidence of closure is concerned, and the figures of closure rates vary between 35 to 70%. Most of the studies do not separate out different types of ventricular septal defect. For example, I said that if it is a doubly committed VSDs, it will never close. If it is a muscular VSDs, it has a 90% chance that it can close. But in general, the maximum closures tend to occur within the first 2 to 4 years of life. However, closure or diminution of size is also known to occur up to adolescence. There is a controversial data on LV dilatation. Typically, we have been told that if the LV is dilated, go ahead and close it quickly. Some studies show that dilatation with age occurs, and equally some others shows reduction in size. There is no data linking LV dilatation to adverse events, But as per recommendation, if dilatation persists beyond 2 years of age, then we have to close it. And if failure to thrive occurs, then we close it early. As far as infective endocarditis is concerned, the incidence varies in different population study, hospital study. Typically in large registry data, it comes to about 0.9 to 2%. Infective endocarditis, remember, can also occur in the post-surgical era or in the device closure. It is difficult to justify closure in order to prevent infective endocarditis. Also, VSD currently is not recommended in the list of high-risk lesion for infective endocarditis prophylaxis. The emphasis nowadays is on dental hygiene. As for recommendation, if one episode of infective endocarditis occurs, then I think it is prudent to close the ventricular septal defect. Employability, insurance, marriage, pregnancy, and childbirth are all genuine issues. It cannot be dismissed in the real world. There are no definite answers to this. Insurance acceptability is now becoming commoner. Small VSDs does not figure in any category of risk in the pregnancy. That means it is a very low risk for pregnancy. And employability in some profession will be completely rejected. For example, if somebody wants to join the armed forces or other important employability, they will be completely refused. It is very difficult sometimes to attribute symptoms to small VSD. It is not uncommon for a patient or the parents coming and telling you this child becomes breathless while playing. It is very difficult to answer whether it is attributable to the VSD. It is very important to rule out other causes like deconditioning, obesity, which is very common in the population. Sometimes symptom-limited treadmill test may help you when dyspnea is the main issue, and then take a decision. As far as cardiac arrhythmias is concerned, some studies shows higher incidence of sudden cardiac death and cardiac arrhythmia in VSD, especially in adults, but it has not been proven in large population study, and there is no data on treatment benefit. There are some difficult anatomies which I was discussing. For example, aortic valve prolapse with no aortic regurgitation. We have to differentiate this group between a perimembranous and doubly committed VSDs. In the doubly committed ventricular septal defect, if you have an aortic valve prolapse, it can progress rapidly. So there are different opinions between the cardiologist and the surgeon. Our Indian Academy of Pediatrics recommends no treatment till aortic regurgitation develop, but we should follow them closely. The AHA-ESC recommendation also concur with this, that you should not treat till aortic regurgitation starts developing. Then there is very rare group of patients with LV dilatation and LV-RA shunt. Without LV, RV shunt, there are difficult decisions. We should treat them only if right atrium and right ventricle dilatation occur. Fortunately, this group of lesions are extremely rare. So to summarize, natural history of large VSD is always poor. Do not wait to close it. If there is no reduction then in size, then close it within the first 3 to 6 months of age. This is the only way to stop seeing the so-called Eisenmenger syndromes like in the West due to simple lesions like ventricular septal defect. One can wait for 2 years with moderate defect if weight gain is good and give a chance for spontaneous reduction. Do not dismiss small ventricular septal defects. You may not advise closure in the majority, but don't lose the follow-up because new lesions like RVOT, LVOT obstructions may develop. Issues like marriage, employability, etc. will always test the skill of a physician and should be treated with empathy and not just dismiss them and say, oh, it doesn't matter, because these are genuine issues on a day-to-day basis. Thank you very much.
Thank you very much, sir, for your excellent talk. If there are any questions from the audience, you may ask to our speaker. If there are no questions, then we now close
Thank you. Thank you very much.
conclude the session. Thank you very much.
Thank you so much, sir, for your insight. May I now request all the chairperson to felicitate our speaker with flower bouquet. There is a small change in a sequence. Our next speaker is Dr. Major Prabhat Kumar sir, but today we have Dr. Debika Chatterjee ma'am. She has to catch her flight, so we would like to request you ma'am, kindly come up on stage. And for that, for this session, our chairperson are Dr. Birendra Prasad sir, Dr. Birendra Prasad Singh sir, PMCH. I would request you to join us. And our next chairperson are Dr. Ranjan Kumar, Dr. Shraddha Ranjan, Dr. Shishir Kumar Mishra sir, Dr. Shambhu, Dr. Bhaskar Bhushan, Dr. Bhi. I would request all the chairperson to chair. And today we have Dr. Debika Chatterjee ma'am. She's from Kolkata.
Good afternoon, everyone. So today our next speaker is very distinguished faculty from Kolkata, Dr. Debika ma'am. She'll be talking on interesting cases of echocardiography. Please, ma'am.
Thank you, Shraddha. And good afternoon, everybody. And it's fantastic to be in Patna once again. I really feel very happy to come and join the scientific session in Patna. And my sincere thanks to all the members of the organizing committee for inviting me. And today I'm going to show you some interesting cases of echocardiography. नहीं हो रहा yeah. So, echocardiography was introduced in early 60s. Initially, we didn't have too many indications, but as we went along, we increased more and more indications, and today we are in such a stage that it has become an integral part of the cardiovascular diseases, and without echocardiography, cardiology cannot survive. This is because, echocardiography can be done at bedside at a very low cost, and it detects the information with high sensitivity and specificity, and that too very, very quickly, and can be used for serial follow-up. Now let me start with my first case, a young female, known case of mitral stenosis, rheumatic, and there was a plan for balloon mitral valvotomy. As we look at the valve, it looks quite good. It's a case of severe stenosis, as you can see, and there is no calcification, and commissures are free of calcification, which is a very, very good sign. Commissural calcification is the contraindication of balloon mitral valvotomy. And we see the color flow. There is good, candle flame appearance with a mean gradient of 18 millimeter of mercury, and the valve area is 0.8 square centimeter. So otherwise, in transthoracic echocardiography, it looks quite suitable for the balloon mitral valvotomy without any regurgitation, good scoring. The score was around 7, Wilkins score, but a main contraindication of BMV is a thrombus in the LA appendage. That can be detected by transesophageal echocardiography. Look here, there is a dense spontaneous echo contrast in the LA, and as I change the angle, I can see a very large thrombus in the LA appendage, which was not seen in transthoracic echo. And these thrombus, presence of a thrombus is a contraindication for balloon mitral valvotomy. And we can see by transthoracic echo, provided the thrombus is very, very large. Otherwise, we detect it by transesophageal echo. As in this case, see, this is another case of mitral stenosis, having a very large thrombus, and we have detected it by transthoracic echo. And sometimes we can see a thrombus in the LA appendage also by tilting the probe and getting an off-axis, short-axis view if it is large enough. But usually we can't see. We are very scared when there is thrombus. We treat it before intervening these type of cases. But our nightmare is when we get a thrombus like this, which is a ball valve thrombus. As you can see, the thrombus is freely moving inside the LA, and any time it may sit on the mitral valve, though it is stenosed, it can sit on it and causing total occlusion to the flow, and any moment it may also embolize. So once we get this is really a nightmare to us. Apart from this, very, very frequently we get in aged patients the degenerative change in the mitral valve, which we call mitral annular calcification. As you can see, there is a whitish calcification on both the anterior and the posterior annulus, causing some obstruction to the mitral flow with some gradient sometimes, but the leaflets are okay. So this doesn't need any treatment. This is just a degenerative process. However, very, very rarely we get a type of mitral annular calcification which we call a caseous mitral annular calcification. It's a benign condition of MAC occurring only in 0.6%, where often we think that this is a tumor or a thrombus. We have a confusion. Well, this is not a tumor or a thrombus. This is also a degenerative process, and often we see the echo-free necrotic area in this dense area of calcification. And so it resembles sometimes an abscess, a thrombus, or a tumor, but nothing to worry. We don't need any active treatment. This usually we get in women over 70 years of age. The pathogenesis is not yet been defined, but obviously it is a degenerative process. No intervention or medical therapy is needed. But if it causes severe obstruction to the mitral flow, then we need to do the surgery. As in this case, it is causing some obstruction, but a mean gradient of only 2 or 3. So it doesn't matter. We can carry on the conservative treatment for other cardiovascular problem. Now, coming to the mitral valve chordae tendineae. You see the chordae are fibrous tendons, tendon-like structures which project from the papillary muscle to the mitral valve leaflets, and these are distributed evenly, and they distribute the loads placed on the mitral valve during the systole, during the closure time. So this is very, very essential for competence of the mitral valve. And the tension given by the chordae are very, very important. Now, if such a chordae is torn, you see, look at the chordae. It's torn and it's projecting from the LV to the LA, and that has made the posterior mitral leaflet flail. So it has resulted in significant anteriorly directed jet of MR. See, the pathology is in the PML, and that is why the mitral regurgitation jet is directed anteriorly. So by looking at the direction of the mitral regurgitation jet, we can see which leaflet is involved in such case. Now, this piece of information is very, very important to the surgeon, because nowadays the surgeons are doing fantastic repair of these valves. Look at this patient, a neocardi was placed and an annuloplasty ring was there. The surgeon has fixed this MR with only a trivial residual mitral regurgitation. So these are the ways we carry on the treatment of these patients with the mitral valve. Now, going to the aortic valve disease, here is a patient who is 70 years old male, complaining of chest pain, shortness of breath, and repeated syncope. On auscultation, we get systolic murmur and ECG LVH. And we do the parasternal long axis anapical 5-chamber view. We see the dense areas of calcification in the aortic valve. So it signifies that there is a calcific aortic valve stenosis. And look at the LV, there is concentric hypertrophy, and contraction is very good. The ejection fraction is pretty good. And we go to the apical 5-chamber view and put the color flow. A very narrow jet of flow is going through the aortic valve, and we get the continuous wave Doppler, and then we trace the spectrum to get the peak velocity and as well as the mean gradient. And we get a peak velocity of 5 meters per second and a mean gradient of 58 millimeter of mercury. And if you look at the latest AC guideline, if the mean gradient is more than 40, we say it's severe, and if the velocity is more than 4 meters per second, we say severe. So this case is a severe calcific aortic valve stenosis. Now let us see another case. Another case of 70 years old male came with the same complaint of chest pain, SOB, syncope, and we do the echocardiography. We get a similar picture of the aortic valve, dense areas of calcification here, you see, and also in the apical 5-chamber view, dense areas of calcification. So we expect to get a very, very high gradient, and we put the color flow across the aortic valve in 5-chamber view, get the CW Doppler, and trace it, and we get a peak velocity of 3.2 meter per second and a mean gradient of 28 millimeter of mercury. We expected a severe stenosis with a mean gradient of more than 40. Instead, we are getting 28 millimeter of mercury. So now, what is the severity of aortic stenosis? Now, as per the AAC guideline, it falls in the moderate range. But if we look at the aortic valve, hardly there is any flow. Look, hardly there is any flow across the aortic valve. Valve is so much calcified, deformed, very minimal flow is taking place. Then how come we are getting a low gradient and a low velocity? Well, for that we need to keep in mind that velocities and gradient across the aortic valve are not always reliable for assessment of severity of aortic stenosis. Because if you look at the LV, you see the LV is having a very poor ejection fraction. So these LV having poor systolic function cannot generate a significant pressure gradient, though the aortic stenosis is severe. So these are the cases where we assess the severity of the aortic stenosis by continuity equation, by looking at the LVOT diameter, LVOT VTI, and aortic valve VTI. We calculate by using the formula, what goes in must come out. So that is the principle behind the continuity equation. We got an aortic valve area of 0.73 square centimeter, and as per the latest AAC guideline, you see we got 0.72. So the aortic, sorry for this mark, it will be here. It's less than 1 square centimeter. So aortic valve area indicates that it's a severe aortic stenosis. And also we can do low-dose dobutamine stress echo in these cases. Look here, at rest, the velocity and the gradient were low, but as we have infused low dose of dobutamine up to 20 microgram per kg body weight per minute, the mean gradient as well as the velocity increased, but the aortic valve area remains same. So it's a true stenosis. Now these are the cases where we go for TAVI, a 70 years man who is not suitable for surgical replacement. We are doing nowadays the TAVI, or we call it transcatheter aortic valve implantation, and the patients show immediate good result with improvement of the ejection fraction. And look at the peak velocity, it's only 1.5 meter per second, and mean gradient came down to 5 millimeter of mercury. So that is the utility of echocardiography in cardiology. Now let us see a case which was sent by a neurologist because she is a 25 years female, admitted with stroke. X-ray ECG were normal, but MRI showed fresh ischemic lesion in right frontal lobe. Now usually this stroke occurs in elderly group of patient. This ischemic stroke is very, very rare in young individual, occurring only in 3% of the stroke cases under 40 years. So the neurologist has sent to find out the cardiac source of embolism. Now what are the causes of cardiac source of embolism? Well, it can be a thrombus in the LA or LA appendage in mitral stenosis, which may dislodge, as I have shown you in the first case, or it might be a LA myxoma with friable margin, which may dislodge in the LA or LV. Vegetation on the left side of the heart also may dislodge, and very rarely a paradoxical embolism through the patent foramen oval. We call it cryptogenic stroke. Very, very rarely we may get it. Now let us see our case. This is the apical four-chamber view. You see this is RARV and LALV. We can see one mass in the RA having irregular margin and another small mass in the LA also. And they are almost at the same level of the IAS. Both are attached to the IAS. So now what it is this a myxoma? If it is a myxoma, why at the same level? Or is it something else? Well, we looked at the RV. Now look here, the RV is dilated, RA also, having systolic dysfunction with TAPSI value of 10 millimeter and the TDI systolic velocity is 6 centimeter per second. So along with that, we are getting RV systolic dysfunction. Now let us look at the tear gradient. TR jet is there, mild tear with a tear gradient of 37 millimeter of mercury in spite of RV having the systolic dysfunction. IVC was sluggish, so the patient is having some significant amount of pulmonary hypertension. So what it is? To confirm the diagnosis whether the mass is the single mass or these are the two separate masses in the RA and LA, we did a transesophageal echo. And the picture was very, very clear with transesophageal echo. As you can see, this is the IAS, and this mass, main part of the mass is in the RA, and a small part has gone to the LA through the PFO. You can see this particular patient is having a PFO through which the part of the mass has gone to the LA, and these are so friable, any moment the patient might have another attack of stroke or pulmonary embolism from the right side, and from the left side, the cerebrovascular accident. So this is called a thrombus in transit, which is straddling a PFO, one leg on the right side, RA, and another leg on the left atrium. So this case has given rise to the paradoxical systemic embolism. Now, the question is, why the mass has passed through the PFO? Well, see, the PFO is present normally in 27% population. So this patient must have had a PFO. Now in the PFO, we know normally there is a left to right flow. How come this mass has gone from the right to left? Well, this is because the patient is having pulmonary hypertension, and that has caused the passage of the mass from the RA to the LA. So the high PA pressure has pushed the mass from the RA to the LA. So this is called paradoxical embolism. The patient was having a thrombus in the right popliteal vein. The peripheral venous Doppler has shown, and having the Apla syndrome, a young girl with Apla syndrome presenting with stroke might be having a cryptogenic stroke. So we need to look at the echo very, very carefully. So this case was operated in our hospital. Look at the mass. It looks exactly the same as you see the one which we have detected in echocardiography, and direct closure of the PFO was done. There is no residual PFO flow. And look at the RV, it has improved. These pictures are before the discharge of the patient from the hospital. So the thrombus in transit through PFO is an extremely rare finding. Only 100 cases are reported in the literature. Commonest presentation is pulmonary embolism and paradoxical systemic embolism through PFO. It's a medical emergency, having a very high mortality rate, and it's very transient in nature. It dislodges immediately. Most of the cases are identified at autopsy. So very, very important role of echocardiography in identifying these masses very, very quickly, which has saved the life of the patient in this case. Now, do I have time? Okay. Then I'll show some 2 minutes more. Okay. The complication of MI, let us see. A patient, 60 years old male, anterior wall STEMI, had primary PCI. He was on a dual antiplatelet therapy and came for a checkup, and we find a mass, a thrombus at the LV apex, seen in 2 views, mass with irregular margin, seen throughout the systole and diastole, and at least in 2 views confirms that it's a thrombus. Now, in spite of being on antiplatelet therapy, this patient has developed a thrombus. Now, is it possible? Well, it is possible. There is a study where it was shown that 100 patients who had undergone primary PCI with antiplatelet therapy, and a thrombus was detected in 15% patients in first 3 months, and that to 2/3 of them within first week. So the message is, thrombus formation is a frequent finding in anterior wall STEMI treated even with antiplatelet therapy, and that is why they should be assessed very, very carefully by echo within the first week and should have a serial follow-up. We are very, very scared if we see this type of thrombus, which may embolize at any moment. Thrombus also sometimes protects the heart in a contained rupture. You see, this is a pseudoaneurysm. The wall is formed only by the pericardium, and this C-shaped thrombus is protecting it from rupture. So we call it contained rupture, and this needs urgent surgical repair. Otherwise, it may rupture at any time. On the other hand, the true aneurysm is having a wide neck. This doesn't need urgent treatment, only the conservative treatment. Now, the post-MI VSD is another finding which can be picked up by echocardiography. This is a patient admitted with anteroseptal wall MI. And look at the, just this case I'll show, and then I'll stop. And on the 3rd day, we got a harsh systolic murmur. Color flow shows left to right flow. And so this is a VSD. From the LV, it's going towards the RV. This is a post-MI VSR or VSD, we say, occurs in 1 to 3% cases. And the mortality rate is very high. Relative improvement in survival is possible if we can detect early. The anterior VSR, the one which I have shown you, is very easy to detect, but posterior VSR is often the one which we miss because their entry and exit point are different, or it occurs in the setting of inferior wall MI. When we see abnormal flow in the RV, be careful in a setting of inferior wall MI. So you tilt the probe till you get, you get an off-axis view and look how the VSD is seen. So other than the identification of the left to right flow and identification of the VSD, it's also important in the present decade to give the information about planning of the device closure, which is an attractive alternative to surgical repair. In this particular patient, there is no apical rim. On the other hand, look at this patient. Look at this patient. This patient is having good apical rim, and so we have done a device closure with no residual VSD. And to end my talk, I'd say a free wall rupture, we need to be very, very careful. We miss most of the cases because there is sudden cardiac death because of cardiac tamponade. But if the defect is small, raised intrapericardial pressure or presence of the thrombus in it may result in cessation of leakage, and that is why the most important message is if you get a localized pericardial effusion overlying an infarcted area, it should be considered as a sealed free wall rupture. As in this case, look here, this is a large anterolateral MI. I got the pericardial effusion in this case, and then slowly I started looking at it. Look, initially I couldn't identify, then as I tilted the probe, I got this, this contained rupture. This case was sent to the surgeon, and then look how the surgeon has repaired this, you see, the before rupture in the lateral wall, large rupture, and after the repair, how nicely there is no flow, and we could save the patient. Thank you.
Thank you, madam, for very interesting case with very good picture quality. We are getting late, so question answer session will be not taken up. I would first
I would like to felicitate ma'am as she has a flight to catch. As usual, it was a visual treat with very nice images, and especially the case of thrombus in transit. I know that is it's a coincidence that we catch these kind of patients, and you had such a beautiful image, ma'am. Thank you.
May I now request all the chairperson to felicitate Devika ma'am to present this shawl. Our next speaker is Dr. Anil Kumar Thakur, sir. I request you to join us, sir. Thank you so much, everyone. Thank you so much.
No.
Now I request Dr. Anil Kumar Thakur sir from IGIC
please deliver his talk on dopamine stress echocardiography.
पेन ड्राइव उसको दिए, वो पेन ड्राइव क्या कर दिया? पेन ड्राइव उसी पे दिया था ना सर। इसमें एचडीएमआई पोर्ट नहीं है, एचडीएमआई पोर्ट लगाने के लिए बगल में इसमें इधर होगा ना पीछे कैसे करें? तो वहीं से करना होगा। कहाँ से? मेरे सिस्टम से, लेकिन वही ट्रेनिंग वही है ना। हाँ ये सब ट्रेनिंग होता है, यहाँ से वहाँ से नहीं जाता। एचडीएमआई प्लगइन सिस्टम है नहीं सर, मैं अपने सिस्टम से कर दूँ, बस वीडियो प्ले नहीं होता है, वीडियो प्ले नहीं होता है। हम कैसे करेंगे? चल रहा है मेरी ट्रेनिंग, तो हम कैसे करेंगे यार? कॉल कैसे देखेंगे, हम कैसे करेंगे? इसका कोई इशू कभी नहीं है। हो क्या नहीं पाएगा, कैसे भी तो करेंगे ही, हैं? तो हम कहाँ से बोलेंगे? तो वीडियो प्ले नहीं होगा तो कैसे करेंगे? आप वहाँ से ही वीडियो प्ले कराइए, हम यहाँ से ही बोल देंगे।
I think some technical error is there.
Good afternoon, respected chairperson, senior colleagues, and my dear friends. Thank you for this opportunity. The dopamine stress echo in coronary artery disease. Stress echo compares wall motion to identify significant ischemia which is not apparent at rest. A stress echocardiography can also be used to evaluate valvular heart disease, pulmonary hypertension, and LV filling pressures. Most common indication worldwide is evaluation of coronary artery disease. A stress echo is either performed with exercise or with pharmacological agent. Common exercise includes treadmill test with immediate post-exercise imaging. These are the other methods of imaging. Imaging should be acquired quickly because valve motion lasts for a few minutes after termination of exercise. These are the types of stress, advantage and disadvantage. Treadmill, of course, will be providing you high workload. You will be getting basal stage and immediate post-exercise stage. Dovitamin will be providing you continuous imaging, and side effect of the drug will be the disadvantage. Dovitamin, although often referred to as a selective beta-1 adrenergic receptor agonist, it also has mild beta-2 and alpha-1 receptor agonist effects. To sum up, the beta-2 and alpha-1 adrenergic agonist effects are relatively balanced. The net effect on the systemic vasculature is minimal in most patients. Stress response. Normal LV valve motion becomes hyperdynamic on stress. This is the normal response. Worsening of valve motion abnormalities or development of new ones is hallmark of stress-induced ischemia. 10% of cases an akinetic myocardial segment that becomes dyskinetic during a stress echo. This change was not found to have a diagnostic or prognostic implication. Adjunctive criteria for positive stress echo: LV cavity dilatation, decrease in global LV systolic function, diastolic dysfunction, new or worsening MR. Indications: evaluation of known or suspected coronary artery disease in patient unable to perform adequate exercise test. Risk stratification after myocardial infarction, before non-cardiac surgical procedure, and identification of viable myocardium in patients with left ventricular dysfunction. Procedure. Typically, beta blockers and other medications are not withheld before testing. An infusion to provide doses from 5 microgram per kg per minute is prepared. Atropine should be available if needed to increase the heart rate. The short-acting beta blockers like esmolol or metoprolol to reverse the adrenergic effects of dovitamin. Nitroglycerin for ischemia, lidocaine hydrochloride for ventricular arrhythmia. Phentolamine mesylate for extravasation of the drug into the tissues. Protocol. Dovitamin is delivered intravenously by infusion pump starting at 5 microgram per kg per minute. At 3 to 5 minute intervals, the infusion rate is increased to 10, 20, 30, and 40 microgram per kg per minute. If another endpoint is reached, test may be terminated before reaching maximal dose. If no endpoint is reached, atropine should be used at peak dosage stage to increase the heart rate. Additional dosage of atropine can also be used, but the total dose, maximum dose not exceeding 2 milligram. Digitized images are obtained at baseline every stage and during recovery with use of a quad screen format using 4 standard views: the parasternal long axis, short axis, apical 4-chamber, and 2-chamber views. Endpoints. Target heart rate is achieved. Development of new regional valve motion abnormality of at least moderate severity should be there. Peak dose, appearance of ventricular tachycardia or sustained supraventricular tachycardia. Severe hypertension or severe hypotension and intolerable symptom. Interpretation. Good interpretation depends on acquiring good quality image. Digital, wall thickness and excursion should be looked for very carefully because it determines myocardial function. 16-segment analysis is recommended for determination of following important myocardial responses: normal, ischemic, hibernating myocardium, and stun myocardium. Normal response is the global increase in contractility, hyperdynamic wall motion, increase in heart rate, and increase in endothelial excursion and systolic wall thickening. Resting wall motion abnormalities indicates ischemia or prior infarction. Hypokinetic, either ischemic or partially infarcted, akinetic, severely ischemic or transmural infarction, dyskinetic, prior transmural infarction. So development of new wall motion abnormalities and worsening of resting wall motion abnormalities are the abnormal responses to stress. Endothelial excursion is less specific than systolic wall thickening. Failure of increase of left ventricular ejection fraction is less specific finding and may be seen in multivessel coronary artery disease, however also present in those patients on beta blockers and patients with valvular heart disease. Ischemic response, normal resting myocardial function. That means there will be no regional wall motion abnormality at the basal stage. Hyperdynamic response to low dose. And hypokinesia or other form of regional wall motion abnormality at the peak dose stage. And complete reversal of peak dose abnormality at the recovery stage. This is the reversible ischemia or inducible ischemia. Viability assessment, stun myocardium and hibernating myocardium. So wall motion abnormality at the basal stage gets improved at the low dose stage, remains improved at the peak dose stage, is the monophagic response and is suggestive of stun myocardium. Wall motion abnormality at basal stage gets improved at low dose stage and again gets hypokinetic, is the biphagic response and is suggestive of hibernating myocardium. This is the same thing in a different format. Try to concentrate over here, over the scar myocardium, scar tissue. So scar tissue, if it is akinetic at the basal stage, will remain so at the low dose stage, peak dose stage, and in the recovery stage. So there will be no change in the scar tissue throughout the procedure. Once again, the hibernating myocardium, biphagic response, and stun myocardium, the monophagic response. So, see, this is the scar tissue, stun myocardium, and hibernating myocardium. Altogether, 16 segments of LV are shown to you. Coronary arterial blood supply of individual myocardial segment is also shown here. You will agree with me that there has been some variation in the coronary arterial blood supply of the individual myocardial segment, but what is recommended is like this, and we'll follow it. This is the outline of the bullseye representation. All basal segments are in the outermost circle, all mid segments are in the mid circle, and all apical segments are in the inner circle. This is the wall motion score index. The sum of the wall motion scores divided by the number of segments scored. So this is the bullseye representation, and see the peak dose. 16 segments are there, Each particular segment is assigned a particular color and a particular point. Say for normal it is green and 1. For hypokinesia it is yellow and 2. For akinesia it is red and 3, and so on. So a normal stress echocardiographic study.
Dr. Anil, please conclude the session.
Yes, sir.
Please conclude the session. Please conclude the talk.
So the time is getting over, and we have other topics also.
Just 1 minute. Just 1 minute.
Sure.
So peak dose valve motion score index 1.0, and that confers a benign prognosis of 0.9% event rate per year. Peak dose valve motion score index is more than 1.7, and ejection fraction less than independent markers of patients at high risk of an adverse clinical outcome. Anyway, this video is not moving here. So, but I will like to convey you that this is a 60-year male had anterior wall infarction, sent for viability assessment, and this is the dovitamin stress echo test. It's showing you the all 4 stages in different phase. Once again, you will agree with me. This is the apical 4-chamber view. This patient has scar tissue, and this particular patient is going to have no amount of benefit, whatever the kind of revascularization may be. So conclusion, dovitamin stress echo is an effective method of evaluation of myocardial ischemia, particularly if performed by experienced operator. Safe, relatively inexpensive, and rapidly performed method of stress testing. It differentiates viable from the scar myocardium. Thank you.
Thank you, sir. That was a nice talk on dovitamin stress echocardiography, which we are using now not only in CAD but also for valvular heart diseases and risk stratification. So thank you for the talk. And we'd like to conclude the session on echocardiography and felicitate our speaker.
Thank you so much, sir. Thank you so much, all the chairperson. So there is an arrangement of lunch, so I would request all of you to kindly have the lunch, and after that we will begin our next session. Thank you so much, everyone. Thank you so much.
नहीं 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 आवाज एक तो माइक दीजिए ना, देखिए ना, नहीं नहीं दीजिए ना एक तो माइक हमको, देखो साउंड बॉक्स दीजिए ना वहां पर, साउंड बॉक्स खोलिए, गेट खोलिए, आवाज जा रही है, खाना खाइए, कार्ड नहीं वहां दिए, बैठे हुए वहां पर है, आइए 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 ना, अरे यहाँ पर बैठिए, सुनिए ना, वहां पर सुनील जी बैठे हैं देने के लिए, कूपन देने के लिए, सुनील जी बैठे हुए हैं, आइए जिनको लेना आइए, देखिए सुनील जी वहां बैठे हुए हैं, देखिए वहां कुर्सी लेकर कूपन वहीं दे रहे हैं सबको यहाँ पर बैठे, क्या सुनिए अजय सर को, हाँ हेलो हेलो, आवाज आ रही है, कहा भाई बॉक्स दीजिए इधर, आप सबों से अनुरोध है कृपया लंच जल्दी फिनिश करें, हम लोग आधा घंटा लेट चल रहे हैं, बहुत इंपॉर्टेंट सेशन है कार्डियक सर्जरी, कार्डियक सर्जन को मत इग्नोर कीजिए, कार्डियक सर्जन के भी लेक्चर्स में उतनी ही क्राउड होनी चाहिए जितने मेडिसिन के लेक्चर में हुई है, सबों से आग्रह है कि अपना लंच फिनिश करके हॉल में एकत्रित हों, कार्डियक सर्जरी पे लेक्चर होने जा रहा है। हम लोग 5 मिनट में नेक्स्ट सेशन शुरू करने जा रहे हैं। आवाज नहीं जा रही है? अरे भाई इधर
उधर नहीं जा रहा है।
अरे कोई बॉक्स नहीं उधर करेगा, कैसे आवाज आएगी? हाँ ये तो, अरे उस रूम में आवाजें नहीं जाती जहां आवाज। हेलो 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 हेलो, आवाज आ रही है? यू ऑल आर रिक्वेस्टेड टू काइंडली कम इन हॉल. वी आर गोइंग टू स्टार्ट आवर नेक्स्ट सेशन वेरी सून. सेशन ऑन कार्डियक सर्जरी. जा रहा देखो, सुनो आवाज नहीं आ रहा है.
आप जाके देखिए, हम बोलते हैं, आपका नाम भी बोलेंगे तो नहीं जाएगा. हेलो 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 हेलो, अरविंद सर. सर वो पार्टीशन दिया हुआ है, नहीं खुलेगा.
खुलेगा. खोलो.
हाँ.
खोले. हेलो, अब देखो तो, गेट खोलो तो. खोलो. अब जाओ तो सुनो तो आवाज. हेलो. हाँ. Very soon we are going to start our next session. Next session is on cardiac surgery. You all are respected delegates. If you have finished your lunch, please come in hall. Very soon, we are already very late. We have to start our next session.
आपसे ले लिए सर.
In a moment, we will begin our next session. So I would request all the guests, all the delegates, kindly join us here in this hall. Soon we will begin our next session. So I would request all the delegates, kindly be seated, kindly join us in the hall. Our next session is cardiac surgery, and our eminent speakers are Dr. Sanjay Kumar and Dr. S.K. Sinha. All the delegates, all the guests, I'm requesting all of you, kindly join us here in this hall. Soon we will begin our next session, and our next session is cardiac surgery. If you are done with your lunch, I will request all the guests kindly join us here in this hall. Soon we will begin our next session. In a moment, we're gonna begin the session. Ladies and gentlemen, we are ready to begin the next session, cardiac surgery. Before calling the speakers, first of all, I would like to invite our chairperson and chairperson of this session are Dr. Ranjan Kumar, Dr. Arvind Kumar, IGIC, Dr. H.N. Prasad, Sir, Dr. Sanjeev Kumar, Dr. Manmohan Sir, Dr. Sahil Avnish, Dr. Kunal Krishna, Dr. Santosh Pandey, and Dr. Amir Kazmi. Dr. Amir Kazmi. I'd request all the chairperson to chair. We're going to begin our next session, cardiac surgery. And the first speaker of this session is Dr. Sanjay Kumar. Sir, I request you to kindly address us. Ladies and gentlemen, distinguished guests, kindly pay attention. We are going to start our next session. Our chairpersons are be seated. And today we have as a speaker Dr. Sanjay Kumar, sir.
Good afternoon, everybody. Now we'll like to start the post-lunch session. A difficult one to begin with, considering the full stomach of everybody, which invites a good sleep. But this is what cardiac surgery is. You can never sleep. You have to be on your toes at any time. So with this, we introduce our first speaker, Dr. Sanjay Kumar, sir, from Dr. Sanjay Kumar, sir. He is HOD and consultant cardiac surgery in Medanta Hospital, Patna. And he'll be talking on this topic, current statuses of valves. So over to you.
Good evening, everybody. And thank you very much, Kunal, and the chairperson for inviting me. And thank you very much, Team Cardicon, for inviting me here. So, status of valve surgery as such, this topic is very, even as a cardiac surgeon, we used to discuss a lot about the ideal valves and approaches for the surgery. But still, it's an ongoing process of discussion and everything. And ultimately, it falls on the patients to what to choose and what not to choose, what he want to. So as far as epidemiology of valvular heart disease, that is changing. Most important part is the epidemiology, etiology is changing. As far as life expectancy is increasing in our country, so pattern of disease is also changing. So now we are getting more and more degenerative valvular disease as compared to rheumatic heart diseases. And like in developed countries. So as far as CDC data, percentage of death due to valvular heart disease by the valves, aortic valve most common, that is 61%. That is again going in favor of our developed countries, which showing the degenerative aortic valve diseases are more common, and that leads to the more and more cardiac deaths. As far as mitral valve is concerned, that is more morbid rather than fatal. So mortality by the mitral valve diseases are coming down. As far as historical perspective, current status can't be without historical things. And it was the development of the heart-lung machine in 1953, which led to development of the cardiac surgery. And first mechanical valve implant was done in 1962 by Albert Starr. That was a ball in case. And homograph Rose procedure evolved later on, tilting disc, and it is the bi-leaflet valves which revolutionized the therapy. And repair is not less important, rather than nowadays it is more being advocated if valve is repairable. But first mitral valve repair was Elliott and Cutler in 1923, that is a finger dilatation of mitral valve. And repair is always preferable over the replacement if feasible. That is less morbid and less mortality, and it is cost effective also, and it saves patient from the anticoagulation and its related problems. And in the future, it may be the bridge to a better valve. And what should be the timing of intervention in cases of a mitral regurgitation? Because it was a previous historical thought that the patient, once patient is dying, then they used to send the patient for the cardiac surgery. But as far as cardiac physiology and medication, pharmacological intervention and critical care has improved, the mortality from a cardiac surgery has come down markedly. I don't think any center must be having a mortality of more than 4% or 5% with the valvular heart disease. So you can see in the natural history, this is the optimum time of the surgery, not the LV dilation. Once the LV dilatation starts, LV dysfunction, that is not the ideal time. This is the ideal time to get it operated, because it affects the patient's survival and on the follow-up. Like if we operate the patient in NYHA class 1 and 2, then you can see that 20-year survival is approximately 80%. But when we operate these patients in NYHA class 3 and 4, then you can see the less than 20% survival at the 20 years. So timing is very important when to refer the patient for a surgery. And one dilemma is always there, survival after the mechanical and bioprosthetic valve, which valve to choose, especially when the age of the patient is between 50 to 60 and 70, you can say, in the developed countries. All patients who are aged 50 to 69, this study showing that mechanical valves are having a better survival. At the only problem is the bleeding, but that also takes care on the survival benefit with the mechanical valve. We are talking about within this age group, 50 to 70. And bleeding, you can see, bleeding rate is definitely with the mechanical valve, it's high, but aortic valve re-intervention rate is very less in cases of the mechanical valve. So, and re-intervention rate in bioprosthetic valve, it's very high. And heart failure, hospitalization, and stroke, there is no gross difference as such. And these are the American Heart Association guidelines, which favors the below 50. There is no problem. Always we recommend mechanical valve, but after 70 or 65, there is no problem. We recommend the bioprosthetic valve. But in between, because a lot of patients we used to get in this age group, so the tissue valve has taken a bit advantage over the mechanical valve, but data is showing that the mechanical survival with the mechanical valve is better as compared to the bioprosthetic valve. Because, and this is the life expectancy as we compare with the developed countries. In India, this is the blue line, it is approximately 70 years. And while with the mechanical valves, bleeding rate goes up as the age of the patient advancing. So what is the ideal valve? So what is the durability of the tissue valve? So we'll go further, and this is the life journey of a mechanical valve patient. If we put a patient at the age of 50 with the mechanical valve, then there is a 4% probability of non-structural dysfunction, that is pannus formation, and at the age of 53, this endocarditis, major bleeding, thrombosis, stroke, and major acute pulmonary embolism. So by the age of 65, reoperation and no option to the switch over to transcatheter valve. So this is a disadvantage of using a mechanical valve between the 50 to 70. While in the bioprosthetic valve, you can see if we put the patient on a bioprosthetic valve, the non-structural dysfunction, that is approximately same, and endocarditis, that is same. But in cases of if patient is requiring re-intervention, then we have an option of valve-in-valve transcatheter interventions later on. But definitely our subset of the socio-economical subset of the patient is not that, but we are talking scientifically. So in the bioprosthetic valve, porcine versus pericardial valve. Definitely pericardial valve has a edge over the porcine valve. You can see in the diagram that these red dots are of pericardial valve, while both are porcine valves. You can see the survival, structural degeneration free. And this is the probability of explant for the structural valve degeneration, especially when reimplanted at the age of 40, then chances of SVD is very high. And you can see it starts after 7 to 10 years, and when a patient's age is less, then it starts early, and if patient's age is 60 or 65, then chances is less than 10% or so. So what is the Indian status? Total aortic valve cases, total valvular cases is being performed approximately 50 to 60,000 within the India, in which 47% is aortic valve replacement, mechanical valve accounts for 57%, and tissue valves approximately 30%. And TAVR, it's rapidly growing with the rate of approximately 14%. In cases of mitral valve replacement, total 53%, mechanical 65%, tissue valve 19%, and repair is 16%. So AVR is more common in a private sector, and MVR is more common in the government sector due to the socio-economical background of the patients and disease pattern. And TAVR is increasing rapidly in India, and repair includes the mitral and tricuspid valve, where the tricuspid repair rate is now, it is picking up. So a spike in mitral valve replacement in India is uncommon than in Western countries. And this is the database for, this is the bar chart for the TAVR centers and the TAVR procedures. You can see in Japan, it's static, like it is growing, but not at as spiky as US pattern. So in India also, we are going to follow this because of, and you can see the surgical aortic valve replacement versus transcatheter aortic valve replacement. This is the surgical. So all procedure is going down. Number of procedures are going down, but in the cases of TAVR, it is increasing. So you can see the very long-term outcomes and degenerative rate, especially if we will implant the patient at the with the bioprosthetic valve at the age of 50, then chances of explant is approximately 50%, and same here. But when we implant later on ages, then chances of SVD is less. So what are contributory factors for the upcoming tissue valves is the modern anti-calcification treatments, which they are going to make it less prone to the structural valve deterioration. And especially now Inspirus Regilia tissue has come, that is showing approximately 20 years SVD free, and this is Percival Plus, that is a stentless with the stent sutureless valve. And these are the current status which are available. This is the Regilia, and this is Percival Plus, and these are porcine and other valves available in the market. So what is the imagine one patient came at the age of 80 years with the severe AS. So what should be the ideal intervention at the age of 80? It can be TAVR. There is no confusion. And if degenerate, then valve-in-valve or surgical implantation is followed by SAVR. But 65 to 80 years, TAVR and SAVR. But TAVR is only when patient is not fit for surgical intervention. But surgery is always best will come. And apart from this dilemma, there is a concept of heart team has been already approved by the American College of Cardiology, which includes the cardiologist, cardiac surgeon, anesthesiologist, and imaging specialist and gerontologist to evaluate the patient and give the best. To conclude, in the patient age 50 to 70 years who underwent surgical AVR, survival was better with patient who received the mechanical valve as compared to the tissue valves. So definitely in the newer generation, bioprosthetic valve with the improved anti-calcification treatment like Inspirus Resilia and Percival, these are having the enhanced durability over the valves. And with the valve-in-valve enabled valve is likely to be the future proof to avoid any surgical reintervention. At the 60 years, maybe the cutoff age for the putting the bioprosthetic valve, less than 60, better to put a mechanical valve. And the lower limit should be remain the 50 in view of and approaches to valve replacement. There are various approaches, standard open heart surgery like sternotomy, but now minimal access surgery has coming up, and with the robot assisted cardiac surgery and transcatheter valves, and as well as endoscopically valve replacements. And this is the cases of one case we did. And TAVI in low risk patient, there's a big no as future indication of TAVI in a low risk patient, that is not indicated as because results of surgical AVR is better as compared to the transcatheter valves. Thank you.
Hello. Next speaker. Yeah, our next speaker is Dr. S.K. Sinha. Needs no introduction. He is coming to Bihar since a long time. He has established cardiac surgery and educated a lot of people who are on the stage, and also operated a lot of patients from Bihar. He is practicing in Delhi. So over to sir.
Good afternoon, and after lunch, I do not think I should bore you much with various things. Now coming to the CABG operation is still one of the most commonly performed procedures with equally matched long-term and short-term results. The results have become better. With the boom in catheter-based interventions, the surgeons also had to innovate because you have to make it better for the patient's appeal. So what we did total arterial revascularization, which has probably a very long-term results. We stopped using the heart-lung machine. In majority of the cases, we innovated off-pump surgery. Then again, we also had a minimally invasive procedure so that the patient says, yes, my scar is less. And the scar on the leg becomes very long, so endoscopic vein harvesting methods were started. Now coming to the CABG versus PCI, if you see the various trials with the bare metal stent, there is a long trials, and of course I don't think anybody uses the bare metal stents now. So what was the analysis results? Long-term mortality, though, was similar after CABG and PCI in majority cases, but CABG is a better option in patients with diabetes who are 65 years or older, because mortality in this subgroup was better with CABG. Now coming to when the drug-eluting stents came, two of the largest trials of CABG versus PCI was ever performed, the Freedom trial and the Syntax trial. There were some other trials also like IRASI 1 and 2. Drug-eluting stents, what this said, that death and subsequent revascularization within 18 months according to the number of disease vessels and clinical subsets. They analyzed everything, single vessel disease, diabetes, multi-vessel disease and all. CABG, the conclusion was that CABG resulted in a lower rates of MACE as compared to the PCI with drug-eluting stents, and especially with patients with multi-vessel and left main disease. People started stenting even left mains and multi-vessel disease and all. But what happened? The results, the patients came for repeat revascularization. So the conclusion was that CABG remains the standard of care for patients with 3 vessels or the left main disease as compared to the PCI. Even in the Lancet with Syntax score 2, the long-term mortality, they said a 4-year mortality in patients with complex coronary artery disease can be well predicted by combination of anatomical and clinical factors in Syntax score 2. Again, what was the result? CABG provided better angina relief at 5 years, primarily due to an advantage among patients with anatomical complex disease as reflected by the high Syntax score. So based on these all things, the patient with ischemic heart disease, the class 1 recommendation was in left ventricular function and severe LV dysfunction. It was important that you go and interfere, and especially this interference was in the form of CABG. Left main with significant left main stenosis, CABG is always recommended. You may find cardiologists who will say, I can dilate a left main, I can dilate this one. But in my opinion, over the years of experience, I always say, if you have a left main, please go for CABG. Again, if there is a complication of ischemic heart disease like ventricular septal rupture, mitral valve insufficiency, free wall rupture, these all come into the purview of CABG. Patients with complex vessels, triple vessel disease, severely calcific vessels, low ejection fraction, these are the places where even cardiologists say that if you go for a CABG, it will be better. The guiding principle should be that CABG improves survival compared with PCI in patients with left main and complex CAD. So coming to that, what I always show is these are the places, the yellow lines like single vessel disease, long lesions, small vessel disease, PCI can be done. But when it comes to multi-vessel disease, a bifurcation disease, chronic total occlusions, and left main disease, these are in the purview of the surgeons. And if you remember this, you always give the patient the best chances. Now coming to what the surgeons have to face in this era of drug-eluting stents. We have to do more complicated cases. Rarely you'll find a surgeon getting a single vessel disease or a simple double vessel disease. They are all stented. We have to do more complicated cases, acute emergencies, patient in cardiogenic shock, patients with left ventricular failure, diffuse vessels, diabetics, renal failures, critical left main, and of course, every week or so, I'll be getting a stented blocked vessel. So what we do is, the preference will be a total arterial revascularization. That can be done by using both the internal mammary arteries and the radial artery. What my preference is to make a composite conduit, either internal mammary anastomose to the left internal mammary, the right internal mammary, or the radial anastomose to the left internal mammary, causing a T, and then you graft all the vessels with that. Unfortunately, the type of patients now what I am getting, it's becoming more and more difficult to use a total arterial, because rarely I get a patient whose ejection fraction is more than 30%. Majority of the patients what I am operating is somewhere between 25 to 30% or 30 to 35%. They may have had a previous stenting. Again, after the stent blocks the ejection fraction, for reasons unknown, the ejection fraction drops drastically. Bilateral mammary usage is always better. Here in the side you can see that both the mammaries have been dissected, and after that what I have made is a T. If you see here, I don't know whether this is true. Now if you see this, I don't know what is नहीं काम करता है. No. Okay, it's a pointer, but you can see that we have made a T. Initially, the radial artery was taken and anastomosed to that, and once you have completed the T, by the use of octopus, the first anastomosis, what you can see, you can make in between the two pots, the Lima to LAD anastomosis is being done. Where the plastic bulldog is being seen, that is the site of the anastomosis with the radial artery. In this case, the radial artery is used to make a composite graft. And after that, the bulldog is advanced, and the second graft you can see is being done, then the third graft, and so subsequently you feel that a circle type of thing has been made. What you can see, the blue one is a shunt which is there so that the blood is not flowing, especially when you are doing a beating heart. So this is roughly more or less, I think this is the third anastomosis is yet to be done. So you can do at least 2 or 3 anastomosis. Nowadays, usually I'll do only 2 anastomosis with this. So if you have a revascularization to reduce the cardiovascular events as compared to the medical therapy, it is better to go for a surgery in patients with refractory angina despite medical therapy with significant coronary artery stenosis, unable to revascularization. Revascularization is recommended to improve the symptoms. In diabetes, it is always preferred to do a CABG because the repeat revascularization, if you do a stent, is very high. So CABG compared to PCI has a benefit in mortality and repeat revascularization in diabetics. The problem for the surgeon in diabetes are these are younger patients. We have poor caliber target vessels, multi-vessel CAD, friable tissues. Nephrological and neurological compromise is quite a bit there. So seeing all these things, if you have a complicated patient, the surgeon is always the answer. CABG will always give you a better long-term results, especially in left main, triple vessel disease, calcific arteries, diabetic individuals, and patients with renal compromise. And wherever possible, a total arterial revascularization should be the goal for most of the surgeons. Thank you.
Thank you, sir. That was an illustrious presentation about CABG. I'd like to ask a question to Sinha, sir. Sir, with your vast experience, I would like to know just for how long will you wait for CABG in a patient who had a recent ACS? for how long will you wait before you can proceed with Yes, sir.
See, the ideal thing is most of these ACS patients give you the worst type of nightmares in between the 3rd to 6th day. If you operate between these two, you expect that you will not have a very good result, especially during surgery and immediate post-op. They give you a lot of trouble. If you operate within the first 24 hours or first, say, 48 hours, usually they are more amenable to surgery and you can get away very easily. If you have a ACS, and especially an infarct with a lot of hemodynamic compromise, in these cases, my suggestion will be to put a IABP and wait for at least 48 hours and then do the surgery. They always do better.
Thank you, sir. Small question to Sanjay, sir. So you were talking about recent advances in valve surgeries. So if we consider redo valve surgeries, so what is your take like in surgical experience, immediate and post-op, immediate post-op, for when you compare a patient with valve repair, where a ring was used, a tissue valve or a mechanical valve, which is complexity-wise, what is your take like?
Definitely, repairing a valve is a definitely complex procedure, and easiest way.
No, I want to ask, like, if you have to explant a valve, either ring, a mechanical valve, or a tissue valve, means what is the complexity?
Tissue valve or mechanical are almost same. Repair is just like a primary surgery. We don't consider repair as a technically, apart from opening a chest, there is nothing like.
No, do you have to take out that ring, or you leave that ring in that?
You have to take out that ring. The ring comes out very easily.
Just last question, one question from me. Dr. Sanjay, many times when echocardiograms are excellent normal ejection fraction and patient undergone mitral valve replacement, sometimes we find post-operative markedly reduction in the ejection fraction. Patient becomes severe LV dysfunction. Prior LV function was absolutely normal. So what is the reason for sudden deterioration of LV dysfunction?
There are multiple reasons for sudden deterioration. It starts with the disease itself, and technically also, it's how was the preservation, myocardial preservation during the surgery, and what about the apparatus have been preserved or not, mitral valve apparatus. At least we recommend to preserve a posterior caudal structures with the replacement. And if we operate these patients in rheumatic heart diseases, if rheumatic activity is ongoing, then these patients behave very badly in post-op period in form of severe LV dysfunction, and that is very important. So rheumatic activities should be negative before taking up the patient for the surgery. And technical aspects, we should respect the tissue, and we should preserve as tissue as we can with the safety, and we should take care of the cardioplegia with the time.
Okay, Dr. Arvind, this may be due to the reverse remodeling sometimes. As organized secretary requests, we are running short of time due to positive time, so there is no more questions, please.
Regurgitant lesions.
Thank you, speakers, very much.
Thank you, speakers. Thank you, our chairperson. And now I request all the chairperson to felicitate our speakers with this shawl. Our speakers are Dr. Sanjay Kumar and Dr. S.K. Sinha, sir. Dr. S.K. Sinha, sir, is arrived from Delhi here to attend the session. And in our next session, our chairperson are Dr. Shyam and Prasad, sir, Dr. Dinesh Kumar Sinha, Dr. P.K. Sinha, Dr. S.B. Prasad, Dr. Mrityunjay Kumar Singh, Dr. Abhishek, Dr. Pramod Kumar, Dr. Ashish Kumar Golwara, Dr. Jaimala Mishra. And our first speaker of this session is Dr. Nasser Abdali. He's from Patna only. Sir, it's over to you now. And one more chairperson, I would request you, sir, to join us. Dr. Silva, sir, please join us. Ma'am, please join us. My bad. Dr. Silva.
Good afternoon. It's very heartening to see such a huge crowd. So without wasting a lot of time, because already we are late, I will stick to the topic, and it's an interesting topic. Long-term antiplatelet anticoagulant after ACS or PCI, what and how long? So in the first two slides, I will be discussing why we need antiplatelet. Basically, when we have an ACS, there is a plaque rupture or there is a thrombus load. So to reduce thrombus burden and flow obstruction, we need antiplatelets. Again, if we are doing a PCI, we use a balloon, and with a balloon or a stent, we can cause an iatrogenic disruption or distal embolization of thrombus or side branch occlusion. Again, stent itself is thrombogenic material. Any disruption in the vascular wall cause thrombogenicity. So also to prevent stent thrombosis, we need antiplatelet. And now the second question is that we are using antiplatelet, so how long we have to use it? So if we see this graph, here we can very well see that the local ischemic events, it's maximum up till 3 months, and then it steadily declines. Local ischemic events usually cause, as I have told in the previous slide, because of the plaque rupture and the iatrogenic damage to the vessel wall. Again, the plaque progression and destabilization also, it slowly declines, and till 6 months it causes a risk, and then it steadily declines over time. Also, the prevention of systemic and ischemic events, when we do a procedure, what we do, we go through the vessels and we can disrupt any plaque, we can disrupt any smaller plaque in the larger vessels also that can cause a stroke or any other sort of other vascular complications other than MI. So it is also to prevent this antiplatelet, also prevent this thing also. So this also steadily declines with time. And bleeding is maximum when we do a procedure, because we use antiplatelet also, we use anticoagulant also. And sometimes we do a rescue PCI, so we use a fibrinolytic also. So if we see this graph, 3 months is a very crucial phase. So 3 months, all the major hemodynamic and vascular complications and changes that occurs during this 3 months. So this 3 months should be targeted very appropriately. So this is a graph, this is a summary basically, using anticoagulation and antiplatelet in both STEMI and NSTEMI. Either we are going for a PCI or we are not going for a PCI. So any ACS we have to give, it's a recommendation that dual antiplatelet should be given for at least 1 year period, whether you undergo a PCI or you do not undergo a PCI. But every patient is different. So since we are now undertaking very high risk plasties, even in patients having much comorbid condition, so we have to individualize our approach. And this individualization should be based on the recommendations and what the major trials show us. So in any STEMI patients, unfractionated heparin should be preferred if going for PCI, because unfractionated heparin is a short half-life. We can very well switch on to, we can do the procedure, we can titrate accordingly to the, regarding the APTT, anticoagulation time. Then prasugrel and ticagrelor is preferred antiplatelet agent than clopidogrel in STEMI patients. And also the recent trial, the ESA React 5 trial has shown then that in patients with NSTEMI or STEMI, if we are using prasugrel on table, it is better than if you are using ticagrelor previously, before taking into the lab. And then after 1 year time, we can switch on to a monotherapy, that is aspirin alone. So directly coming to the guidelines, what the American Heart Association says, that in patient with PCI, a loading dose of aspirin, that is 160 to 325 milligram, is recommended. And then the continuation dose is 75 to 100 milligram. In patients with ACS undergoing PCI, a loading dose of P2Y12 inhibitor, that is a second antiplatelet, should be given. And in stable ischemic heart disease, clopidogrel is preferred. In NSTEMI or in patients having ST elevation MI, either ticagrelor or prasugrel should be preferred. We can also use IV canagloril in very high ischemic risk patients. But in patient having PCI or having history of stroke or TIA, prasugrel should not be given. Anticoagulation, again, in patient undergoing PCI, IV intravenous unfractionated heparin is used to reduce ischemic events. And if patient is having heparin-induced thrombocytopenia, we can very well use bivalirudin or agratoban in place of unfractionated heparin. In patient with therapeutic subcutaneous heparin, in whom last dose was administered within 12 hours of PCI. This is important because most of the times what we do, patient is admitted, we put it on unfractionated, on enoxaparin, and at times we take it within 12 hours, we take that patient to the lab. So ideally patient, if we are planning a patient for a PCI, it is better to use unfractionated heparin than using enoxaparin. So this is the summary of basically a patient undergoing PCI, how we'll use the antiplatelet. So in stable ischemic heart disease, clopidogrel is the drug of choice as a second antiplatelet other than aspirin. We have to give it for 6 months, that is class 1 indication. But if the patient is having a high bleeding risk, there are several protocols, several calculators that we can predict which patients are having high bleeding risk. In the coming slide, I will discuss it. And if the patient is having a high bleeding risk, we can discontinue it after 1 to 3 months. And if no high risk bleeding risk is there, and if DAPT is another score that I will discuss in the coming slide, is more than 2, so we can prolong it for a period of a year and so. But 6 months period we have to give dual antiplatelet in stable ischemic heart disease. In bare metal stent, it is rarely used. So if a patient suppose is planned for surgery, 1 month or 2 months he is having a cancer or something like that, and it is inevitable surgery, so we can use bare metal stent also. If a patient has, because we have to give antiplatelet, do DAPT for 1 month only. In all the ACS patient, we have to give it for 12 months, it is recommended. But again, we can titrate it according, if the patient is having high bleeding risk, we can discontinue it after 3, 6 or after 1 year. That again I will discuss what are the criteria and what subset of patient we can discontinue it. Again, if a patient is having atrial fibrillation and the patient has to undergo a PCI, so we have to give dual antiplatelet plus an anticoagulant. And in anticoagulant, NOACs is preferred in the dose apixaban 5 mg twice daily, or dabigatran 110 mg, or rivaroxaban 15 mg once daily, or 2.5 mg BD in some trials, COMPASS trials and all. 2.5 mg BD is also sufficient. So at least for 1 week we have to give 3 drugs, an anticoagulant and 2 antiplatelets. And then we can use a clopidogrel preferably and an anticoagulant for a longer period of time, that is for 6 months to 1 year, depending on the ischemic versus bleeding risk. Again, if the patient is undergoing CABG, so we have to initiate aspirin within 6 hours, 100 to 325 mg post-operatively, and continue indefinitely. Trials have shown that it has reduced saphenous venous graft occlusion and adverse cardiovascular events. Again, in selected patient undergoing CABG, that is off pump or high syntax score, we can initiate DAPT, but it is also class 2B indication. Seeing on the high ischemic risk, we can initiate a dual antiplatelet therapy, and some trials have shown that improved vein graft potency compared with aspirin alone. So what are the various criteria? So these are the 2 scores which we can calculate the ischemic risk and in which subset of patient we have to use a lower duration of therapy. So there are 2 scores, DAPT score and precise DAPT score. So precise DAPT score is based on the 6 criteria: hemoglobin, WBC, age, creatinine clearance, prior bleeding, and the score point is between 0 to 100. If a score is more than 25, that means patient is having a high bleeding risk. So we have to give a shorter duration of DAPT, either 6 months or 3 months, depending on what the score comes. If the score is less than 25, we have to give at least for 1 year, and we can even prolong, because in some trials, Pegasus, TIMI 54 and all, they have shown that low dose of ticagrelor when prolonged up till 30 months have shown, 1.5 years have shown benefit as compared to 1 year therapy. Again, this is another score, DAPT score. It was previously used. Now most of the time precise DAPT is used. So in this, various criteria are there. Score, if it is more than 2, we have to give a longer DAPT, and if less than 2, a standard DAPT. This one slide is basically the European guidelines. Again, most of the things are same. I have discussed nothing very much different. In stable for 6 months, in NST and STACS, it is for 12 months. And again, for if high bleeding risk is there, it's 6 months and 3 months. Accordingly, we can see here. And this is the this is a big graph. I'm not going to discuss much in detail, but there are 2 criteria developed by the European Society of Cardiology. One is Academic Research Consortium High Bleeding Risk Definition. So in this, at least 1 major and 2 minor criteria, if it is there, so they are the high bleeding risk group. In these patients, we have to give antiplatelet for a shorter duration, that is in stable ischemic heart disease, either for 1 month or 3 months, or in ACS either for 6 months, 3 months or 6 months. And again, high ischemic risk definition. So these are some points. Technical aspects I'd like to discuss, because the cardiologists do, at least when we are implanting more than 3 stents or 3 stents or 3 lesions, we treat if stent length is more than 60 mm, or there is history of complex revascularization, that is left main, bifurcation stenting, CTO or stenting of large patent vessel, or history of previous stent thrombosis. In these patients, we have to use DAPT for a longer duration, that is ideally for a year, and we can prolong it to 18 months. So by this I conclude my slide. Thank you.
Thank you, Dr. Nasser Abdali, for your brilliant talk. Due to constraint of time, no question, please. Now we are moving to ahead. Next topic is newer guidelines by ESC 2023 over acute coronary syndrome. Our next speaker is Dr. Nishant Tripathi. Please, over to Dr. Tripathi.
Good afternoon, everyone. Thank you, chairpersons, and thank you, organizing committee, for giving me an opportunity to speak in this conference. So most of the things have been made simpler by Dr. Nasser in his previous talk regarding antiplatelets and antithrombotic therapy in acute coronary syndrome. So recently there was a newer guideline, so the people over here wanted me to talk about what are the new things. So I will only focus on the new things. Firstly, for the first time, the ESC has combined all STEMI and non-STEMI in a single guideline. It may not matter to us, but there, because everything is guideline based, so for them it is a very big thing, because they have merged both STEMI and non-STEMI together, made it very simple. So for physicians in European countries, it's a very big thing for them, because it has made their life simpler. Also, it provides a comprehensive overview of management of patients from diagnosis to initial presentation, long-term management after that. So whenever we manage ACS, the one term that we must remember is the first medical contact, because he is the first person who sees a patient with chest pain. He may be a village physician, he may be a general physician, surgeon, he may be the patient may come to hospital, but the first person who is seeing a patient with suspected ACS is a very important person. We do not follow the strict guidelines, but for them, first medical contact is an important person, and whenever that a person of chest pain comes, he has to think. So now they have come up with a concept, think ACS, what he has to do. So ACS is A for abnormal ECG, C is the clinical contact. So ECG has to be done in 10 minutes after presentation. So whoever the patient is going to with chest pain, he has to do an ECG within 10 minutes of presentation. And if it is abnormal, he has to think on the lines of ACS. Then C is clinical context. What are the differential diagnoses? He has to examine the patient. Is the chest pain cardiac in origin, or it can be a non-cardiac chest pain? And then he has to do some test for that, and what is the stability of the patient. So ACS, any physician who is seeing the patient with chest pain, he has to think on this line. So think ACS. This is one thing which has come up. Then they have come up with a working diagnosis of ACS, which is nothing but only an ECG based diagnosis. You don't have to do anything else. So patient of chest pain, if ACG is showing some abnormalities, which suspecting cardiac ischemia, you have a working diagnosis of ACS. If it is ST elevation, you have to follow the guidelines of STEMI management. If it is non-ST elevation, then you have to follow non-ST elevation. So you don't have to wait for some further testing to manage these patients. So this is a working diagnosis of acute coronary syndrome. Final diagnosis obviously always be made by further investigations like troponins, angiography, and imaging. And what will be the final diagnosis? Then you can label it as STEMI, non-STEMI, unstable angina, or non-ACS. But the first working diagnosis should be either a STEMI or a non-STEMI. And you have to manage it on that line. For STEMI, guidelines have not changed much. It is still primary angioplasty within 120 minutes if possible. So the patient, you see a patient and you think that within 120 minutes an angioplasty can be done. It is still the gold standard of the treatment. But if you find that primary PCI within that time period is not feasible or not possible, you must fibrinolyze, thrombolize the patient. For now we have so many cath labs and so many cardiologists over here. So in our state also, the scope of primary angioplasty is expanding. But there is still too much of challenges. So in Patna, we may get a primary angioplasty within 120 minutes. For most of, in other cities, peripheries, from villages, it's not possible for them to travel to a PCI capable center. So my request to the periphery physicians will be to thrombolize these patients and then shift to a PCI capable hospital. And I'll be happy to inform that now, since I have come, like recently I've seen people are thrombolizing in peripheries also, and that is a very good thing. We should promote thrombolysis in an STEMI patient. Now, the non-STEMI is a vast spectrum. It is it can be a non-cardiac from unstable angina to very complex acute coronary syndrome. So first thing is to do a troponin. Now the focus in ESC guidelines is on high sensitivity troponin, because you remember that conventional troponin takes 6 to 8 hours to become detectable in blood. So they have come with high sensitivity troponins, which may be detectable in 1 hour, and it may rise in 2 hours. So they have come up with 0, 1 hour and 2 hour algorithm. So you do a troponin. If it is a very low initial and there is not showing a rise in 2 hours, that means you are dealing with a non-cardiac or very low risk cardiac symptom. So you rule out pathway. You have ruled out acute coronary syndrome. On the other extreme, if the initial high sensitivity troponin is very high, or the second troponin is showing a very significant rise, that means rule in, that you have confirmed the ACS diagnosis. Now you have to manage it as ACS. In between, there is an observed pathway. If you are not convinced that troponin rise is significant, then you can observe the patient for serial ECGs and serial troponins. So this is high sensitivity troponin assay. Now, once you have established the diagnosis of acute coronary syndrome, STEMI, obviously, you will think of primary PCI or fibrinolysis. Now, I am only focusing on non-ST ACS. So think of invasive strategy first, whether your patient can benefit from early invasive strategies. So who are those patients? If the patient is very high risk features like hemodynamic instability, cardiogenic shock, arrhythmias, mechanical complications, so they will not do good with medical treatment. So they need early invasive therapy. If these features are not present, only high risk features like confirmed diagnosis of ACS, positive troponin, ECG changes, which are the vast majority of patients, then and not emergent, but an early invasive strategy is preferred less than 24 hours. Initially, it used to be a class 1 indication, but now this current guideline has downgraded this indication as 2A. That means you have time to wait in these patients, try to stabilize, try to find what is the best thing you can do for this patient, and then send the patient for coronary angiogram or revascularization. Don't rush, don't shift the patient just seeing at the ECG that ECG is showing changes, referred here and referred there. Give him the basic initial treatment. And other patients, low-risk patients, only mild troponin, mild ECG changes, chest pain is not there, hemodynamically stable, that can be managed with medicines, and on high-risk suspicion tests, then only you should shift for PCI or angiogram. So in a non-STEMI patient, you should be wise, you should be thinking about the patient, not just refer him to another hospital. Antithrombotic therapy, most of the things have been discussed by Dr. Nasser. Still antiplatelet and anticoagulants are the mainstay of management. So what are the new things? There has been, as Dr. Nasser was talking about, it was about the duration of DAPT that has got significant change. Initially, we used to give DAPT for 1 year in all ACS patients. But now there is a revised indication that it can be shortened. You have to give DAPT for 3 to 6 months who are not at a very high ischemic risk. Most of the points were discussed by Nasser. So if you think that ischemic risk is not very high, you can stop dual antiplatelet at 3 or 6 months and continue on only single antiplatelet, which can be either an aspirin or a clopidogrel. Then, now recently, clopidogrel is preferred as an alternative for 2 aspirin for a long-term treatment. In high bleeding risk, DAPT can be stopped at 1 month only, and then on a single antiplatelet agent, you can follow him. But in the first 30 days, you should not withhold dual antiplatelet after an ACS event. Similarly, in CABG, it is recommended to resume DAPT after surgery. As Sir was saying, only in the initial part, you have to stop it. One word about cangrelor. It is a new molecule which is being used in cath lab. It is an intravenous clopidogrel, you can say P2Y12 inhibitor. It's the same mechanism of action, but it is intravenous, very fast. So it is used before PCI. But the problem is, no trial has shown benefit of cangrelor if the patient is already receiving clopidogrel or another P2Y12 inhibitor, because the effect of cangrelor is diminished in those patients. So it can be only used when the patient has not received any P2Y12 inhibitor. So remember this, it has to be used in case-to-case basis. Routine use of cangrelor should not be done. Only in clopidogrel naive patient who, especially emergency PCI you are doing, ventilator is there, you cannot give orally, then this drug should be used in PCI. Regarding anticoagulants, still heparin is the class 1 indication, no change in those guidelines. Unfractionated heparin is mainstay. In European countries, bivalirudin, fondaparinux is used to reduce the bleeding risk. Bivalirudin is not available. Fondaparinux we can use in low-risk patients. Why these things are important? Because we have to think of bleeding also. 40% of PCI patients are high bleeding risk in some of the trials, and their shorter DAPT should be important. A couple of slides about this bleeding risk, why it is important. Because the bleeding risk, initially the ischemic risk is high, and after like 1 month, bleeding risk increases. So after 1 month, you don't need potent dual antiplatelet therapy, but you have to individualize the therapy. So this is a flowchart of how to de-escalate therapies, how to reduce bleeding, like radial artery approach in PCI. We all follow that. Radial artery intervention is done, and that is good for the patients. PPI, you have to identify the high bleeding risk patients. And one thing, this slide mentions that in East Asians, bleeding risk patients are more bleeding prone. So we have to think of that also. More than ischemic, bleeding is very common, which we cardiologists tend to ignore. The GI bleeds, there are so many melinas we see in every OPD. On aspirin, patient is taking dual antiplatelet for no matter how long. Angioplasty 1857 में हुआ था, चल रहा है D-plate है. So we have to think about that also. We have to de-escalate the therapy. And revascularization, this is for interventional cardiologists. Complete revascularization is again now in focus. So it has to be done in a staged manner within the admission or within 45 days. And intravascular imaging, of course, it has a special role in patients with ACS when you are doing an intervention, especially if clear-cut culprit artery is not available. And a long-term management plan is most important part after you have managed the patient. Lipid-lowering therapy. A new thing has come, colchicine is being used in a recent trials. If the patient is not controlled on your standard medical treatment, young, premature CAD, recurrent events, colchicine is a new drug which has been found to be effective in recent trials. And ezetimibe, of course, we are using. So I am summarizing. So these are the things that has been focused in the new guidelines. Think invasive, think antithrombotic therapy, think of bleeding risk, revascularization appropriate, and secondary prevention for long-term management. Thank you.
Thank you, Dr. Nishan, for your brilliant and illustrative talk. Now, regarding question and answer, protocol will remain as such. Now, we are moving to the next topic, that is the management of cardiogenic shock. And next speaker is Dr. Ashok Kumar from Patna. Please, over to Dr. Ashok Kumar.
Good afternoon, respected chairperson, august audience, and thanks to organizing committee for giving me opportunity to talk about this dreaded situation, that is cardiogenic shock. Not for the patient only, but for the treating physician also. Because we all know that cardiogenic shock occurs in about 5 to 10% of STEMI, whereas in about 2.5% of STEMI. And urgent coronary revascularization are the only answer to save the patient prior to patient shifting into cardiogenic shock. Because almost 75% patients with cardiogenic shock secondary to MI present with multivessel disease, and this data has come from shock trial. Most of the data of cardiogenic shock came from the shock trial only. And we all know that decreasing in-hospital mortality with increasing rate of early PCI in patient with cardiogenic shock. So always try to open the closed artery as early as possible, because about 50% of patients of STEMI, which involves mainly left anterior descending artery, lined up into cardiogenic shock, but about 72% went into cardiogenic shock within 24 hours. That's why early revascularization can save the patient as well as the hospital resources also. So STEMI with multivessels and cardiogenic shock, culprit and multivessel PCI. So answer is only do stabilize the patient and do culprit vessel only PCI, not go for the complete revascularization, because that increases the chance of renal dysfunction, even mortality. These are the definition of cardiogenic shock. What it is a condition where the pumping capacity of heart decreases, that leads to decreased perfusion of the target organ and leads to end-organ hypoperfusion. And that can be clinically assessed by cool clammy extremity. If urine output less than 30 ml per hour, heart rate increases. And if we are able to measure cardiac index, that is less than 2.2, whereas pulmonary capillary wedge pressure more than 15. So these are some criteria of diagnosing cardiogenic shock. And this is staging A, B, C, D, E. Very easy to memorize, and this has been advocated by Sky later on, taken by AHA or ESC also. So stage A is all patients are of STEMI or non-STEMI is at risk of going in cardiogenic shock. When the patients develop some feature of cardiogenic shock, say if the patient is developing hypotension, but still there is no sign and symptom of hypoperfusion, they are beginning of shock. And classical shock, when the patients come with systolic blood pressure less than 90 or mean arterial pressure less than 65, it will be classified as cardiogenic shock. And this is the time where we intervene early, we can save the life. After that, when start deteriorating and ultimately slips into extremism, and that is very difficult to save, because still, even after having mechanical circulatory support device, revascularization, the mortality is hovering around 50%, even in best of the best setup with patients of MI with cardiogenic shock. So not only mortality during hospitalization is high, even after some patients, about 50% of patients which survive cardiogenic shock, they develop further complications in follow-up. So they remains in heart failure lifelong. So this is a prototype case presented with chest pain, diaphoresis, hypotension, tachycardia, cool clammy extremity. So this is a typical case of shock, but there are 6 types of shock, but this is classical example of cardiogenic shock. I'm skipping some slide due to paucity of time. So presentation might be depending upon the involvement of different organ. Mental obtundation might be a feature even when there is low cardiac output. So if the perfusion of brain is low, there might be some symptoms and renal dysfunction all. So this is very important schematic diagram. What happens after myocardial dysfunction, systolic function or earliest diastolic dysfunction occur, that may lead to increase in LVADP and that further worsen ischemia. Whereas systolic dysfunction reduces stroke volume, further cardiac output reduced, patient may went into hypotensive shock. And if the presentation of cardiogenic shock delayed, patient may develop SIRS, systemic inflammatory response. So sometime we will see the patients of cardiogenic shock with well perfused or with good pulse volume. So that has the delayed presentation of cardiogenic shock. I'm skipping the causes just to enumerate different causes. These are the ancillary tests to how to diagnose. We all know, this is the time frame, and that is very important. Whenever a patient of cardiogenic shock present in emergency, don't waste a single minute of time. Just start oxygen, establish vascular access, assess rapidly the patients. We are using CLIP classification since long, and that gives good idea, clinical judgment about the stages of cardiogenic shock, even the prognostic marker. So whenever the patients came in CLIP 4, the mortality in thrombolytic area in 70s, it was about 80%, but now it has reduced to about 50% only. So within 15 minutes, we have to establish venous access, we have to insert central line, and we have to give saline at least 20 to 30 ml per kg body weight over 30 minutes. Even though the patient blood pressure doesn't respond, we can start vasopressors. So we have lots of vasopressor we can use, we are using. So these are the different type of vasopressor agent. But first and foremost, if the mean arterial pressure is less than 60, start norepinephrine. And if it goes above 90, we can add dobutamine. So this is some clumsy slide. So this is the better slide. Cardiogenic shock, if the patient present in early shock. So we can start with IABP. Why IABP? It increases the diastolic, it causes diastolic augmentation and reduces afterload. That's why it increases the perfusion and it helps in stabilization of the patients. But it is not going to increase cardiac output. So support the patients with IABP and do cardiac catheterization. I have already said culprit vessels revascularization and stabilize the patients if stable. Pain. So the treatment is always, ESC guideline is always advocating to do immediate PCI. And all cause of mortality and renal replacement therapy is less in culprit only. So these are the some mechanical circulatory support. It has been subdivided into 2 groups, short term and long term. Here I'm talking about the short term circulatory mechanical circulatory support device. Most commonly, what we are using is IABP, but nowadays Impella has came in a bigger way. After IABP shock 2 trial, the use of IABP in cardiogenic shock has reduced because the guideline is also saying the routine use of IABP is not helpful in cardiogenic shock, but on case basis we can use it. Now Impella, but recently 2 trial. One is ISAR shock trial that has compared IABP and Impella. Of course, Impella give better stabilization, better hemodynamic support, but in terms of clinical outcome, it was equivalent to IABP. So it needs some more study. And why? These are the I have already talked. So why US FDA has given approval of Impella in cardiogenic shock on the basis of these some registry and trial. So many community study or case study has definitely shown benefit of Impella. Some organization has already shown the even in cardiogenic shock patients survival is about 70% with using of shock team and using VA ECMO along with Impella. So time will, and this is the prototype of Impella. It has 2 flow, inflow pushes in ventricle. This device has to be put across the aortic valve. And inflow will be in ventricle, that will reduce LVADP, so wall tension will be reduced. And it increases coronary perfusion, that's why O2 supply increases and O2 demand decreases. And outflow directly pumps the blood from LV to aorta. It increases cardiac output as it increases the flow. That's why the mean arterial pressure increases. So what to do? This is a bit summary slide in cardiogenic shock patients. If patients come with LV dysfunction, just start IABP or Impella if available. Impella is a bit costly and not available widely, but I think every cath lab has IABP. So put IABP and revascularize the patients. If patients improve, you can discontinue IABP. If not, and there is a respiratory distress, we can take help of VA ECMO. And if it fails, we can go for ventricular assist device, or last option is heart transplant. So cardiogenic shock remain a major challenge in acute cardiac care. An integrated approach is needed with early revascularization, inotropic support, mechanical support, eventually as a bridge to heart transplant. Multidisciplinary collaboration needed by interventional cardiologist, cardiac surgeon, intensivist, and heart failure cardiologist. So this is very important, and I think summary slide. Shock team is important, and revascularization strategy to be followed. So prompt diagnosis, invasive hemodynamic assessment. Some trial has shown it is always better to do pulmonary artery catheterization to measure the hemodynamics, early coronary angiography and revascularization. PCI strategy, always go for culprit vessels only revascularization, and other vessel to be done as a stage revascularization within same hospitalization, or you can call after some time. Mechanical circulatory support device, acuity of illness, circulatory device depend upon the different phenotype of cardiogenic shock. So we can take help of mechanical circulatory system. So to conclude, cardiogenic shock remain lethal, early revascularization improves survival, and mechanical circulatory support is redefining the treatment paradigm. Protocol-driven approach are promising. Thank you.
Thank you, Dr. Ashok, for your wonderful talk in time range. A few questions are allowed only. Please.
Thank you, Ashok sir, for wonderful discussion. I have a question with Nishant sir. You have very long experience with primary PCI, sir, especially in the patient where the thrombus load is very much high, and we are using all the conventional agent like tirofiban, but still.
Sorry, thank you. The CM is expected to come. We need some time to prepare the stage for the inauguration ceremony. Thank you very much, all the speakers and chairperson, for wonderful talks and discussion. Thank you.
I request all the chairperson to felicitate our speakers, to present the shawl. And in a moment, we will witness the gracious presence of our Chief Minister Bihar, Honorable Sir Nitish Kumar. Thank you so much, everyone. Thank you so much.
भाई मोरिया के स्टाफ्स एंड जो हमारे डेकोरेटर्स हैं काइंडली जरा स्टेज की तैयारी जल्दी फटाफट करें, समय कम है.
काम करता है मुझे है देखना इसका नहीं तेरा कुछ करना देखने के लिए भाई ये काम कर रहे हैं तू चालू करेगा तो फिर चालू करेगा
ये भी तो ऑफलाइन हाँ हाँ ये आप नहीं नहीं ये पढ़ाइएगा सपोर्ट टीचिंग इसका ओके
ग्राउंड पे इसे कौन रख दिया? अरे उसमें जाए सर,
अच्छा कितना अलाउंस करवाना सब वो गाड़ी
सर सिक्योरिटी से मिला दीजिए, सिक्योरिटी का काम है, मिला दीजिए।
बोले नहीं तो हम फिलहाल गाड़ी
थोड़ा किनारे रखवा दीजिए, नहीं कि थाना ले जाएगा, थाना ले जाएगा, अरे नहीं थोड़ा किनारे करवा दीजिए ना भाई, किसी डॉक्टर का नाम होगा उन्हीं के कॉन्फिडेंस नहीं है, गाड़ी अब थाना में कहीं भेजा कोई नहीं था।
बोलिए उनको। अच्छा ये सब जो है सिस्टम कहाँ बोलिए, ये सब हटा दीजिए।
ये वरुण से दूर वही साल है इधर मेरा कहना था ना मैडम, ये इसका सर काम है अभी इसका
है ना आपको, यहाँ खड़े होने में देख लीजिएगा कोई प्रॉब्लम नहीं। ठीक से
वो बताएंगे लोग कोडलेस माइक कोडलेस माइक है, कोडलेस माइक देगा
जैसे था
कुर्सी 3-4 कुर्सी एक्स्ट्रा नहीं रखे हैं
चाहिए क्या? हाँ, उसको बोल दिए दुबे जी और किसी को बोल देना ये चेयर है 4 कुर्सी पीछे सेम चेयर रखिए ना दुबे अरे 4 कुर्सी पीछे रखवाइए फिर मैं वही चलिए
2 ट्रे चाहिए जरा यहाँ सुनो मशीन यही रहो यहाँ 2 ट्रे चाहिए 2 ट्रे लेके आओ 2 नहीं कपड़ा लगा के जल्दी लेके आओ 1 मिनट के अंदर मेरा घर यहाँ चेयर लगाओ यहाँ पर चेयर लगाओ और 3 को लगाइए सिक्योरिटी के लिए चेयर दो छूना मत चेयर दो कप रेडी करो जल्दी लेके आओ मेरे साथ
Good evening, ladies and gentlemen. In a very short moment, we will witness the gracious presence of our Chief Minister, sir. हम चाहेंगे जोरदार तालियों के साथ करतल ध्वनि के साथ हम इनका स्वागत और अभिवादन करें। हमारे चीफ, हमारे अभिभावक, समस्त बिहार के अभिभावक, माननीय मुख्यमंत्री बिहार, इनकी महिमा उपस्थिति हमारे लिए बहुत मायने रखती है। करतल ध्वनि के साथ
अनिल कुमार सर, आपसे रिक्वेस्ट करती हूँ, अनुरोध करती हूँ कि हमारे बीच मुख्य सचिव संजीव कुमार से अनुरोध करूंगी। ठाकुर, चेयरपर्सन साइंटिफिक कमेटी, आपसे निवेदन कि आप मंच पर अपना स्थान ग्रहण करें। डॉक्टर यूएन सिंह, सेक्रेटरी सीएसआई बिहार चैप्टर, आपसे निवेदन आप मंच पर अपना स्थान ग्रहण करें। और डॉक्टर अनुप कुमार सिंह, ऑर्गेनाइजिंग सेक्रेटरी कार्डिकॉन 2023, आपसे भी अनुरोध आप मंच पर अपना स्थान ग्रहण करें। बहुत ही सुखद क्षण हम सभी के लिए कि आज कार्डिकॉन 2023 का ये 29वां सम्मेलन, जिसमें देश भर के समस्त वरिष्ठ हृदय विशेषज्ञ यहां पर उपस्थित हैं और इस सम्मेलन की शोभा बढ़ रही है माननीय मुख्यमंत्री महोदय की गरिमामय उपस्थिति से। मैं अब डॉक्टर शमा रानी आपसे अनुरोध करती हूं कि आप माननीय मुख्यमंत्री महोदय का स्वागत और सम्मान ये पुष्प गुच्छ भेंट कर करें। जोरदार तालियों के साथ हम इस सुखद क्षण के साक्षी बने। हम सभी के लिए यह पल, यह क्षण बहुत ही सुखद, समस्त बिहार वासियों के लिए। मैं चांदनी शर्मा जी आपसे अनुरोध करूंगी कि आप आदरणीय दीपक सर को आप पुष्पगुच्छ भेंट कर आप उनका सम्मान करें और उनका स्वागत करें। तालियां बजती रहनी चाहिए, ये बहुत ही सुंदर पल है हम सभी के लिए। मैं सेलिन जी आपसे अनुरोध करती हूं कि आप आदरणीय संजय कुमार सिंह सर का आप पुष्पगुच्छ भेंट कर आप उनका स्वागत और सम्मान करें। और मैं पिंकी सिन्हा जी आपसे निवेदन करती हूं कि आप हमारे आज के सम्मानित अतिथि हैं डॉक्टर विजय बंग, आप उन्हें यह पुष्पगुच्छ भेंट कर आप उनका सम्मान करें। और अब मैं सभी सम्मानित मंचासीन अतिथिगण और माननीय मुख्यमंत्री महोदय आपसे सादर अनुरोध करती हूं कि दीप प्रज्वलित कर आज के इस कार्यक्रम का हम शुभारंभ करें। हमारे भारतीय संस्कृति की ये परंपरा कि हम ईश्वर, अपने आराध्य को हम याद कर उनको नमन करके हम किसी भी कार्यक्रम का शुभारंभ करते हैं, हम इसकी शुरुआत करते हैं। माँ सरस्वती का आशीर्वाद हम सभी पर बना रहे। बिहार और देश के तमाम प्रांतों पर ईश्वरीय कृपा बनी रहे। या श्वेत पद्मासना या ब्रह्माच्युत शंकर प्रभृतिभिः देवैः सदा। और ये जलता हुआ दीपक द्योतक है, प्रतीक है अंधकार पर प्रकाश के विजय होने का। और ये जलता हुआ दीपक, ये ज्योति, इसका प्रकाश माननीय मुख्यमंत्री महोदय के व्यक्तित्व सा जो समस्त बिहार को प्रकाशमान कर रहा है। वीणा पुस्तक धारिणीं अभयदा जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्। आपका बहुत बहुत हृदय तल से आभार। मैं मंचासीन सभी सम्मानित अतिथिगण आपसे सादर अनुरोध करती हूं कि आप अपना स्थान ग्रहण करें। सभी सम्मानित अतिथियों का हम हृदय तल से आभार व्यक्त करते हैं। और अब मैं स्वागत संबोधन हेतु निवेदन करती हूं डॉक्टर सुनील कुमार सर से कि आप आए अपने संबोधन हेतु।
माननीय मुख्यमंत्री जी और दीपक बाबू और संजय बाबू और आए हुए मेरे सभी अतिथि लोग को मैं तहे दिल से स्वागत करता हूं।
आपका बहुत बहुत धन्यवाद। और अब मैं विशेष संबोधन हेतु डॉक्टर के बरुण सर आपसे अनुरोध करती हूं कि आप यहां उपस्थित हों।
आदरणीय मुख्यमंत्री जी बिहार श्री दीपक बाबू, मुख्यमंत्री के महोदय जी के प्रधान सचिव श्री संजय कुमार सिंह जी, सेक्रेटरी हेल्थ श्री विजय बांग, डॉक्टर विजय बांग, नेशनल प्रेसिडेंट सीएसआई, द ग्रेट कार्डियोलॉजिस्ट ऑफ मुंबई, मंच पर विराजमान हमारे चिकित्सक भाई, आज हम लोगों के इस आयोजन में जो कार्डियोलॉजिकल सोसाइटी ऑफ इंडिया बिहार चैप्टर की शाखा के द्वारा वार्षिकोत्सव के रूप में एक बृहत वैज्ञानिक सत्र मनाया जा रहा है, जिसका होस्ट इंदिरा गांधी हृदय रोग संस्थान पीएमसीएच कर रहा है। इंदिरा गांधी हृदय रोग संस्थान पटना कर रहा है। वार्षिक सम्मेलन का आयोजन के बारे में बहुत सी चर्चाएं हो चुकी है। मैं साहब का समय ज़्यादा नहीं लूँगा क्योंकि उनके पास समय की कमी है। आज मैं, चूंकि इंदिरा गांधी हृदय रोग संस्थान इस कार्यक्रम का होस्ट कर रहा है, इसीलिए मैं चाहूँगा, अनुमति चाहूँगा अपने मुख्य अतिथि साहब से कि मुझे 2 शब्द इंदिरा गांधी हृदय रोग संस्थान पर बोलने की अनुमति दी जाए। इंदिरा गांधी हृदय रोग की स्थापना 1970 में की गई थी। उस समय ये पीएमसीएच के अधीन था। 1982 ईस्वी में ये इंदिरा गांधी इंस्टीट्यूट ऑफ कार्डियोलॉजी एक सेपरेट एंटिटी के रूप में कार्य किया और उस समय से यह यहाँ पर हृदय, खासकर हृदय रोग, दूसरे का नहीं, रोगियों का जांच व उपचार शुरू हुआ। 1984 में यहाँ चिकित्सकों की पुनर्गठन करके, स्क्रीनिंग करके किया गया चिकित्सक, और उस दिन से लगातार यहाँ कार्य हो रहा है। उस संस्थान के प्रति बिहार की जनता, यूपी की जनता और नज़दीक के प्रदेशों की जनता का विश्वास बढ़ा। हमारे यहाँ भीड़ बढ़ी। वहाँ की चिकित्सा व्यवस्था से लोग अति प्रसन्न हुए। सभी तबके के लोग वहाँ से प्रभावित हुए। जगह कम था, जगह की कमी थी। आए दिन सरकार के पास हम लोग प्रार्थना करते रहते थे कि हम लोगों के पास जगह की कमी है, हम लोगों को बेड चाहिए। हमारे आदरणीय मुख्यमंत्री श्री नीतीश कुमार जी एक दिन अस्पताल निरीक्षण में आए और पुराने भवन के प्रथम तल पर उन्होंने घूमते हुए गए तो वो बोले कि गंगा तट पर ये एक बहुत बढ़िया स्थान है, आप लोग इसको पुराना जर्जर भवन क्यों रखे हुए हैं 2 मंजिला, इसको बड़ा बना दिया जाए। और उन्होंने उसी वक्त निर्देश दिया कि इस पर हम 10 मंजिला भवन, जो भारत वर्ष का एक अनूठा सुपर स्पेशलिटी कार्डियक हॉस्पिटल हो, खड़ा करेंगे। बस क्या था, दूसरे ही दिन साहब ने सभी संबंधित विभागीय पदाधिकारियों के साथ, आर्किटेक्ट के साथ स्वयं आए और हम लोगों को सुपुर्द कर दिए कि डॉक्टर साहब आप लोगों को जो करना है कराइए और जल्दी कीजिए। शीघ्र ही उसका शिलान्यास हुआ। उस समय स्वास्थ्य विभाग के प्रधान सचिव श्री दीपक बाबू थे, जो पॉजिटिव अप्रोच रखते हैं। उनकी भी इच्छा हुई कि साहब का निर्देश है, इसको जल्द से जल्द बना दिया जाए। कालांतर में 10 तल्ला नया भवन, बिल्कुल सेंट्रली एयर कंडीशन आजकल के स्थिति को देखते हुए हाईली स्पेशस जो कॉरपोरेट हॉस्पिटल में उस तरह का व्यवस्था नहीं है, हमारे यहाँ अत्याधुनिक सामानों से लैस 2 मॉड्यूलर ओटी, 2 कैथ लैब, 60 बेड का सीसीयू, उसके अलावे पोस्ट ऑपरेटिव रूम, पोस्ट कैथ रूम प्रारंभ हुआ। अत्याधुनिक उपकरणों से सरकार द्वारा मुख्यमंत्री जी का एक ड्रीम प्रोजेक्ट के रूप में इसे विकसित किया गया। बार बार मुख्यमंत्री जी कहीं भी हमसे भी कभी भेंट होती थी तो पूछते थे, डॉक्टर साहब अस्पतालवा क्या हुआ? हम कि जी सर हो रहा है चालू, कॉर्पोरेट टाइप का हॉस्पिटल है। और कालांतर में साहब ने 2022 के जून में इसका उद्घाटन हुआ और 6 जून 2022 से हम लोग अपने डायनेमिक पॉजिटिव अप्रोच वाले जो निदेशक महोदय हैं डॉक्टर सुनील कुमार, उनके देखरेख में, उनके मार्गदर्शन में कुछ कमियां होने के बावजूद भी हम लोगों ने काम शुरू किया और इंदिरा गांधी हृदय रोग संस्थान के सभी कर्मी, चिकित्सक, डायरेक्टर साहब को अपने गार्जियन के तरह मान करके उन्होंने कार्य प्रारंभ किया। आज उसका नतीजा है कि पुराने भवन में जहां बेड की किल्लत होती थी, हम लोगों को शिकायतें आती थी, मंत्री महोदय जी का फोन आता था, विधायक महोदय जी का फोन आता था, अपने परिचितों का, बेड दिलवा दीजिए, बेड दिलवा दीजिए। वहां हम लोगों का एक ही काम रहता था, बेड दिलवा दीजिए। आज वो समस्या नहीं है। आज वहां अत्याधुनिक उपकरणों से लैस बिहार भारत का सबसे दूसरा बड़ा अस्पताल है, जहां 251 हार्ट का रोगी है। इंडिया में केवल एक ही जगह है जहां इतना बड़ा कार्डियक सेंटर है। हमारे यहाँ कोई दूसरा चीज नहीं है, केवल कार्डियक। जो भी मरीज आता है हमारे यहाँ, उसका काम पहले होता है, कागजी कारोबार बाद में होता है। माननीय मुख्यमंत्री जी ने हमारे इस कार्य को लोगों की नसीहत दी थी कि अब अनुकरण कीजिए इंदिरा गांधी इंस्टीट्यूट को, जो काम कर मरीज का जान बचाता है, फाइल बाद में बनाता है। आप लोग अनुकरण कीजिए। हमें याद है, साहब को भी याद होगा कि सबको बताते रहते थे। आज हम लोग डॉक्टर सुनील कुमार जी जो काफी पॉजिटिव अप्रोच वाले हैं और सब लोगों की बात सुनते हुए सबको मिला जुला करके अस्पताल को बहुत ऊंचाई तक ले गए हैं और हमें आशा है कि अभी और ऊंचाई पर जाएगा। जहां पुराने भवन में हम लोगों की संख्या जितनी रहती थी, एक साल में हमने फिगर दिया है, एग्जैक्ट फिगर हम नहीं ला पाए हैं, एक साल में 1621 से 1622 का फिगर है हमारे पास, जो कि एंजियोग्राफी, एंजियोप्लास्टी और पेसमेकर की संख्या 1622 से 1623 में जस्ट डबल हो गई। यही है हमारे अस्पताल का, ये मुख्यमंत्री जी का ड्रीम प्रोजेक्ट का 10 मंजिला भवन का। आज वहां से सभी चिकित्सक हमारे काफी अनुभवी हैं, पोलाइट हैं, मरीजों के साथ उनका व्यवहार उत्तम है। हमारी परिचारिकाएं सभी अच्छी हैं, हमारे कर्मी सभी अच्छे हैं और चूंकि ये सभी अच्छे हैं, मुख्यमंत्री जी महोदय का आशीर्वाद उस अस्पताल पर सदा से रहा है, दीपक बाबू का सदा से रहा है, विभाग का सदा से रहा है और हम उम्मीद करते हैं कि हमें आगे भी रहेगा। लेकिन मैं आज अपने आदरणीय विकास पुरुष श्री नीतीश कुमार जी, मुख्यमंत्री बिहार जी को एक निवेदन करना चाहता हूं इंदिरा गांधी हृदय रोग संस्थान परिवार की ओर से कि साहब ने कहा था कि इंदिरा गांधी इंस्टीट्यूट इतना बड़ा अस्पताल हो गया, इसके लिए एक सेपरेट एंटिटी चाहिए। आज हम लोगों के पास अस्पताल जाने के लिए रोड नहीं है, पीएमसीएच होकर जाते हैं और पीएमसीएच वाले रोकते क्या है तो सभी लोगों को मालूम है। हम लोगों को मेरीन ड्राइव पर गाड़ी लगा करके वहां से पैदल इंदिरा गांधी इंस्टीट्यूट जाना पड़ता है। सभी चिकित्सकों को मैं मांग करूंगा अपने इंस्टीट्यूट के तरफ से, जनता के हित में मरीजों को आने के लिए भी, एम्बुलेंस के आने के लिए भी, कि सर का जो निर्देश था विभाग को कि उसे गंगा पथ से जोड़ दिया जाए, मैं निवेदन करता हूं इसे पूरा होना चाहिए। यही मेरी प्रार्थना है और आप आए, ये हम लोगों के लिए बहुत बड़े सौभाग्य की बात है, क्योंकि ये पहला मौका है जबकि आप किसी स्टेट कॉन्फ्रेंस में आपने शिरकत किया है, अपना आशीर्वचन दिया है। जी धन्यवाद।
आपका बहुत बहुत आभार व्यक्त करते हैं। और अब हम निवेदन करते हैं डॉक्टर सुनील कुमार सर से कि आप माननीय मुख्यमंत्री महोदय को अंग वस्त्र और स्मृति चिन्ह जो अंग वस्त्र भेंट कर हम उनका सम्मान करें। समस्त बिहार के अभिभावक, आज आपकी गरिमामय उपस्थिति हमारे लिए बहुत मायने रखती है। डॉक्टर सुनील कुमार, डॉक्टर सुनील कुमार संग माननीय मुख्यमंत्री महोदय को यह अंग वस्त्र भेंट करते हुए, और अब मैं डॉक्टर के बरुण सर से अनुरोध करती हूं कि आप प्रधान सचिव दीपक सर को आप अंग वस्त्र भेंट कर आप उनका सम्मान करें। डॉक्टर के बरुण सर से निवेदन। और अब मैं निवेदन करती हूं डॉक्टर संजीव कुमार सर से कि आप आदरणीय संजय सर का आप सम्मान करें या अंग वस्त्र भेंट करते हुए। मैं डॉक्टर अरविंद कुमार सर आपसे निवेदन करती हूं कि आप डॉक्टर विजय बंग हमारे बीच में हैं, आप उनका सम्मान करें या अंग वस्त्र भेंट करते हुए। थोड़ी तालियां बजती रहनी चाहिए, यह हम सभी के लिए बहुत ही सुखद क्षण है।
डॉक्टर मनीष मंडल जो मेडिकल सुपरिटेंडेंट हैं आईजीएमएस में, मैं चाहूँगा 2 शब्द जरा कहें।
धन्यवाद अरविंद सर। मंचासीन माननीय मुख्यमंत्री बिहार माननीय नीतीश कुमार जी सर, डॉक्टर मिस्टर दीपक सर जो हेल्थ डिपार्टमेंट में शुरू से साथ रहे हैं हम लोग के साथ और अभी तक सर साथ हैं। जो भी प्रोग्राम होता है या जो भी कार्य हेल्थ डिपार्टमेंट में होता है उस पर विशेष रुचि सर लेते हैं। माननीय संजय सर आईएएस और हम लोग सबके अभिभावक, सेक्रेटरी हेल्थ, समय समय पर सर का प्यार पूरे हेल्थ डिपार्टमेंट में सबको मिलता रहता है। सीएसआई के नेशनल प्रेसिडेंट, मंच पे बैठे डॉक्टर सुनील कुमार, आईजीआईसी के डायरेक्टर ही नहीं, हम लोग सबके अभिभावक, जो हेल्थ डिपार्टमेंट में किसी को भी कोई प्रॉब्लम हो तो एक पैर पर खड़ा रहने वाले आदमी हैं। सबका प्यार सबको मिलता रहता है इनका। सीएसआई के स्तंभ डॉक्टर अरविंद कुमार जो पहले आईजीएमएस भी थे, अब प्राइवेट प्रैक्टिस में भी हैं, लेकिन गरीबों से सर का विशेष लगाव रहता है और गरीब मरीजों के लिए विशेष तौर पे काम करते हैं, नॉर्मल काम के अलावा भी। मंचासीन जितने भी गणमान्य लोग हैं उनका मैं अभिवादन करता हूँ। मन से इतर मेदांता के डायरेक्टर डॉक्टर सिंह, मिस्टर गंगवार सर आईपीएस, मैडम छोटू जी, हम लोग सबके प्रिय नेता और गरीबों के लिए हर जगह खड़ा रहने वाले नेता, आपका अभिवादन है। हमारे आईजीआईसी के डिफरेंट फैकल्टीज़, डॉक्टर अशोक कुमार सिन्हा सर, आईजीएमएस के फैकल्टी डॉक्टर ओम कुमार, फार्माकोलॉजी के हेड ऑफ द डिपार्टमेंट हमारे डॉक्टर ललित मोहन जी यहाँ हैं, और विभिन्न जितने भी आईजीआईसी, इंदिरा गांधी कार्डियोलॉजी, इंदिरा गांधी इंस्टीट्यूट ऑफ मेडिकल साइंस, हेल्थ सेक्टर में कार्डियोलॉजी से जितने भी डॉक्टर्स हैं सबका अभिवादन मैं करता हूँ। हम लोग सब जो यहाँ हैं वो हेल्थ केयर सिस्टम के लिए, और हेल्थ केयर सिस्टम में सबसे सुप्रीम जो है वो है कार्डियोलॉजी है, क्योंकि हमें सबको पता है कि अंत में कार्डियक फेलियर से ही डेथ होती है और इसी को हम लोग को टेक केयर करना है। ये जो आज समारोह और जो सत्र है, इस सब का निचोड़ हम लोग के दिलो दिमाग में रहना चाहिए और इसकी जो अच्छाई है वो हमारे दिलो दिमाग में रहना चाहिए, ताकि इसका विशेष बिहार की जनता को हम लोग दे सकें। और माननीय मुख्यमंत्री जिस तरह से काम करते हैं वो सब हम लोग जितने लोग यहाँ बैठे हैं सबके लिए प्रेरणा स्रोत। लगातार निरंतर 24 घंटे कोई एक अस्पताल नहीं, किसी भी अस्पताल के लिए सर ऑलवेज विशेष तौर पे काम करते हैं, ताकि हेल्थ सेक्टर एक ऐसा सेक्टर है कि पहले यहाँ से लोग बाहर जाते थे 90%। मैं तो कहीं भी जाता था पहले कॉन्फ्रेंसेस में, तो हेल्थ सेक्टर में जब घूमता था तो बिहार का पेशेंट हर जगह मिल जाता था। लेकिन आज माननीय मुख्यमंत्री की वजह से प्राइवेट एंड गवर्नमेंट सेक्टर दोनों इतना अच्छा बिहार में कर रहा है कि इसका लाभ जनता को मिलता है, और जनता को जब लाभ मिलता है तो पूरा पुण्य का काम होना ही होना है। क्योंकि प्रोग्राम लंबा है, नहीं खींचे, इसलिए मैं अपनी वाणी को विराम देता हूं। मैं धन्यवाद देता हूं आईजीआईसी के डायरेक्टर सर को और पूरी टीम को जो इतना अच्छा कॉन्फ्रेंस कर रहे हैं। थैंक यू।
आपका बहुत बहुत धन्यवाद। और अब मैं संबोधन हेतु आमंत्रित करती हूं डॉक्टर अरविंद कुमार को, सीएसआई बिहार चैप्टर।
परम आदरणीय मुख्यमंत्री जी, ऑल द डिग्निटरीज ऑन द डैश ऑफ द डैश, सीएसआई और इस कॉन्फ्रेंस का उद्देश्य मैं सिर्फ 2 शब्दों में बताना चाहता हूं। मेडिकल साइंस ने बहुत तरक्की की, हर साल नई नई दवाइयां, नए नए रिसर्च हो रहे हैं। दुर्भाग्य का विषय है हार्ट अटैक, उससे संबंधित बीमारियों की संख्या भी बहुत बढ़ रही है। तो कॉन्फ्रेंस के माध्यम देश विदेश के और अपने राज्य के विद्वान विशेषज्ञ एक जगह इकट्ठा होते हैं, नई जानकारियों को हमारे जनरल फिजिशियंस को, जनरल कार्डियोलॉजिस्ट को साझा करते हैं। ये जब अपने क्षेत्र में जाते हैं, गांव में, ब्लॉक में, डिस्ट्रिक्ट में, तो अपने मरीजों को इस नई टेक्निकों से हार्ट की बीमारियों से कैसे बचा जाए, उसका सही इलाज क्या हो और कब उनको स्पेशलिस्ट पर रेफर करें, जो कि हमारे मुख्यमंत्री जी की यही इच्छा रही है कि इस आधुनिक चिकित्सा का लाभ अंतिम व्यक्ति तक जाए। हम लोग सीएसआई नेशनल लेवल पर और बिहार के लेवल पर हम लोग की भी यही इच्छा होती है, सभी टेक्नोलॉजी, सभी इलाज बचाव का जो भी एक एक चीज है वो अंतिम व्यक्ति तक हम लोग पहुंचाएंगे इस कॉन्फ्रेंस के माध्यम, सीएमई के माध्यम से, साइंटिफिक प्रोग्राम्स के। ये डॉक्टर्स के लाइफ का इंटीग्रल पार्ट हो गया है टू अटेंड कॉन्फ्रेंसेस, सीएमई, ऑल सेमिनार्स। थैंक यू वेरी मच।
और अब मैं संबोधन हेतु आमंत्रित करती हूं हमारे बीच प्रधान सचिव आदरणीय श्री दीपक कुमार सर हैं, जिन माननीय मुख्यमंत्री महोदय के मार्गदर्शन और दिशा निर्देशन में आप बिहार की बेहतरी के लिए निरंतर प्रयासरत और कार्यरत हैं। आप जैसे वरिष्ठ अधिकारियों के कारण हमारे बिहार को, समस्त बिहार को गर्व महसूस होता है। सर।
माननीय मुख्यमंत्री जी, सीएसआई के ऑल इंडिया अध्यक्ष डॉक्टर अजय भंगा जी, उपस्थित हमारे कलीग्स, सम्मानित चिकित्सकगण, बहुत प्रसन्नता हो रही है इस तरह का कॉन्फ्रेंस यहाँ पर हो रहा है। और ऐसे कॉन्फ्रेंस से जाहिर है कि काफ़ी लाभ होता है, चिकित्सकों को लाभ होता है, पब्लिक को लाभ होता है। मैं सिर्फ 2-3 बातें कहूँगा जो मुझे लगता है कि शायद अगर आप लोग इस पर विचार करें। एक तो कि आम लोगों में यह जानकारी, यह ट्रेनिंग कैसे मिले कि वो डिस्टिंक्शन कर सकें कि हार्ट अटैक का दर्द है या नॉर्मल दर्द है, किसी और चीज़ का दर्द है। तो अगर इस तरह का कुछ पब्लिक की जानकारी के लिए कुछ हम सोच सकें, आसानी से पब्लिक समझ सके, यह बताने, यह अगर कुछ हम लोग इस पर विचार विमर्श करें तो यह आम लोगों के लिए बड़ा फायदे की बात होगी। और दूसरा मुझे लगता है कि जो विचार करना चाहिए कि हमारे छोटे छोटे जो हेल्थ सेंटर होते हैं, प्राइमरी हेल्थ सेंटर हैं, सब सेंटर हैं, वहाँ के चिकित्सक कैसे ट्रेन हो सकें जो इसको एक तो डिस्टिंक्शन कर सकें इस बीमारी, इसमें हार्ट का, और प्राइमरी ट्रीटमेंट कर सकें। अगर इस पर यह सीएसआई का जो कॉन्फ्रेंस विचार करेगा तो मुझे लगता है कि लोगों के लिए बड़ा फायदे की बात होगी। मैं धन्यवाद देता हूँ इस कॉन्फ्रेंस के लिए।
आपका बहुत बहुत धन्यवाद सर। और अब मैं संबोधन हेतु आमंत्रित करती हूँ नेशनल प्रेसिडेंट सीएसआई डॉक्टर विजय बंग सर को।
आदरणीय मुख्यमंत्री साहब नीतीश कुमार जी, मिस्टर दीपक कुमार प्रिंसिपल सेक्रेटरी, मिस्टर संजय कुमार और बाकी सब मेरे मित्रगण और आईजीआई के डायरेक्टर, सभी को मेरा अभिवादन। और आप सब इतने हाई नंबर्स में देख के अच्छा लग रहे हैं। मुझे एक बात सुन के अच्छी लगी मिस्टर दीपक कुमार की कि लोगों में ये जानकारी कैसी फैले कि भाई लोगों को पता चले कि ये हार्ट का दर्द है या हार्ट का दर्द नहीं है। इसके लिए हम एनुअल कॉन्फ्रेंस है हमारी कलकत्ता में जो सीएसआई नेशनल बॉडी करेगी, वो कॉन्फ्रेंस में 7,000 डॉक्टर रजिस्टर होते हैं नॉर्मली, और वो कॉन्फ्रेंस में हम एक वेबसाइट, पब्लिक एजुकेशन वेबसाइट का इनॉग्रेशन करने वाले हैं। ये हमारा 75th ईयर है, जैसे भारत का 75th ईयर है, हमारे सोसाइटी का भी 75th ईयर है। तो उसमें हम ये जानकारी, पूरी डिटेल जानकारी देंगे और सब भाषा में रहेगी, एक भाषा में नहीं, सब भाषा जो प्राय जो बोली जाती है हर एक स्टेट में, वहाँ की जो रीजनल लैंग्वेज है उसके हिसाब से वो बनी रहेगी। पर उससे भी ज़्यादा इम्पोर्टेंट काम ये करना है कि हमको, नीतीश कुमार जी यहाँ हैं तो मैं ये बात बोलना चाहूँगा कि हार्ट अटैक के लिए एक नेटवर्क बनना चाहिए। नेटवर्क यानी क्या कि एक, मान लो किसी को चेस्ट पेन हो रहा है, उसको ऐसा लगता है कि वो हार्ट अटैक का पेन है, तो उसके पास एक नंबर होना चाहिए। वो नंबर वो डायल करे, उसके पास एम्बुलेंस आए और जहाँ उसका इलाज सही हो जाए वहाँ उसको लेके जाए। ये एक नेटवर्क होना चाहिए, इससे बहुत जान बचेगी। जो कार्डियक अरेस्ट होते हैं, 65% कार्डियक अरेस्ट ड्यू टू हार्ट अटैक होते हैं। बहुत सिंपल है ये, एक नंबर होना चाहिए बस, और कुछ नहीं कि ये नंबर डायल करो, और गलती से भी किसी ने जानबूझ से किया है उसके लिए भी एक डिस्क्लेमर होना चाहिए कि जानबूझ से किया तो सजा भी मिलेगी। जेन्युइन है तो ठीक है, आप करो फोन, कोई प्रॉब्लम नहीं है। तो ये एक बहुत इंपॉर्टेंट है। दूसरा, हमारे यहाँ एयर पॉल्यूशन से बहुत डेथ हो रही है। एयर पॉल्यूशन 2 वजह से होता है, इंडस्ट्रियलाइजेशन और दूसरा कारण है अर्बनाइजेशन। तो ये इंडस्ट्रियलाइजेशन, अर्बनाइजेशन, इसको कंट्रोल करने के लिए भी सरकार के तरफ से कुछ पहल होनी चाहिए, जिससे ये जो वातावरण है, इंडोर पॉल्यूशन, आउटडोर पॉल्यूशन, उसमें कमी आए। अभी वो सिगरेट स्मोकिंग से ज्यादा ऊपर हो गया है आउटडोर पॉल्यूशन, इंडोर पॉल्यूशन, एयर पॉल्यूशन। तो ये 2-3 जगह अगर हम काम करेंगे तो बहुत लोगों की जान हम बचा पाएंगे। उसमें ज्यादा लोग यंग है, यंग हार्ट अटैक, कार्डियक अरेस्ट से हो रहे हैं, प्रोडक्टिव एज में हो रहे हैं, वो हम रोक सकेंगे। बाकी तो हम लोग डॉक्टर लोग कॉन्फ्रेंस करके ये सब कन्वे कर ही देंगे और उसका इलाज हो ही जाएगा। नए रिसर्च हो ही रहे हैं और नई नई दवाइयाँ आ रही है, नए इलाज हो रहे हैं, और अभी तो डिजिटल आ गई है तो उससे आगे ही बढ़ेंगे। पहले से ही हम तो टेक्नोलॉजी बेस्ड थे कार्डियोलॉजी, अब डिजिटल हो गया तो और एक्स्ट्रा ऑर्डिनरी हो जाएंगे। तो ये सब बातें हैं, इससे ज़्यादा मैं कहना नहीं चाहूँगा। थैंक यू वेरी मच।
आपका बहुत बहुत आभार। और अब मैं स्मारिका विमोचन के लिए अनुरोध करती हूँ। मैं अनुरोध करती हूँ डॉक्टर श्यामा रानी आपसे, आप मंच पर स्मारिका लेकर उपस्थित हो, और डॉक्टर सुषमा से आप मंच पर उपस्थित हो, और साथ ही साथ इस स्मारिका के संपादक वरिष्ठ हृदय रोग विशेषज्ञ डॉक्टर अजय सिन्हा, मैं आपसे भी अनुरोध करती हूँ आप मंच पर आए, और सभी मंचासीन गणमान्य अतिथियों से निवेदन, सादर अनुरोध कि स्मारिका विमोचन करें। और कार्डिकॉन 2023 स्मारिका का विमोचन माननीय मुख्यमंत्री के कर कमलों द्वारा, साथ ही साथ मंचासीन सभी गणमान्य अतिथियों के कर कमलों द्वारा। आप सभी का हम बहुत बहुत आभार व्यक्त करते हैं। आप सभी अपना स्थान ग्रहण करें। और आज राष्ट्र भर में बिहार की छवि जो उभर कर आई है, बिहार ने मजबूती से अपना पर्चा बुलंद किया है, इसके पीछे मात्र एक ऐसी शख्सियत है जिसका हाथ है, जिनके दिन रात अथक प्रयास और परिश्रम का परिणाम है कि आज कोई भी क्षेत्र हो, रोजगार, शिक्षा, चिकित्सा या कृषि, हर क्षेत्र में बिहार मजबूती से अपना नाम दर्ज करा रहा है। जी हां, पीएमसीएच और आईजीएमएस के बाद बिहार को एम्स और आईआईटी की सौगात मिली। यह मात्र उनके परिणाम और उनके परिश्रम का ही परिणाम है। जी हां, माननीय मुख्यमंत्री महोदय, हम समस्त बिहार वासियों के अभिभावक, हमारे प्रेरणा स्रोत, उनके सम्मान में 2 पंक्तियां। तुम सोच रहे हो बस बादल की उड़ानों तक, मेरी तो निगाहें हैं सूरज के ठिकानों तक। माननीय मुख्यमंत्री महोदय, आपका सादर अभिवादन।
ये आज कार्डियोलॉजिकल सोसाइटी ऑफ इंडिया की बिहार शाखा के वार्षिक सत्र का उद्घाटन कार्यक्रम हुआ है और इस कार्यक्रम में उपस्थित होने के लिए मुझको कहा गया। मैं उपस्थित हुआ हूं, मुझे बड़ी खुशी है और आप लोगों की बात सुनकर के भी अच्छा लग रहा है। अब यहाँ इस कार्यक्रम में उपस्थित हैं हमारे साथ आए हुए बिहार सरकार के पूर्व मुख्य सचिव और अभी मुख्यमंत्री के प्रधान सचिव हैं श्री दीपक कुमार जी, और यहाँ आए हुए हैं कार्डियोलॉजिकल सोसाइटी ऑफ इंडिया सीएसआई के राष्ट्रीय अध्यक्ष श्री विजय बंग जी, आईएसआईसी के निदेशक डॉक्टर सुनील कुमार जी, स्वास्थ्य विभाग के सचिव श्री संजय कुमार सिंह जी, आईजीआईसी के संयुक्त निदेशक डॉक्टर के वरुण जी और बिहार शाखा सीएसआई के अध्यक्ष डॉक्टर अरविंद कुमार सर्राफ जी, और यहाँ उपस्थित हैं डॉक्टर अनिल ठाकुर जी, डॉक्टर अनूप सिंह जी, डॉक्टर यूएन सिंह जी, डॉक्टर मनीष मंडल जी, डिप्टी सुपरिंटेंडेंट आईजीआईएमएस, निदेशक मेदांता पटना के डॉक्टर रविशंकर सिंह जी, और यहाँ उपस्थित हैं डॉक्टर एचएन दिवाकर जी, जीएस गंगवार जी, अपर मुख्य महानिदेशक मुख्यालय, और इस कार्यक्रम में उपस्थित देश के विभिन्न राज्यों से आए हुए हृदय रोग विशेषज्ञगण, विशिष्ट अतिथिगण, प्रिंट एवं इलेक्ट्रॉनिक मीडिया के पत्रकार मित्रों, छायाकार बंधुओं और इस अवसर पर उपस्थित सभी बहनों एवं भाइयों, बहुत खुशी की बात है कि आज जो काम आपने किया है कार्डियोलॉजिकल सोसाइटी ऑफ इंडिया का, तो ये बहुत अच्छी बात है और इसकी बिहार शाखा के द्वारा आयोजित विशेष वार्षिकोत्सव स्तर में यहाँ मुझे बुलाया गया और इसमें शामिल होकर के मुझे बड़ी खुशी है। और मुझे आमंत्रित करने के लिए मैं आयोजकों को भी धन्यवाद देता हूँ। और मुझे बताया गया कि देश के विभिन्न राज्यों से एवं बिहार के अधिकांश हृदय रोग विशेषज्ञ, कार्डियोलॉजिस्ट और चिकित्सक इस महत्वपूर्ण कार्य में भाग ले रहे हैं। तो ये बड़ी खुशी की बात है और सब लोगों की मीटिंग हो रही है, आपस में बातचीत करेंगे, सब तय कर रहे हैं, तो ये बड़ी खुशी की बात है। और इसके बाद आपको जानते हैं कि हम लोगों ने तो सब कुछ बहुत काम किया। हृदय रोगों के इलाज की विशेष व्यवस्था की गई। इलाज के लिए तो और सब चीज़ों का इंतजाम किया ही गया है। पहले क्या हालत था आप लोगों को मालूम है? कितना कम हालत था पहले बिहार में। आपको मालूम है कि जब हम काम शुरू किए थे तो उस समय कितने लोग रहते थे, इलाज में आते थे? बहुत नाम मात्र के लोग इलाज में आते थे। तो हमने कितनी संख्या बढ़वाई, इवन प्रखंड के स्तर पर हर जगह से करके। और यहाँ पर तो जो भी था सबसे पुराना बिहार का जो हमारा है पीएमसीएच, तो हम तो थे भाई, जब हम थे हमारे साथी, हम तो वहाँ पढ़ रहे थे इंजीनियरिंग में, तो यहाँ तो हम लोगों का एक दूसरे के साथ रिश्ता समूचा रहा था पटना यूनिवर्सिटी में, तो हम तो सब जगह घूमते ही न रहते थे। और यहाँ पर जो डॉक्टर साहब यहाँ पर मौजूद हैं, तो अभी जो आपका इंस्टीट्यूट है, जो भी पता ही चला है कि जो हम भी यहाँ पर बहुत अच्छा बन गया है, तो इसीलिए जो आप समझ ही रहे हैं कि आईजीआईसी का भी, तो आईजीआईसी की क्या स्थिति था, आपको जरा मालूम है ना कि क्या स्थिति था आईजीआईसी का, कितना बुरा हाल था, आपको मालूम है। और आईजीआईसी, हम तो जब एमपी थे तो मेरी माँ की तबीयत खराब हुई थी, तो एक बार वहां ले गए थे। आज जब रात भर हम वहीं रुके हुए थे, तो जहां पर रहने का इंतजाम था उसके बगल में नीचे से हल्ला करते रहता था सब। हमने कहा अरे भाई कमाल चीज है, ये हॉस्पिटल हो रहा, नीचे सब हल्ला करता है, तो कोई मतलब है, तो ट्रीटमेंट ठीक होता है। तो आप याद करिए, सब चीज को हम बदल न दिए जी, और आपका इंस्टीट्यूट कैसा बन गया, आईजीआईसी कैसा बन गया है, साधारण चीज है। हम कितना आईजीआईसी को बड़ा किनारे में रखे रहते हम के ना, अब वो तो बेचारे नहीं रहे, बहुत अच्छे डॉक्टर थे। तो वो तो उनको भी हमने कहा कि भाई नहीं साहब, यहाँ पर पूरे तौर पर ऐसा इंतजाम होना चाहिए, तो सब का सब इंतजाम करवाए। और अब कैसा बढ़िया इंस्टीट्यूट हो गया, और जब शुरू हो गया तो इनका कम्मा शुरू नहीं हो रहा था, हम गए कि नहीं गए, ये काहे देरी हो रहा है। और उसके बाद जब जब ये लोग कहते हैं कि इसमें ये कमी हम पूरा कर देते हैं, अभी आप डिमांड कर रहे थे कि उसका रास्ता नहीं, अरे हम तो पहले ही कह चुके कि उसका रास्ता आपको जाने का होगा। और हम लोग जो बनवा रहे हैं, तो एम्स का तो अलग ना बन रहा है जी, और कितना बड़ा बनवा रहे हैं, हैं? अरे पटना मेडिकल कॉलेज हॉस्पिटल, पीएमसीएच का कितना बड़ा बनवा रहे हैं। अरे वर्ल्ड का दूसरा क्या है, आज तो देश में कहीं नहीं दुनिया में, अभी हाल में एगो आया है, एगो छोटका राज्य में कोई बनाए हुए है, तो उसको और कहीं इलाज है, वो तो झूठे बात हो रहा है। लेकिन जितना ज्यादा हम लोगों ने करवा दिया, आपको जान रहे हैं कि 5,600 का ना है, हाँ 5,000, तो इसका हम सब करवा रहे हैं, बोलिए, और 3 राउंड में करवा रहे हैं। और एक एक चीज से उसका जो रिश्ता है, अब कैसा बन जाएगा, ऐसा कहीं है। अब पहले तो पूरा आता था, बाहर से कितना लोग इलाज में आते थे, अब उसके बाद और जो भी पढ़ते थे यहाँ के लोग, अब बाहर उधर हम कहीं जाते थे, दूसरे राज्यों में या दूसरे देशों में गए हैं, तो यहाँ के जो भी लोग थे आपके डॉक्टर हमको मिले बाहर में, यहाँ के पढ़े हुए लोग कहाँ नहीं, इंग्लैंड में और कहाँ नहीं मिले। तो हर जगह ऐसे ही जाते थे हम कोई भी कार्यक्रम में, तो जो भी यहाँ के लोग थे तो कोई ना कोई कार्यक्रम में मिल लेते थे, बताते थे हम वहाँ के रहने वाले। तो जितना बढ़िया जो है, तो एक एक चीज के लिए कम्मा कर न रहे जी, तो हर चीज को छोड़े हैं। इंदिरा गांधी इंस्टीट्यूट ऑफ मेडिकल साइंस जो है, ये तो बना पहले ना जी, अब पहले बना, लेकिन जब हम आए तो देखा ठीक से काम ही नहीं कर रहा है। तो आईजीआईएमएस को भी कितना बढ़िया बनवाए, तभी तो उसके जो आपके डायरेक्टर है वो है ना जी, तब कैसा बनवाए हैं बोलिए। आज 250 का ना 2,500 का ना बनवा रहे हैं, और एक एक चीज ना सब डेवलप किए हैं, बराबरी ना जाकर के देखते हैं जी, कैसा सुविधा किए हैं। तो जरा सा आप आए हुए हैं बाहर से, तो जान लीजिए, आपके राज्य में हम लोग नहीं जाते थे, खूब जाते थे, सब जगह घूमते घामते, हम लोगों से परिचित कोई भी आदमी कहीं, और हम लोगों का वहां भी ट्रीटमेंट के लिए भेजते हैं ना हम लोगों को, और वहां भी सब इंतजाम करवाए हैं ना सबके रहने का, और वहां का जमीन हम लोग लिए हैं ताकि सब लोगों को रहने का भी वहां पर भी सब तरह का इंतजाम करवा रहे हैं, सब करवा रहे हैं। कहीं भी अपने लोगों का ट्रीटमेंट के लिए वो सब कर रहे हैं। अब बिहार में भी पूरा ट्रीटमेंट करा देने के लिए काम हो रहा था। अब अच्छा है, आप लोग एक एक बात यहाँ पर कर रहे हैं, बहुत अच्छा है। और एक बात जान लीजिए, ये बाल हृदय योजना जो है, तो हम लोगों का 7 निश्चय 2 में अब बाल हृदय योजना के बारे में हम लोगों ने तय किया। क्या तय किया कि बहुत ही था कि हम लोगों ने हृदय में छेद के साथ जन्मे बच्चों का निःशुल्क उपचार कुछ होता ही नहीं था। तो जब पता चला तो इसके लिए हम लोगों ने उसके इलाज के लिए इंतजाम किया। और आप जानते ही हैं कि अहमदाबाद के अवस्थित सत्य साई अस्पताल में मुफ्त में इलाज होता था। हम उन लोगों को यहाँ से सब लोगों का हम पता करा करके अब भेजने लगे वहाँ। बोलिए, जितना भी 5,000, 5 लाख, 10 लाख जो भी पैसा उसको देना है, सब कुछ करा उरा करके मदद करके सबको भेजवा करके। और वहाँ पर तो कुछ नहीं होता है, यहाँ से जाने आने का सुविधा हम लोग सब तरह से कह रहे हैं। तब कितने लोगों का इलाज हो गया। हमको तो पता चला है कि अहमदाबाद स्थित सत्य साई अस्पताल में 794 बच्चों का इलाज हो चुका है। यहाँ से जानते हैं, जब हम लोग शुरू किए थे तो इसी में 21 में ही 2000, तो उसी में इसी सबको भेजने के लिए हम लोग खड़ा होकर के हुए, यहीं से पटना से। एक बार हम जा करके वहाँ भी देखे कि कैसा रहता है, और खूब अच्छा ट्रीटमेंट सबका। अब इतना ज़्यादा हो रहा तो हम लोगों को लगा कि भाई उसको वहाँ भेज रहे हैं तो यहाँ पर क्यों नहीं होना चाहिए। तो आप लोगों के हम लोगों ने 2 जगह, IGIC में और IGIMS में, दोनों जगह कहा कि यहाँ पर ये काम होना चाहिए। तो आज हमको खुशी है, और हमको जो पता चला है कि अब IGIC में 198 बच्चों का इलाज हो चुका है। अब वहाँ जाने के बाद अब क्या हो रहा है, तो अच्छी बात है। लेकिन IGIMS में भी शुरू हो गया है। तो अभी हाल में तो हम रिपोर्ट मांगे हैं, तभी हमको मिला है कल परसों कि 24 बच्चों का भी इलाज वहाँ हो गया। अब तो और ज़्यादा इतना न विस्तार होगा कि 24 होगा, वहाँ तो और ज़्यादा न होगा। तो किसी को बाहर भेजने की ज़रूरत शायद ही पड़ेगी, और सबका यहाँ पर इलाज होगा। तो हम लोग अलग अलग ट्रीटमेंट के लिए भी कोई भी ऐसा चीज़ नहीं है जिसको हम लोग छोड़ते हैं। और बाकी सबको तो कितना विस्तार करवाएं। अब यहाँ पर तो बैठे हुए हैं क्या जी, दिवाकर जी, कहाँ करवाए आपसे, यहीं पर बैठे हुए हैं। इनको कहाँ लगवा दिए थे, भाग गए थे, और समझ गए पटना से भाग गए थे दिल्ली। और जब हम दिल्ली में रहते थे तो इनका परिचय दिल्ली में हुआ। मेरा एक साथी था, साथ पढ़ने वाला लड़का, वहीं पर था, तो वही इनसे परिचय कराया। और उसके बाद इनको हम कह चलिए, जब हम आ गए तो इनको हम वहां पर करवा दिए। कितना बड़ा काम हो गया, आप जरा सोच लीजिए, कितने जगहों पर काम हो रहा है। कोई इंस्टीट्यूट को छोड़े हैं जी, हर इंस्टीट्यूट को। और कितनी संख्याएं बढ़ाई हैं, 6 ही था ना मेडिकल कॉलेज। अब बढ़ करके कितना हो गया, 13 ना। अब बढ़ रहा है और हमारा है। हाँ, तो इतना और बढ़ाने में हम लगे हुए। तो सब लोगों का ट्रीटमेंट हो, तो सब तरह के विस्तार के लिए काम लगे हुए हैं। तो आप लोग आज बुलाए हैं तो आए हैं। आप पहले तो बराबर हम आप लोगों के बीच में आते ही थे। जब दीपक कुमार जी थे तो जब हम पहली बार आए तो यही डिपार्टमेंट देख रहे थे। और जब हम आए नहीं थे तो इनसे मेरा परिचय हुआ, इनसे भेंट हुआ बेचारे का। हम एयरपोर्ट से आ रहे थे दिल्ली से पटना, तो यही कहे आजकल हम देख रहे हैं डिपार्टमेंट। जब आ करके हम ही को मिल गया 5 में अधिकार, तो हम इनको लगवाए। और कितना ज्यादा काम हुआ, कितना ज्यादा काम हुआ है, आप सोच लीजिए। आप कितना हो रहा है, आप सोच लीजिए कि हम लोग तो बता रहे हैं PMCH में बेड जो भी आपको बताए 5462 बेड का, तो उसका काम शुरू हो गया। और IGIMS आप समझ लीजिए, उसका हम लोगों ने कर दिया है 2500 बेड का, अभी बोल ही दिए। और NMCH यही पटने में है, उसको भी आप हम लोगों ने कर दिया है 2500 का बेड। और SKMCH मुजफ्फरपुर का भी कर दिया है 2500 बेड का कर रहे हैं, और उसके बाद NMMCH ये जो गया का है इसका भी हम लोग 2500 बेड का इसका करवा रहे हैं। और उसके साथ साथ DMCH दरभंगा मेडिकल कॉलेज हॉस्पिटल, मैंने पहले पटना मेडिकल कॉलेज हॉस्पिटल था और दूसरा दरभंगा मेडिकल कॉलेज हॉस्पिटल, तो उसका भी हम करवा रहे हैं विस्तार। तो इतना ज्यादा लोगों का ट्रीटमेंट हो तो कौन काम, हम सब काम कर ही रहे हैं। और इसके अलावे जो भी है 3 अस्पताल की बात अभी आपको करवाए। हड्डी के लिए पटना के राजवंशी नगर अस्पताल था, उसको देखने गए और हुआ कि ना इसका तो और ज्यादा विस्तार होना चाहिए, बहुत लोग इलाज कराने के लिए जाता था, और उसका नामकरण हम कर दिए लोक नायक जयप्रकाश नारायण अस्पताल। इसलिए कि बेचारे जब हमको पता चला कि जेपी भी अपना इलाज के लिए वहीं गए थे, तब उनका मूर्ति का स्थापन कर दिया है और नामकरण हम कर दिया है लोकनायक जयप्रकाश नारायण अस्पताल। लेकिन सब तो भुलाइए जाएंगे कि क्या था। हम जो चीजवा कर देते हैं उसको कुछ अब याद रखता है। अब आजकल इतना लोग पत्रकार लोग हैं, तभी बेचारा सब जानता है, लेकिन इसको कहा जाता है कि हम कोई काम किए हैं उसको मत छापो, जो भी हो उसको केंद्र का बता दो कि वही छापा। और जितना हम लोग किए हैं तो खाली आपको बता देते हैं। यहाँ पर हर तरह का इंतजाम हम लोग करवाते हैं, समझ गए ना, कि सब जगह का इंतजाम और सब लोगों को बढ़ाने के लिए सारा काम हम लोग कर रहे हैं। और उसके अलावे तो इनका हुआ हड्डी के लिए भी, और इसमें जो हुआ इसका हुआ नामकरण लोकनायक, और आंख के लिए राजेंद्र नगर हॉस्पिटल उसका भी विस्तार किए गए। लेकिन हम तो भाई कहेंगे, आप यहाँ पर बैठे हुए हैं, हमको अभी पता चला है कि इतना बढ़िया बना दिए थे, इधर फिर ठीक काम नहीं कर रहा। तो अब जो आए हुए हैं सेक्रेटरी साहब, आप जरा देखिए, वो तो हम उनको बता दिए हैं, आपके वो तो चले गए हैं आजकल छुट्टी में ना, अपर मुख्य सचिव, तो जरा देखिए हम उसको बनवाएं। और सबसे पहले ही ना 2 जगह शुरू किए, और तीसरा अभी तक आप लोग अभी तक पूरा नहीं किए हैं, ये सब डायबिटीज आदि के लिए न्यू गार्डिनर रोड अस्पताल। अब कहाँ किए थे? सबसे पहले न्यू गार्डिनर रोड अस्पताल में ना किए थे जी, हैं? जब हम दवाई का ही नहीं, उस समय के उपराष्ट्रपति जी को हम बुलाए थे, हैं? हाँ, भैरव सिंह शेखावत जी को, और वहीं से हम सबसे पहले करवाए थे कि जो इलाज के लिए जो हम लोग हर अस्पताल में पैसा दे रहे हैं, सब तरह का इंतजाम करने के लिए, पहले नहीं था, तो सब तरह का सुविधा के लिए और लोगों को यहाँ बिहार में शुरू किया। अब आप जानते हैं उसके कई साल के बाद, उस समय कांग्रेस का था केंद्र में, तो हमको कहा कि अरे भाई एक जगह के बारे में बताया कि वहां पर वो लोग कर दिया है कि यहाँ पर इलाज के लिए लोगों को दे रहा है ट्रीटमेंट में, और सबको हॉस्पिटल में भी दे रहा है। तो हम कहेंगे तो आपको मालूम नहीं है जी, हम लोग तो 2006 में बिहार में शुरू कर दिए, आपको पता नहीं है। पर बिहार में जो होता है उस समय की सरकार भी नहीं सोचता था। अब आजकल वाला तो जानता भी है, तब भी उसको जान के बंद रखता है। तो हम लोग तो इतना काम करवाएं, सबके हित में शुरू से ही हम लोग काम करवाएं, तो सब कुछ तो मेडिकल के लिए, और जानते हैं कितना ज्यादा हम लोग खर्चा करवाते हैं, हर तरह से सब तरह से, और सबका ट्रीटमेंट हो जाए। और बाकी है कि यहाँ के लोगों को तो करा ही रहे हैं हम लोग, हम मदद भी करते हैं कि जो कोई भी गरीब गुरबा तबका का है, जिनकी आमदनी जिसके परिवार की एक सीमा के अंदर है, तो सबको जितना भी इलाज के लिए होता है, सब तरह का मदद के लिए भी हम लोग मदद करते हैं, सबको देते हैं, सहायता करते हैं। तो सब तरह का सुविधा तुम लोग कर ही रहे हैं, ताकि कोई, आप बोलिए ना, इन्हीं से पूछिए कि जो IGIC में कितना आदमी जाता है ना जी, और सबको सरकार की तरफ से जो दिया जाता है मदद, तो इसीलिए सब तरह का सुविधा अब दे करके। और दूसरी बात है कि जो हम लोगों ने आप इसमें जो कर दिए थे, इसमें IGIMS में, तो तो पहले तो उसमें भी लोगों को ट्रीटमेंट पे पैसा लगता था, IGIMS में तय कर दिया कि उसमें मुफ्त में होगा इलाज। तभी हाल ही में भी तय कर दिया, मालूम हो न गया। अरे तो सबको करते रहते थे, देरी करते थे। अब तो डॉक्टर साहब सब लोगों का पैसा तो हम देते ही हैं। आपके जितने लोग हैं, आपके जितने चिकित्सक सब हैं, लेकिन उसके साथ साथ जो इलाज कराने के लिए आवेगा उसको भी कोई तरह की असुविधा नहीं हो। तो हमको पता चला कि नहीं, वहां तो हम तुरंत अभी हाल ही में कहा है भाई IGIMS में हम लोग ये सुविधा किए हैं तो इसको तुरंत होना चाहिए। तब सब तरह से हम लोग इस तरह का इंतजाम करवा रहे हैं। तो ये आपको कहेंगे, आज हमको बुलाए हैं तो बड़ी खुशी की बात है कि हर तरह के ट्रीटमेंट के लिए और आप लोग जो भी काम कर रहे हैं तो ये सब चीज़ के लिए बाल हृदय योजना वाला भी सब काम और आपके यहाँ भी हो ही रहा है। तो अब बहुत अच्छे ढंग से सारा काम करवाइए, तो इसीलिए बहुत खुशी की बात होगी। तो आज भी कितने लोग हैं, आए हुए लोग हैं, कार्डियोलॉजिकल सोसाइटी ऑफ इंडिया की बिहार शाखा के सभी पदाधिकारी, सबको मैं बधाई देता हूं, धन्यवाद देता हूं। और आप ट्रीटमेंट भी बहुत अच्छा कर रहे हैं और आप लोग पूरे मजबूती के साथ सबका इलाज करिए, अधिक से अधिक लोगों को सुविधा हो जाए, यही हमारा आग्रह है। और आपने आज के इस अवसर पर मुझको भी मौका दिया आने का, इसके लिए मैं आपको धन्यवाद देता हूं कि हमको आने का मौका मिला। हम मुझको बड़ी खुशी हुई कि आज आप डॉक्टर लोगों के बीच में बुला रहे हैं, तो इसलिए मैं आप लोगों का बहुत बहुत अभिनंदन करता हूं। और आप लोगों का तो हम इज्जत हमेशा करते रहते हैं और सब दिन करते रहेंगे। और कुछ डॉक्टर लोग मेरे यहाँ आते रहते हैं तो इन लोगों से भी हाल पूछिएगा कि हम इन लोगों का कितना इज्जत करते हैं। तो इन्हीं शब्दों के साथ आप सब लोगों को बहुत बहुत बधाई। और आप ये कार्यक्रम आयोजित कर रहे हैं, बहुत अच्छे ढंग से करिए और सब जगह से जो लोग भी आए हैं उनकी भी बात को सुनिए और कोई आवश्यकता हो बिहार में तो और करने की कोशिश करिए। और अगर जरूरत पड़े सरकार की तरफ से कोई भी सहयोग और चाहिए तो आप बता दीजिएगा, और सेक्रेटरी साहब भी यहाँ पर रहेंगे, एक एक बात बता दीजिएगा और तुरंत ला करके खबर दीजिए ताकि इन लोगों को कोई तरह की दिक्कत नहीं हो और इनके लिए जो सहयोग की जरूरत हो, सहायता की जरूरत हो, वो हम लोग करेंगे। इन्हीं शब्दों के साथ आप सबको बहुत बहुत बधाई। मैं अपनी
आदरणीय, आपने आशीर्वचनों से हमें अनुग्रहित किया, इसके लिए हृदय तल से हम आपका आभार व्यक्त करते हैं। और अब मैं धन्यवाद ज्ञापन हेतु अनुरोध करती हूं डॉक्टर अनूप सिंह सर से।
एज ए ऑर्गेनाइजिंग सेक्रेटरी मैं अपने प्रदेश के मुख्यमंत्री, माननीय मुख्यमंत्री श्री नीतीश कुमार जी का तहे दिल से शुक्रगुजार हूँ, जो हमारे इस कॉन्फ्रेंस में आए और इन्होंने इनॉग्रेशन किया और हम लोगों को आशीर्वाद दिया। मैं साथ में आए अन्य अतिथिगण का भी तहे दिल से आभार व्यक्त करता हूं कि वो आए और इस कॉन्फ्रेंस को सक्सेस बनाने में हमारी मदद की। सेंट्रल CSI प्रेसिडेंट डॉक्टर विजय बंग सर भी हमारे अनुरोध करने पे आए हैं और हमारे राज्य के कोने कोने से सभी चिकित्सकगण यहाँ आए, इस कॉन्फ्रेंस में भाग लिया और एक दूसरे को अपने नॉलेज के आदान प्रदान किया। धन्यवाद।
बहुत बहुत आभार आपका, बहुत बहुत धन्यवाद। जोरदार तालियों के साथ हम माननीय को हम विदा करें। आपकी गरिमा में उपस्थिति हमारे लिए बहुत मायने रखती है। आपका बहुत बहुत आभार, बहुत बहुत धन्यवाद।
कर रहे हो यार? अरे यार पहले कुर्सी खाली करो ना यार।
आप सबों से आग्रह है कृपया हॉल में बैठे रहें। बहुत जल्दी अब हम लोग के बचे हुए 2 सेशन स्टार्ट हो रहे हैं। वी आर गोइंग टू हैव वेरी 2 important वेरी सेशन। One is hypertension session and one is ECG and arrhythmia session. Very soon, once the stage is ready, we will start very soon. All the chairperson and speakers are requested to please stay back here.
Ladies and gentlemen, 2 more sessions are left. So I would request all guests kindly be seated, take your places. Soon we will begin our next session. So ladies and gentlemen, all distinguished guests, take your seats please. Next session is Hypertension Symposium. All distinguished guests, I would request you all kindly take your seats. In a moment we will begin the session. Announce करो sir. So now we're going to start our next session, Hypertension Symposium. And before starting our session, there is a special announcement. Today is the birthday of Dr. Arvind Kumar sir. So I wish you all wish him a happy birthday. Happy birthday, sir. Please play a happy birthday song.
Really, I just forgot because I am here from 8:30 onward without taking this. I didn't see any WhatsApp mobile message, even family message. This was my commitment to the Cardicon. Sorry. Thank you very much.
Thank you so much, sir. And now I would request our all chairperson to chair. First of all, I would request Dr.
PK Singh, PK Pramod Kumar Singh from Begusrai.
Dr. Pramod Kumar sir from Begusrai. Kindly come up on stage. Dr. Samrendra Jha, Dr. Himanshu Kumar, Dr. Abhishek Kumar, Dr. Kaushal Kumar Jha, Dr. Nishant Kumar, Dr. Abhishek, Dr. Neeraj Kumar, and Dr. Vipin Kumar, sir. All the chairperson, kindly come up on stage. And our first speaker of this session is Dr. Deepak Ranjan Das. He's from Cuttack. Dr. Deepak Ranjan Das, sir. It's over to you.
May I request all the delegates, please be seated and please maintain silence. We are having our very important guest lectures from Dr. Deepak Ranjan Das. He is from Odisha. Please honor him by keeping silence.
At the outset, let me convey my heartfelt gratitude to all the organizing committee of Cardicon Bihar for giving me this responsibility of deliberating on an important topic. Due to paucity of time, and we have two subsequent speakers who will be also discussing on important aspects of this issue. So the topic which have been assigned to me is recent guidelines on hypertension, and when we look at the guidelines, the recent means the 2023 ones actually are the European Society of Hypertension guideline, which is actually the talk of the town. And why do I utter that phrase? Because in the history of European guidelines, for the first time, European Society of Hypertension has come out with a guideline which is exclusively ESH guideline. Because all the time you will see they were combined guidelines of ESC, ESH. So first time they have separated, or you can say parted their ways from the ESC, and they have come out with very fundamental differences to the existing guidelines of hypertension that have been suggested by different European societies like British Hypertension Society or other national societies of different countries. And we have a consensus guideline which has come just last month, that is Indian Society of Hypertension guideline. And just to avoid the confusion, ISH actually stands for International Society of Hypertension, who came out with their guideline in 2020 during the peak of the COVID. So this is mentioned as INSH. So keeping these two comparisons, I'll just highlight the important points. But since I'm the initial speaker of this session, we have to have an idea of what is this whole danger. Almost 1 billion people, and this is predicted to go up to 1.5 billion. And hypertension affects 1 out of every 5 adults in India. And primary risk factor for 2 deadly things. And the first deadly one was the focus of discussion during this inaugural session, starting from the Chief Minister to all our organizing committee members. And it contributes to approximately half of the deaths of heart disease, so also of stroke. But this is the real challenge. Almost 170 guidelines exist in the world, but you see our dismal performance in terms of achieving optimal hypertension control. So less than 1 in 7 of people who have actually hypertension have reached the target of therapy. So less than 14%. And in the very outset, let us know what will be the focus of discussion on the recent guidelines, because ESH is the talk of the town. So I'll just tell 4 important points, because it's a voluminous guideline. But what are the key points? In most patients, treatment should be initiated with 2 drugs. So we are moving from a step care approach where we used to start with 1 drug, upscale its dose, and then go for combination. Currently, we should go for 2 drugs to improve the speed, efficiency, and predictability of BP control. Although several 2-drug combinations can be used, the preferred 2-drug combination has been one RAS blocker, could be S inhibitor or ARB, with either a calcium channel blocker or a diuretic. Now, this is the most controversial point. A beta blocker can be used at any step in combination with any drug from major classes as guideline-directed medical therapy. So, whenever there will be any discussion about ESH 2023, the most important focus of discussion will be about beta blockers. Their revival as an important antihypertensive therapy. But monotherapy is not out of the window. You could still go for monotherapy, but with a high normal blood pressure for cautionary reasons in old patients, and if they have a high frailty index. Now they have come up with different frailty index assessment scores, and it may be considered in low risk patients with stage 1 hypertension where the systolic blood pressure is less than 150 millimeter of mercury. So these 4 are important concepts that have been proposed by this ESH. And we'll have few comparison and contrasts. So the top left corner is what has been suggested by our Indian Society Consensus Guideline. Why it is not a guideline? Because when you come up with an Indian guideline, you have to exclusively analyze the data of Indian hypertensive patients and come up with your guideline. That is not possible because we don't have an exhaustive set of data to come out with a guideline, but then it is called a consensus guideline. And we have actually the previous Indian guideline on hypertension, IGH 3 and 4 came up. They were very likely the European guidelines where they had grade 1, grade 2 and grade 3 hypertension, but this guideline suggests grade 1 and grade 2 hypertension. And we know that this is just a comparison, overall comparison of Indian guideline, International Society of Hypertension guideline, European guideline and the American guideline, which is yet to get revised. Now, what are the key differences amongst these guidelines? ACC had lowered the threshold for hypertension diagnosis. You know, there was a furor all across the world because they reduced the level of diagnosis of hypertension and consequently they re-stratified the stage 1 and stage 2 hypertension. So they graded one hypertension as 130 to 139 and 80 to 89, but for almost all of the guidelines it is 140 and 90 above. And European and Indian guidelines are somewhat similar, but they are gradually accepting the specific importance of beta blockers. You can't give it carte blanche, but it can be used as a first-line therapy in certain scenarios, and they are enhancing its utility as an antihypertensive agent. In contrast to ACC, we don't know, maybe the next guideline of ACC may change it, the whole outlook towards beta blockers. And isolated systolic hypertension is a very specific entity in all these guidelines, whereas it is not in American guideline. Now, when you think of blood pressure measurement, all guidelines have almost similar principle, and the focus is on aneroid and digital devices. Mercury sphygmomanometer is not being favored by any of the international guidelines. And the recommendation is, this is the recommendation. What we do is definitely different. Should take 3 readings, discard the first reading, take the average of last 2 readings. This is very much similar. And Indian Society and European Society categorically mention that blood pressure should be measured in 2 arms. And if I confess honestly, I'll do it maybe in at best 5% of all my patients. But that's what the recommendations say. And all the guidelines across the board, they give due importance to ambulatory blood pressure monitoring and home blood pressure monitoring. And that's because of concepts of white coat hypertension and masked hypertension. And when you think of numbers, there are 2 numbers. What is a threshold for diagnosis and what is a target blood pressure? So threshold for diagnosis, you see across ESA, ESC, ISH and Indian Society of Hypertension is very same, and we know ACC had already reduced this level, and that was done after the publication of SPRINT trial data, but not many people are overwhelmed by the data of SPRINT. And this is an initiation and choice of antihypertensive drug, just a comparison. Due to paucity of time, how do we use the, can I use the pointer here? I don't know. Okay. Oh, this, okay. So what, I'm not sure whether it, but what is important is, when you think of treating a patient of hypertension, you must give due consideration to the atherosclerotic cardiovascular risk. Because with atherosclerotic cardiovascular risk, you may think of initiating the therapy with pharmacotherapy in contrast to the usual recommendation, start with lifestyle modification, then add drugs. So the key factors are atherosclerotic cardiovascular indications. And in ISH, ESC and Indian society, they are more in favor of initiating therapy early. And lifestyle changes or therapeutic lifestyle changes, these 6 are similar across all guidelines: weight reduction, physical activity, smoking cessation, reduced alcohol intake, stress management, and DASH type of diet modification. One thing has come up specifically in ES 23 is potassium supplementation has been found to reduce blood pressure. This was earlier included in lifestyle modification. As a part of DASH diet modification, you increase your intake of fruits and vegetables which are rich in potassium. But now this has come out as a separate recommendation. Now in management of hypertension, the focus is on single pill combination. Previously, the American College of Cardiology recommendation that we'll see, it still recommends individual drug uses, but both European Society and the Indian guidelines, they are promoting single pill combination with either 2 drugs or 3 drugs as per your need. And what is peculiar or interesting about the International Society of Hypertension is for every therapeutic situation, they have 2 set of recommendations. One is essential, one is optimal. Optimal means the best. But if you don't have a scope to go for the best, you can give something less than the best, but still you could achieve your target. So that's why they have come up with 2 sets of recommendations, which is essential and optimal, unique to International Society of Hypertension, not given in. But what I will suggest is ACC still continues separate agents or in a fixed dose combination. But for other guidelines, it is mandatory that you should start off single pill combination because it improves adherence and produces a better control. Now, this is just an overview comparison of different guidelines about specific indications. But our third speaker will be exclusively deliberating on the comorbidities. This is just a comparison of how to treat hypertension with coronary artery disease, hypertension with a CVA, hypertension with heart failure, with CKD, diabetes mellitus. Because for us cardiologists, most of the patients of hypertension will be having some other comorbidities.
Request you, sir, to summarize.
Yes, I'll be ending it. So the specific drug choice, what I will just say, in presence of CKD, the diuretic becomes loop diuretic. In other cases, it almost remains the same. The 3 guidelines giving, and this is the emerging role of beta blockers. ACC does not recommend it as a first line, but all the 3 guidelines give it due importance. And this is, these are the selected conditions where beta blockers. Hypertension with elevated resting heart rate that is greater than 80 beats per minute. And these are the other conditions where ESH is promoting beta blockers. Diuretics, the only controversy is ACC only thiazide type diuretics, others both thiazide. And resistant hypertension is the next topic which will be discussed. Hypertension in pregnancy, all the entities are grouped into HDP, hypertensive disorders of pregnancy. And the drug treatment essentially same, labetalol, calcium channel blockers, and methyl dopa. So thank you for your patient hearing.
Thank you very much, Dr. Das. Very good speech. Let me know some practical aspect. In how many percentage of your practice you do ambulatory blood pressure monitoring?
So I usually utilize ambulatory blood pressure monitoring for 2 important contexts. One is when I suspect white coat hypertension, because sometimes we measure the patient's blood pressure at say 150 by 100. The patient says, sir, all the time I have been measuring my blood pressure at home, it is 130 by 80. To actually, there are 2 aspects to it. One is it is scientifically validated. To establish the diagnosis, you must take an ABPM and you find that the average awake blood pressure and the average asleep blood pressure is more than 135 by 85. So you can definitely say that you are having blood pressure, you need to take medicine. Otherwise, he will go from one doctor to other doctor asking him the same question. Second thing is, when you give a patient a treatment and you find that his blood pressure is controlled in your clinic, but he complains that he had some problem like say headache and he measured and his blood pressure was high. This could be the reverse, which we call as masked hypertension. So these two have been recommended by almost all guidelines to use. So these are the two scenarios where I have used.
Thank you. Thank you very much, Dr. Das. Next speaker is Dr. Neeraj Kumar from Patna. He will be talking about resistant hypertension. Dr. Neeraj Kumar.
Change कैसे है? How to change the slides? This one. Fine. Respected chairpersons, respected seniors, and friends. My job is simpler, as Dr. Das has covered the general aspects of the hypertension, the resistant hypertension in evaluation and management. As we enter the third millennium, we are on the verge of biggest epidemic ever for cardiovascular diseases in human history. And most of it has to be blood pressure related, that we probably give much less weightage than what it deserves. So blood pressure that remain above goal in spite of the concurrent use of 3 antihypertensive agents of different classes. One of the agent must be diuretic, and all agents should be prescribed at optimal dosage or as tolerated. The optimal dose of medication should be at least a moderate dose, if not the maximum dose. Patients requiring 4 antihypertensive medications, even if it is controlled, will be labeled as resistant hypertension. The world's leading factor for cardiovascular disease, stroke, disability, and death is probably this resistant hypertension. So, coming to this ESH 2023 guidelines, it is the true resistant hypertension is defined as systolic BP more than or equal to 140 mmHg or diastolic BP is equal to or more than 90 mmHg, provided that maximum recommended or tolerated dosage of 3 drug combination comprising ACE inhibitor or ARBs, calcium channel blockers, and a diuretic has been used. The BP controlled should has been confirmed by ambulatory BP monitoring, and the other causes of apparent or pseudo-resistant hypertension, especially poor medication adherence, and secondary hypertension has been excluded. If confirmation by ABPM is not feasible, then home BP monitoring may be used instead. It is recommended to manage resistant hypertension as a high-risk condition because it is frequently associated with organ dysfunction, hypertension-mediated organ dysfunction, and increased cardiovascular risk. In the patient of resistant hypertension, we should ideally target the BP below 130 by 80, but at least it should be reduced below 140 by 90. And we should definitely reinforce the lifestyle measures if it has not already been utilized at its best. In most of the studies, it has been found that 10% of the diagnosed patient of hypertension ultimately will be diagnosed as resistant hypertension, and we should be willing to search for them. In clinical trials, sometimes in the hypertensive group, 30% patients has been diagnosed as resistant hypertension, only because of better adherence to the protocols and checking the BP more frequently. In a study, cross-sectional study from a tertiary care referral hospital in South India, there was 53% in a group of hypertensive patients, 53% were controlled, 52% on less than 3 drug, 1% on more than 3 drug, that we can call as resistant hypertension. And again in this study, almost 10% of people were found to have resistant hypertension. By the worldwide data in Asian population, Indian Heart Journal 2017, the 33.5% were only controlled hypertensives on the medication, and 17% of the people were found to have resistant hypertension. The major chunk was again uncontrolled hypertension without the criteria of resistant hypertension, which is the window of opportunity for all of us. Why do we need to look after the resistant hypertension? Because 35% of all CV deaths, 50% of all stroke, 25% of all CAD deaths, and 50% of all congestive heart failures. And it is the commonest cause of CKD and end-stage renal disease, causing 25% of all premature deaths related to renal diseases. So we need to first rule out the causes which lead to apparent resistant hypertension, that is pseudo-resistance or poor adherence of medication, improper techniques of BP measurement, the white coat effect, high-risk patient lifestyle, and drug-related secondary causes. The commonest mistake normally while we take the BP or our staff takes the BP does is measuring the BP before letting the patient sit quietly and be comfortable. The second commonest cause is use of too small a cuff, particularly in obese patients, will result always in a falsely high blood pressure readings. The poor adherence of antihypertensive therapy, if you don't do adequate counseling, it is expected that 40% of patients with newly diagnosed hypertension will discontinue their medication in the first year of their treatment. So white coat effect, we all know, it is not as simple as we think it is, because the risks caused by this is higher than a non-hypertensive, although it is lower than a well-controlled hypertension. So in this group also, the older age, the higher baseline BP, obesity, excessive salt ingestion, CKD patients, diabetics, and patients with LVH have a higher risk. The obesity is a very common feature with resistant hypertension, and treating the obesity helps controlling the BP. Few drugs are there which may be the culprit of causing the resistant hypertension. They should be looked at and removed if not very necessary. Few underlying conditions should be evaluated to rule out the reasons of secondary hypertension like renal artery stenosis, primary aldosteronism, renal parenchymal disease, pheochromocytoma, and sleep apnea. How to evaluate and manage with patients appearing to have resistant hypertension? First, confirm the treatment resistance. That if the BP is really high after taking adequate dosage of 3 medicines, and exclude pseudo-resistance by 24-hour ambulatory BP monitoring or homebound BP monitoring. Assess for secondary hypertension and assess for the target organ damage. The heart is one of the most common sufferer with resistant hypertension that leads to LVH, arrhythmias, CAD, and early detection is crucial. Kidney bears the burden. It is a frequent cause of CKD. Many a times, even in 6 months duration of uncontrolled resistant hypertension, it may cause renal damage. Proteinuria, renal artery stenosis should be evaluated, and renal function, assessment of frequent renal function is necessary for management of resistant hypertension. The brain is also not spared. There is increased risk of stroke, cerebrovascular disease, even cognitive impairment, and blood pressure control is necessary to reduce these problems. Atherosclerosis, vascular stiffness, peripheral artery disease can be caused due to damage of the endothelial damage caused by high blood pressure. Hypertensive retinopathy, we all know, and regular eye checkups are important in patients with resistant hypertension. So what are the treatment goals? We know the primary goal is to achieve and maintain target blood pressure. Other than that, we should reduce the other risk factors of cardiovascular and organ damage. There should be effective management should focus on reducing the elevated risk of heart attack, stroke, and cardiovascular events due to associated risk factors. Prevention of target organ damage and slowing the progression of target organ damage. We should try to reduce the hypertensive heart disease, the renal impairment, and cerebrovascular events, as well as to enhance the quality of life, the symptomatic improvement of the patient, and improving the overall blood pressure to the better quality of life. So, what are the treatment possibilities over and above the 3 drugs that we are talking about, and the combined pills are available and it is recommended? The diuretics are a mainstay, and over and above that thiazide type diuretics, the spironolactone if the patient is not having hyperkalemia. Other than that, adding beta blockers, alpha 1 blockers, and centrally acting agents. Thiazide type diuretics, if not used earlier, it should be used in where the eGFR is more than 30. However, loop diuretics should be used and they will be beneficial if eGFR falls below 30. Chlorthalidone could be used either way, in less than 30, even more than 30, or even less than 30. Renal nerve denervation is to block the sympathetic outflow and reduce the BP. If all these measures fail, still is available. Patient with resistant hypertension should be followed very closely with frequent follow-ups. Follow-up should include periodical ambulatory BP monitoring or home monitoring of BP, as well as frequent assessment of hypertension-mediated organ damage, particularly the kidney function and serum potassium level. Regular use of home BP monitoring will help the drug adherence also. So mostly when the patient is labeled as resistant hypertension, he is already on adequate dosage of ACE inhibitor or ARB plus calcium channel blocker plus diuretics. Then if it is in CKD stage 1 or 1 to 3, then spironolactone can be added or any other variant of it. Beta blockers, alpha 1 blockers can be added, and then centrally acting agents can be added. If still remains uncontrolled, then consider renal denervation. If in CKD stage 4 and 5, the loop diuretics can be used, chlorthalidone can be used, and then beta blocker and alpha 1 blocker should be added, centrally acting agent should be added. The lifestyle modification, if not done adequately, should be reinforced in every possible meeting. Promote a heart-healthy diet like DASH diet, high in fruits, vegetables, whole grains, lean protein, and low-fat dairy. Diet should be low in sodium, low in saturated fat, and added sugars. Weight management should be done adequately because treating obesity may help treating the resistant hypertension, and weight loss can lead to significant reductions in blood pressure. Regular exercise is a cornerstone of hypertension management. Limiting alcohol use, sodium restriction, stress reduction. Easier to say, difficult to done, but chronic stress can contribute to hypertension and cannot allow you to control the BP adequately. Smoking cessation, smoking is a major risk factor of cardiovascular disease. Medication we all know.
Dr. Neeraj, kindly conclude.
Yes, sir. It is not going down. Anybody can help? I think there is last slide only is left. So the diagnosis part, we need to give 3 medication in adequate doses. We should know that complications and risks are high if the patient is having resistant hypertension. Diagnosis, while ruling out the pseudo resistance and the drug choices to treat the resistant hypertension. Thank you very much.
Thank you very much, Dr. Neeraj, for your very useful talk. Do you see any role of SGLT2 inhibitor in this resistant hypertension?
Pardon, sir?
Use of SGLT2 inhibitors in resistant hypertension. Is any scope?
SGLT2 inhibitors, even the sacubitril valsartan combination, and few new drugs are pipelines, but they are not established therapy for it yet.
Okay, thank you very much. Next speaker is Dr. Anupam from Patna. He will be talking about hypertension in special situations. Dr. Anupam, please.
Very good evening. And CSI organizers, Cardicon organizers, my sincere thanks to all of you for having me here and giving me opportunity to come and interact with all of you. So the topic, as already stated, is hypertension in special situations. Now, why do we need special attention to hypertension in special situations? Because treatment of hypertension is not limited to controlling a particular number. There are certain situations with coexisting hypertension which have compelling indications so that overall prognosis of the disease can be modified. So because of this reason, these special situations, they have to consider the special drugs which improve the long-term prognosis and the end organ damage in these situations. What are these special situations? Pregnancy, diabetes, ischemic heart disease, CKD, strokes, and childhood and adolescence. So let us go through these situations one by one. First, the hypertensive disorders of pregnancy, or called HDPs. So they affect about 10% of pregnancies worldwide, according to the recent data of 2022. Major cause of maternal, fetal, and neonatal morbidity and mortality, and risks posed by hypertension in pregnancy include maternal, fetal, as well as neonatal risks. Now, all hypertensions in pregnancy are not the same. They are either a patient can have pre-existing hypertension, which can be diagnosed if it is present before 20 weeks of gestation. Then it is not gestational hypertension, rather it is the pre-existing hypertension. Or if the patient presents first time beyond 20 weeks, then if the hypertension persists beyond 42 days postpartum, it is chronic hypertension of pregnancy. Second category is gestational hypertension, which develops in this duration of 20 weeks to 40 days postpartum. It can be transient gestational hypertension, which usually normalizes over a few hours initially. Sometimes people think that it is due to anxiety of checkup, but 40% of these women ultimately develop gestational hypertension, which persists throughout the pregnancy. Then more severe forms are preeclampsia and then eclampsia, of course. Preeclampsia can be superimposed on chronic hypertension. It can be without chronic hypertension. Now, prevention and treatment of HDPs, lifestyle measures are, of course, the primary way of avoiding or preventing them. So all the ACE inhibitors and ARBs have to be stopped, including direct renin inhibitors. Now, treatment of mild pre-existing hypertension or mild gestational hypertension, individually compare the risk-benefit ratio of drug treatment or no drug treatment, or the risk of hypertension, because even the drugs considered safest in the hypertension, including alpha-methyl-dopa, they also have shown some effect on the developing fetus. any drug so can be potentially dangerous. So if it is just mild hypertension, it is better to leave it alone, because in the natural course, second trimester, the BP drops. So therefore, we have to judge the risk-benefit ratio of giving the drugs and no drugs. Decision should be based on BP levels, presence of hypertension-mediated organ dysfunction, and BP after a short-term trial of antihypertensive withdrawal. If it continues to be less than 140/90, then there is no need to restart the drugs, but if it shoots beyond, then the drug has to be resumed. Now, what is the clinical evidence whether the drug treatment should be reserved for severe hypertension in pregnancy, or it can be given even for the mild or moderate hypertension? In 2022, recently, there was a trial, CHAP trial, published in New England Journal of Medicine. It concludes that in pregnant women with mild chronic hypertension, a strategy of targeting BP less than 140/90 was associated with better outcomes than a strategy of reserving treatment for severe hypertension only. Therefore, it is recommended that all hypertensives should maintain a BP of less than 140/90. Another trial, CHIPS trial, which was published in 2015. So the conclusion from both these trials, so far these are two largest trials which compare the data without medicines or with medicines in mild to moderate hypertension in pregnancy. So both the trials together show that with drug treatment, pregnancy-related composite adverse outcomes are significantly reduced. Both studies indicate a reduction in severe preeclampsia. Hence, the threshold continues to be the same, which is established for patients without pregnancy, which is 140/90 millimeters mercury. And the drugs of choice are labetalol, alpha-methyl-dopa, and extended-release nifedipine. A word about whether the conventionally considered safe drugs are still considered or are really safest or the best in pregnancy-induced hypertension. Traditionally, labetalol and alpha-methyl-dopa were considered the first choice drugs. But recent data reveals that probably nifedipine extended release is the best. This was revealed by a recently published meta-analysis of multiple trial, huge data, that nifedipine and nitroglycerin, they had best control of about 55% and 90% reduction of the blood pressure. And on the other hand, the traditional drugs, hydralazine and labetalol, were associated with very less reduction in BP. So probably the nifedipine extended release should be considered the drug of choice in this situation. Now, patient may have secondary hypertension in pregnancy, which are renal artery stenosis, hyperaldosteronism, or pheochromocytoma. Now, renal artery stenosis, every hypertensive young woman desiring to have pregnancy should undergo a renal Doppler study, because renal artery stenosis, if it is due to fibromuscular dysplasia, it increases the pregnancy-related complications. Aldosterone is a natural competitor of progesterone. Therefore, all patients of primary hyperaldosteronism should be discouraged from having pregnancy. Pheochromocytoma, the maternal and fetal mortality are very high. So all these patients, in case become pregnant, they should undergo a cesarean section electively, and along with that, tumor removal should be planned in the same sitting. Coming to hypertension in presence of cardiovascular disorders, recommendations for treatment with hypertension with CAD are drug treatment should be initiated in the high normal range of BP also, as already indicated by my previous speakers. So the level at which the BP or the target level is 130 or lesser for systolic and 80 or lesser for diastolic BP. Drugs with documented favorable effects in CAD are ACE inhibitors and beta blockers. These should be preferred. In patients with hypertension with CAD with angina, beta blockers and both dihydropyridine and non-dihydropyridine CCBs are particularly useful. Lowering the heart rate to 60 to 80 beats should be an additional treatment goal in hypertensives with CAD. Only in patients who have baseline heart rate of less than 50 beats per minute, beta blocker and non-DHP CCBs should be avoided. Hypertension and LVH are frequently associated with INOCA and MINOCA. Therefore, treatment with RAS inhibitors, beta blockers and CCBs should be preferred so that LVH can be regressed and the myocardial oxygen demand can be reduced. Now, can aggressive BP lowering in patients with hypertension and CAD be dangerous, or the so-called concept of J-curve? J-curve has been observed for composite of death and non-fatal MI and stroke in major trials and the meta-analysis including huge data. It has been observed that the composite endpoint of non-fatal MI, stroke and death was lowest at systolic BP of 130 and diastolic BP of 90. So it was thought that, but on the other hand, when stroke studies were done, it was observed that lower the BP, better is the outcome in terms of recurrence of stroke. So when the data was retrospectively separated for MI and stroke, it was observed that the incidence of stroke comes down with further lowering of BP while the MI increases marginally. Therefore, lower BP than 130/80 is good for preventing strokes but not for cardiovascular outcomes. Coming to hypertension in patients with diabetes, there is a bidirectional interaction during diabetes in the form of diabetes as it is associated with hyperinsulinemia. It stimulates the sympathetic nervous system, which in turn increases the systemic vascular resistance, leading to hypertension or aggravation of hypertension in hypertensive cases. At the same time, it also causes insulin resistance, which further increases insulin levels or the hyperinsulinemia and perpetuating the adverse cycle. So this interaction, that is one of the reasons that in diabetics, the hypertension is more severe and more chances of having resistant hypertension. Common causal links of unfavorable effects of modern lifestyles also contribute to this relationship. Now, what to do in such cases? What is the optimal treatment? The characteristics, as we already talked, are greater systolic BP elevation with wider pulse pressures, higher BP variability or the so-called labile hypertension. Non-dipping patterns are very frequently seen in ABPM, higher rates of resistant hypertension, high salt sensitivity, and trend towards orthostatic hypotension and hyperkalemia. Patients with hypertension and diabetes are considered to be at high cardiovascular risk and at very high cardiovascular risk if they already have established CVD or advanced CKD. This necessitates the implementation of meticulous lifestyle measures and antihypertensive therapy to offer protection against micro and macrovascular complications. The BP threshold for starting drugs continues to be 140/90 or above. BP target is less than 130/80. It, as we discussed, it improves strokes but not cardiovascular events. Agents, any of the 5 major drug classes, including a RAS blocker, should be prescribed to patients with hypertension and diabetes.
Dr. Anupam, please.
Yeah, sorry, just
summarize.
Yeah, one minute. So one small word, as the question was raised about SGLT2 inhibitors. In the recent ESH guidelines, SGLT2 inhibitors have been observed to have some effect on BP reduction also. So they have been included as class 1 agents in patients with diabetes and hypertension. Coming to CKD, BP target is less than 130/80. By initial days, the GFR may decline when we lower the BP, especially with ACE inhibitors, but we should not worry about it because it stabilizes soon. I'll skip some slides. Coming to this chart, what are the antihypertensive preferences? The main point here to concentrate upon is that even in patients with eGFR less than 30 on the right side of this slide, even there, in them, the ACE inhibitors and ARBs should be started initially along with CCBs, and we should observe in case patient, because 15% drop in eGFR is expected with these drugs. But if the drop is more pronounced, even only in those cases we should consider discontinuation, and we should always rule out renal artery stenosis in these cases. I think quickly going through just one slide on stroke. So hemorrhagic stroke, the BP target, if it is within 6 hours of symptom onset, it is 140/90. Other than this situation, there is no condition in acute stroke where BP reduction should be drastic. In cases with hemorrhagic stroke, if BP is more than 220 systolic, then we should aim for a BP 180 for initial 72 hours. Should not go more low than this. While in ischemic stroke, if the BP is more than 220/120, then only it should be reduced, and initially only 15% reduction should be planned with IV drugs. Recently, there has been special attention on hypertension in children. In 23, the American Heart Association has published this statement. Prevalence of hypertension in childhood is quite significant, 2 to 5%, and most of the cases it is primary hypertension. The targets are less than 95th percentile in children up to 15 years, and if beyond 16 and above, it is like adults 140/90. ACE inhibitors, CCBs, beta blockers and diuretics are recommended for the control of blood pressure.
Just one question, ma'am. What is your BP target for ISH patients, systolic targets? ISH patients, yeah.
Okay, systolic hypertension. Yeah, it is 140 systolic. Since it is isolated systolic, the diastolic is expected to be within 90, but the systolic target continues to be 140, less than 140.
Thank you, Dr. Anupam, for a nice overview of all the different scenarios in management of hypertension. So with this talk, we conclude this session.
And now I would request all the chairperson to felicitate our speakers. Dr. Deepak Ranjan Das, Dr. Neeraj Kumar, Dr. Anupam Bambani ma'am, speakers of the session, and Dr. Vipin is presenting this shawl to our speaker. A little clap will make more beautiful this moment. So, ladies and gentlemen, thank you so much. Thank you so much, all of you. And now I would request our rest chairperson for our last session, Dr. L.K. Prasad, Dr. B.P. Azad, Dr. Ashutosh Kumar Sinha, Dr. Alok Kumar,
Dr. Abhinav Bhagat, Dr. Rajiv Krishna, Dr. Ram Sagar Rai, Dr. Ranjit Kumar. I would request you all kindly come on stage to chair. And the first speaker of our last session is Dr. Ajay Kumar Sinha from Patna. Dr. L.K. Prasad, Dr. B.P. Azad, Dr. Ashutosh Kumar Sinha, Dr. Alok Kumar, Dr. Abhinav Bhagat, Dr. Rajiv Krishna, Dr. Ram Sagar Rai, Dr. Ranjit Kumar, our chairpersons of our last session. Dr. A.K. Thakur, sir. Dr. Nashar Abdali, sir, kindly come up on stage.
So good evening, friends, and let me thank at the outset CSI Bihar, who's been very dear to my heart. You know, we have been working for so many years now, and I don't know how much I have given, but definitely I have given something to this organization. 3 terms as governing body members, 2 terms as associate editor of Indian Heart Journal, convener of two Rheumatic Heart Disease Council and Preventive Council in the era of COVID, when we did a very national-wide meeting on. See, if you talk about atrial fibrillation, which is a very, very common arrhythmia, in fact, the commonest arrhythmia, which all of us encounter every day, almost every day. Even if you see less number of patients like me, I would be seeing at least one atrial fibrillation for sure. Etiology can be anything. This is a very complex scenario, and the management of this situation, this condition is now, it's a combination of multiple factors, multiple people involved, so many health caretakers are there. This is a very catchy diagram. I thought, why not keep it in the beginning? So they are just like heart failure management, 4 pillars. Similarly, atrial fibrillation there are 4 pillars, and they are lifestyle and risk factor management. Anticoagulation is very, very important, extremely important. And last 10 years, 15 years, I have been telling wherever I go that in your practicing chamber, you must have a chart of Chad-Swask scoring system. If not, at least your computer should have that. So that, based on that, we anticoagulate. Initially with warfarin, now with newer anticoagulant, NOACs, 5 of them which are available now. Then comes the era of rate control. People thought that rate control was the only answer in atrial fibrillation. In fact, we'll see some good trials on that. And then came the era of rhythm control, which is the talk of today's. My assignment is rhythm control in atrial fibrillation. So let's look at the first trial, a firm trial in 2002, and that showed that rate control is as good as the rhythm control. And after that, for many years there was silence. Nobody thought of going anything beyond that. But let me tell you that my passion of learning, reading, discussing, and seeing in atrial fibrillation cases started in 2010. I've been to Dr. Mithilesh Das' place in Indianapolis, in USA, stayed with him for a couple of days, went to his lab, and similarly, in those time only, I went to Sanjeev Narayan's lab. I saw what was he doing for atrial fibrillation. If you see Douglas Jives in the same place, Indianapolis, great man, and if you listen to his video lecture of 2023, you will just Google it and see the old man freaks, he speaks on atrial fibrillation. And of course, Gregory Lipp is a pioneer in atrial fibrillation. And now this is the thing. I went to the lab of Dr. Sanjeev Narayan. I was not knowing what is he doing. I was not able to see anything. I was not able to understand everything. But later on I realized that he was the pioneer person in a trial known as FIRM trial. And he believed that his concept was that this, because of multiple rotors, atrial fibrillation originates. And that was a novel kind of thing which gave him a lot of laurels. He is an Indian guy who was in UK, now in Stanford, and he is doing a lot of work in the field of cardiac arrhythmia. Coming to example of a patient, very old patient of mine, he shifted out from Dhanbad to Patna, came to somebody referred from Dhanbad. He was living in my area, so he came and consulted me. Severe LV dysfunction, coronary artery disease, little bit of plaque here and there on angiogram. And he was, of course, having COPD. Several times cardioverted, but did not revert to sinus rhythm. He went to Bangalore for evaluation, in fact. And Deepak Padmanabhan, is it the name correct? I believe he is the guy who rang me up. Dr. Sinha, there is a patient of yours. Do you want him to undergo radiofrequency ablation? I said, I don't know. I am not the right person to answer. But if you think so, to my surprise, this gentleman underwent radiofrequency ablation at this age, at so much of LV dysfunction, mitral irritation, and he improved like anything. His LV function improved, he remained in sinus rhythm, and still after, say, more than a year and a half, still his sinus rhythm is maintained. So, we are now come to an era of radiofrequency ablation. Now, I've just run through the slides how atrial fibrillation is increased. You see, this is a map of US. See in 2013 what is the density of atrial fibrillation. And all over the globe, the scenario is same. This is the first presentation I did in 2012 at ESC, European Society of Cardiology meeting, and there was no question of rhythm control at all. None of us were knowing anything about rhythm control. And so was Indian Heart Journal presenting IHRS data of atrial fibrillation, no mention of rhythm control at all. But what happened? Now we have started learning more and more about the atrial fibrillation, anticoagulation, better symptomatic control, treating comorbid condition, and understanding the stroke risk, symptoms, severity, substrate severity. And basically what is there? that atrial fibrillation is a atrial myopathy because of so many risk factors, so many dysfunction, so many underlying conditions. And this is what the gist I found in European Society of Cardiology conclusion, that primary indication for rhythm control using cardioversion, antiarrhythmic drugs and or catheter ablation is a reduction in AF-related symptoms and improvement in quality of life. I will just run through the slides because I have got left with only 3 minutes, less than 3 minutes. They are the drugs which came from 1920. Quinidine to multiple drugs, sotalol, dofetilide, dronedarone, Varnacant, which is a atrial specific drug meant for this thing. And ranolazine, of course, is being used. And finally, rhythm control by drug came in East AFNET trial. This is a trial which gave us I will just this trial gave us a lot of vision to us, and this was a beautiful trial which concluded that rhythm control is possible in atrial fibrillation provided we treat early. You know, all the trials on rhythm control by drugs failed because drugs were given quite late. So if you attack this disease early, and even with drugs, because this trial was predominantly drugs, not ablation. And drugs were propafenone and flecainide for those who were not having any structural heart disease, and some of the patients were on amiodarone and dronedarone, and some of the patients only atrial fibrillation. So this was not a drug catheter ablation trial. So in conclusion was that early rhythm control may confer lower risk of stroke, death. And another trial which compared drugs with ablation, early AF trial, which clearly showed that probably ablation is much superior to antiarrhythmic drugs. I will just so long-term outcome of ablation, we have seen that this gives better results, better persistence of sinus rhythm, and better outcome. Real-world data of about 2 lakh patients. You see huge number of patients, pulmonary vein isolation gives the best result, and flecainide in between. And rhythm control treatment as a whole is better than no rhythm control. So what is there is that ablation is associated with lower risk of stroke and mortality, and in addition, slower decline of cognitive function. That is very, very important. So if ablation is a miracle or myth, it's really miracle now. It's not a myth now. With this, I think time is... I'll show a couple of trials and their results. These 3 trials have given a vision, future vision to us, that catheter ablation treatment in atrial fibrillation in presence of heart failure can give us a better result in future. Something about the atrial MR because of atrial fibrillation, what is known as atrial functional mitral dilatation. In that category, if you do ablation, then probably you are going to get better results. Just last example of one of my patient, rheumatic heart disease patient, very bad, twice BMB done, yet after cardioversion, she remained in sinus rhythm and she is still in sinus rhythm. So that is the example of cardioversion giving rise to sinus rhythm. So that's all. My detection, so first detected episode of atrial fibrillation is an important opportunity to prevent disease progression. As we know, heart failure, every time heart failure comes, and what Vikas was showing, that so first opportunity of atrial fibrillation, we must catch and do best possible. I was surprised to see that now flecainide is available in inhaler, and that's what it gives results in some 30, 60 seconds. But that's a wonderful thing to have in future. Cryoablation has come now. People are doing cryoablation in and out in our country also. Couple of centers are doing cryoablation. So now cryoablation is giving a better result compared to earlier. But still, I would say that we are improving, and we will be learning till the end of our career. Thank you very much.
Sir, I would like to know, you have told that early intervention, either in the form of pharmacological or in the form of RFA. So, is there any cut-off point? What do you mean by early intervention?
See, the best trial on drug is East AFNET trial, done by Kirchhoff. This from Germany. And what he did was, all the patients were treated in the first 3 months of persistent. If you see 1 year natural history of atrial fibrillation, try an attack in the first 3 months if you really want to achieve sinus rhythm. Yeah, that's what.
I think if it is done early, the atrial diameters will be less.
Absolutely.
If it goes late, then the ablation and drug therapy will not be effective.
You can think of atrial reverse remodeling, because everything on is electrical remodeling, structural remodeling, autonomic functional remodeling, everything is like that.
Thank you, sir. The next, please, Dr. Samsar.
Good evening, everyone. I know we are running late, but this is the last session, and it was kept so that the topics would have been interesting. Let's coming to pacing. The era of pacing has now changed. Now, we were doing conventional pacing for more than 25 years, but now it has changed. We are more inclined toward conduction system pacing. We need to give the results of pacing which has to be comparable with the physiological conduction system, what it is occurring in our normal heart. So we will be discussing on conduction system pacing. Now, the pacing modalities are conventional RV pacing, which we usually do, and others are physiological pacing, which is also called the conduction system pacing. There are two things. One is Hess bundle pacing, and one is left bundle pacing. Now, the traditional RV pacing, the deleterious effect with traditional RV pacing was the LV dysfunction, progressive LV dysfunction with normal RV pacing, and second thing was atrial fibrillation, and hospitalization for heart failure is a frequent thing. Those we are usually watching our patients, those who have been implanted normal pacemaker in the era of 2000s, they frequently get hospitalized for heart failure. The LV function has decreased with time, and almost I can say that 10 to 15% of these patients are those candidates who need an upgradation, whether to CRT or whether to conduction system pacing. So that's why the interest has been generated that we need to address this situation, so that if a patient on any kind of pacemaker, he stays for 20 to 30 years, he should maintain his LV functions, and heart failure hospitalization has to be decreased in further follow-up. Also, the data in the Dutch follow-pace study is showed that every 10% increase in RV right ventricular pacing, it has been associated with 8% increase in heart failure associated death when long-term data is calculated.
the pacing, suppose that if we are pacing our RV for more than 40%, then heart failure hospitalization is increased by 2.5 times what it is usually in absence of pacing. The detrimental effects are quite variable with patient to patient. The recommendation, they also say that whenever the LV function, LV ejection fraction, if it is in the range of 35 to 50% and the patient is requiring pacemaker, and if the amount of pacing, if it is 40% of the regular sinus rhythm, if the patient is maintaining sinus rhythm but it's still he is requiring intermittently more than 40% of RV pacing, then CRT has been agreed by everyone as per the guidelines, but the cost of CRT is high. The newer modality came, which is known as conduction system pacing, and it can be recommended in these patients especially. Initially, it was found that the morphology conduction system pacing should be advised. Initially, his bundle pacing was started, then left bundle pacing superseded his bundle pacing. Initially, in left bundle pacing, it was said that the patient should have a baseline left bundle branch morphology. So initially, it was advocated for those patients only who had a baseline LVB pattern. But when the time progressed, in last 3 to 4 years, it has been advised for any kind of patients. No morphology is a prerequisite now for left bundle area pacing. These are the areas. His bundle area, it is near the AV junction, and the left bundle area which we need to pace, it is located almost 1.5 to 2 centimeters below the his bundle area. The limitation, what we commonly do at my center, what I commonly do is left bundle pacing, because his bundle pacing, it has a very long learning curve. The cost is very high. The after effects of his bundle pacing, the degree of lead dislodgement, the amount of impedance which we get, it is quite variable. And also, as per the guidelines, the 2A recommendation is that whenever we do a his bundle pacing, we have to have an RV backup lead in place, because in almost 15 to 20% of cases, the impedance gradually increases or threshold is very high, and the risk of dislodgement of his bundle lead is very high. These are the advantages of his bundle. His bundle is quite more physiological as compared to left bundle pacing. But in those patients who have infrahisian conduction block, his bundle pacing is not going to work. In that patient, left bundle pacing is going to work. The main disadvantage is that the target area is very small, capture thresholds are often very high, sensing issues have been there, and approximately it has been, as per the data, it has been seen that in 7% of the patients who have underwent his bundle pacing, lead revision was required. Now coming to left bundle pacing, the advantages are as comparable to his bundle pacing, and disadvantages, lead related disadvantages are not there in left bundle pacing. The important risk factors associated with that are the perforation of the RV septum towards the LV side, but it is all dependent upon the operator who is doing that. These are the data which has been published by Dr. Vijay Raman. I think he holds one of the largest number of cases of conduction system pacing. His data has been published in recently EHRA 2023 conference also, and I can say that he is the master. Overall, when we see that how much conduction system pacing which center is doing, so all over the world, Fuwei Institute in China, in Beijing, it is the largest volume center for conduction system pacing in the world, but it has almost 50 to 60 cath labs. So obviously there will be almost more than 200 operators which are doing this conduction system pacing. So coming to left bundle pacing, which is quite feasible and quite practical, and the learning curve of left bundle pacing is very low. I can say that. And also when it comes to his bundle pacing, the electrophysiological knowledge has to be very good, because you have to map his bundle so that you can place his bundle lead properly. But when it comes to left bundle pacing, initially his bundle catheter, his catheter was required, but gradually when time passed on, surface 12 lead ECG was the only requirement, and now also when I when we are doing at our center, we only do a 12 lead surface ECG. The attachment, what the normal ECG electrode, it is not there. We have to attach a 12 lead complete ECG, and it has to be monitored. It can be defined as a capture of the left bundle. Usually the septal myocardium capture has to be there. An important thing is that the pulse width is very important. It is not that you have to pace at a high pulse width and you get a threshold at high pulse width. Pulse width at least of 0.4 millisecond is required, and you should get a threshold of 1 volt. A transvenous access is required. Transseparate placement of pacing lead into LV septum. Endocardium in the left bundle area has to be there, and confirmation of the capture of left bundle has to be done. These are the data, the feasibility, safety, acute effects of left bundle pacing, and it has been quite convincing. This was published in Heart Rhythm journal in 2019. The thresholds were quite stable, and the long-term data with his left bundle pacing, they have been superior and comparable to lead safety issues with a conventional RV pacing also. Now, the data came that can we use it in place of CS lead, that's CRT, in place of CRT, if the patient, because CRT is a quite costly affair. So we can offer left bundle pacing. The main advantage of left bundle pacing versus CRT is that the lifetime warranty with CRT is never there. No company is offering any lifetime warranty. Hardly it is 5 years or 6 years. But when we do a left bundle pacing, we can use the dual chamber pacemaker device, because you need to only attach 2 leads, one RA lead and one left bundle lead, if you are doing a dual chamber pacemaker. So your work of CRT is also done, and patient also gets a lifetime warranty for the device. So any PG replacement is not going to cost him further on. So the cost is very low. The usual dual chamber pacemaker plus extra added cost of almost 30,000-40,000 is there as compared to normal dual chamber pacemaker. So these are the data which have shown that it is well comparable with CRT. The QRS narrowing, which has been resulted with a proper left bundle area pacing, it has been quite more narrower as compared to those achieved after CRT implantation. Now let's see how we approach. First of all, the septal thickness is very important. These are the procedural aspects. The septal thickness, ideal septal thickness should be more than 7 mm. Whenever it is less than 7 mm, then we have to be very cautious when we screw in the left bundle lead, because the risk of septal perforation towards the LV side is very high. Second thing, if the septal thickness is less than 5 mm, if the basal septum area where we need to pace, if it is less than 5 mm, the better we have to avoid it, because we, with a 2-3 screw we can easily go towards the left ventricular side. And the intrinsic rhythm, what it is there, if the left bundle branch block rhythm is there, intrinsic rhythm, then the things are quite comfortable. If it is not there, then you have to manipulate the data, the different parameters, they are quite different as compared to left bundle intrinsic rhythm. So we have a special C3510 catheter through which the lead is passed, and it is usually a lumenless lead. So we have to screw the lead only, no external screw is required. The view is very important. We have to screw it in a LO view, usually 30-35 degree is required, so that you can vertically puncture the septum. Now the gradually impedance is monitored and the lead is advanced. Now the important thing is that we have to see the notch in V1, sheath angiography, if it is required, it has to be done. Initially in all cases of left bundle pacing, we used to do a sheath angiogram, that up till what depth we have reached. But now it is not required at all, because the ECG changes and the LVAD, which we usually see, they are more important determinants. And if you have went across the septum towards the LV, you can easily perceive that by the change in the impedance and the threshold of the lead during the ECG monitoring while doing the case. And the fulcrum sign is important, and impedance, it has to be monitored. Now, these are the important aspects. At times, I cannot say that we are 100% successful in doing left bundle area pacing. Selective left, initially it was said that you have to, LBB pacing was the term, but now the term has changed. Now it is LBB-AP, left bundle branch area pacing. So it comprises of selective left bundle branch, left anterofascicular pacing, left posterior fascicular pacing, and deep left ventricular septal pacing. So deep septal pacing means that you enter the septum and you go to the left LV side of the septum. You should not perforate it. At times you cannot catch the left bundle area. At times the areas are fibrous, so it is not quite easy possible. So different parameters which we have to see. First of all, the QRS transition. If you have got a selective LVB pacing, then it is quite good. If you are not getting that on threshold test, then you have to see the splitting and the LVAT. If you decrease the threshold and LVAT is increased by 10 milliseconds, suppose you are pacing at 10 volt and again you are pacing at 1 volt, and if the LVAT is increased by 10 milliseconds, then you are quite good. Then you can finally conclude the procedure. The second thing, the LVAT, if their baseline ECG is left bundle branch block, then the LVAT, it should be less than 80 millisecond ideally. If it is non-LVB, then it should be ideally less than 75 millisecond. Then also if the morphology is quite matching, then you can complete the procedure. If still you are not getting this, then the V6 to V1 peak inter-peak distance has to be calculated. If it is more than equal to 45 millisecond, then you are quite comfortable and you can conclude the case. If you are not getting this also, then potential V6 LVAT, that RWPT is the LVAT, what we usually say. To STIM, if it is more than almost equal or the difference is less than 10 milliseconds, then also you are quite good, you can complete the procedure. The QRS transition to selective left bundle pacing, if it is achieved on program stimulation or gradually going deep inside, then also you are good, you can complete the procedure. If you are not getting all of these, at times we take 2 to 3 hours while doing a left bundle pacing. Then the LVAT, it should be less than, if it is less than 100 millisecond, then also it can be a quite satisfactory that you are not going a selective left bundle branch, but it is near the left bundle, it is in the left bundle branch area. The interpeak distance, if it is between 34 to 45, then also it is quite comfortable. The transition to septal pacing morphology has to be there, and the prolongation of QRS by 10 to 14 millisecond on threshold test. LVAT, if it is prolonged by 10 to 15 millisecond from decreasing threshold to output to 10 to 1, then also it is quite acceptable. And finally, if we are unable to get any of these, then you have to be satisfied with the deep septal pacing in the form of QR in V1. Then we can say that we can conclude with deep left ventricular septal pacing. So these are the things which have to be, which are important, and these are the common sites where we pace it.
Dr. Shamshad,
yes,
please conclude.
Gradually when we proceed, the ECG changes are like this, which we can see, and these are the ECG changes which we gradually see when we move from RV septum to deep septum to left ventricular septum to the specific left bundle branch capture. The very important morphology is the V1. You can note that in V1, when we reach the RV septum, we can get a notch on the Q wave segment of the V1. Gradually, when we progress towards deep septum, that notch gradually goes on the ascending limb and it disappears. When we are perfectly in left ventricular septum area, then there is a terminal R which is achieved. And then when we finally reach the specific left bundle branch area, then this terminal R is taller than the initial R wave. So this is the thing which is usually ideally which should be seen, but it is ideally it is usually seen only in 20 to 30% of the cases, which I have experienced with our team. We have done almost 40-45 cases of left bundle pacing, but we have hardly seen these kind of ECG changes in only 10 to 15 cases. So I will show you 2 cases. This is case 1 with LVB morphology. Patient was having LV dysfunction, 40% of ejection fraction was there, cost was an issue. On cardiac MRI, no scar was there. So we offered him option of CRT versus left bundle area pacing. So finally we concluded with left bundle area pacing. This was the lead placement, the RAO view and the LAO view. And this was the final ECG which we achieved. So significant narrowing of QRS was achieved. Initially it was almost 150, 160 millisecond. Finally we were able to achieve 110 millisecond of QRS. The morphology you can see in V1, the typical morphology of left frontal area pacing, that terminal R wave has been achieved and it is more prominent than the proximal R wave. This was the case too. This was the ECG. When he was in the periphery, CPR was done, he was resuscitated, then he was brought at our center, temporary pacemaker was done. And after stabilization, on day 2, we did a pacing because this patient was having LV function of almost 40 to 45%. That might be due to his cardiac arrest, but we finally concluded that we will do left bundle area pacing because his angiogram it was a normal coronary angiogram, and this was the final ECG which was achieved. And one thing very important is that if the patient is requiring mandatory pacing, then ideally a unipolar pacing mode has to be given to the patient. That thing only will be more able to capture the specific left bundle. In this patient also, the QRS was very narrow as compared to conventional pacing, and I can say that the QRS which we achieved in this case was almost 90 to 95 milliseconds. And both these patients are doing good. It is almost 1 year after implanting device in these 2 patients. Thank you. If there is any question. Yeah.
But if you study the literature, maybe 10 years back, there is a lot of comparison between biventricular and bifocal pacing. But subsequently, over a span of last 5-6 years, people have lost interest with bifocal pacing. Maybe in cost content scenarios, people are more interested to go for bifocal pacing, by which you can curtail the cost, and maybe, as you have suggested, the patient can get a benefit of
lifetime
warranty. But means the data of those times would not prove that bifocal is at least as good as
but the latest data, the 3 to 4 years data which is available from the data from Dr. Shanmuga Sundaram, he was doing those cases in Madurai, in Tamil Nadu, and the data from the Fuai hospital in Chennai. These are the 2, we can say, the largest center. They have presented that they compare 2 things, isolated left bundle pacing with CRT. In that case also, they have seen that the QRS narrowing was quite good, and heart failure hospitalization was significantly reduced, and also the LV ejection fraction improvement, it was always quite comparable. The second thing which Fuai Hospital published was that it was a LOT CRT, that left bundle branch CRT, now we call it. In that, in this left bundle branch CRT, we place a CS lead, and a left bundle lead is also placed. And the BIV pacing, which we were earlier doing with a RV lead, RV apex lead and CS lead, now we are doing with a left bundle lead and CS lead. And it was seen that there was significant and dramatic change in the heart failure hospitalization as compared to conventional CRT, and they have also shown that there was a significant mortality benefit as compared to isolated CRT versus left bundle CRT.
Oh, initial data was the narrower the QRS complex post-transplant, the better is the outcome.
Yeah.
Similar is your experience also.
Dr. Samshad, is there any case report or regarding the risk of acute or long-term coronary injury with LVBP area pacing?
Coronary perforation. Coronary issue.
Coronary.
Yeah.
Coronary.
3-4 case reports have been published where suppose if you are, this is a septum and you are screwing your lead towards the septum and this is the end of septum, the anterior wall, and this is the groove where LAD is lying. So suppose if you are not mapping in properly and if you are screwing the lead towards anteriorly, then obviously if you go very deep, your screw can go into LAD, and it has been seen that patient had MI just after left bundle area pacing. 2-3 cases have been reported, and it was then surgically managed.
Now we have done many cases, I think 32.
Yeah, 36.
So how much additional time you take from the RDFX pacing to this pacing?
The average time, if you will ask me, then it is additional time which is required. It is almost 30 to 40 minutes at least in a case. In few cases, it required almost 2 hours extra as compared to conventional pacing. And in few cases, it required only 10 to 15 minutes. It all depends upon how exactly and how good the potential you get, the morphology which you get. Because on an average, if you will ask me that how many re-attempts do you need, on an average, at least 2 sides of a screw we need when we want to do a selective left bundle area pacing.
Thank you, Dr. Samshad.
Thank you.
Next.
Now Dr. Shaukat will from Purnia.
Good evening, all the organizing committee members and chairperson and all the delegates presented here. My topic of presentation is prevention and management strategies of sudden cardiac death. Sudden cardiac death is defined as the sudden natural death presumed to be cardiac origin that happens within 1 year of onset of symptom in witnessed case and within 24 hours of last being seen alive when it was unwitnessed. As we know, sudden cardiac death is the most important cause of all cardiovascular death. It is around 50% of all cardiovascular death are due to the sudden cardiac death, and it is the first manifestation of cardiac disease in 50% cases. Its incidence increases with the age, and male has more incidence as compared to female even after comparing with the coronary artery risk factors. As per cause, in young cases, the primary electrical disease and cardiomyopathies are the primary cause of sudden cardiac death. In middle age is coronary artery disease. In older cases, along with coronary artery disease, there are valvular disease and heart failure case. These are the enumerated view of causes of sudden cardiac death. In younger population, CPVT, long QT, Brugada and acute coronary syndromes, and ARVC and hypertrophic cardiomyopathy. In older patients, chronic CAD, ACS and sarcoidosis are present. We need to aware the public, and we need public intervention for the benefits of out-of-hospital cardiac arrest. We should train our community training in the basic life supports. We should available public automated external defibrillators and bystander CPR. With mobile activated dispatch of basic life support, trained volunteers to the area of happening of sudden cardiac arrest. We know there are many risk factor calculators for the hypertrophic cardiomyopathy ARVC, but the evaluation of sudden cardiac risk in general population was not evaluated. There was a paper published on the, and that publisher summarizes 12 independent risk factors for the sudden cardiac death risk in general population. That is age, male sex, African American race, current smoking, systolic blood pressure, use of antihypertensive medicine, diabetes, serum potassium, serum albumin, SDL, estimated GFR and QTC interval. In that paper, they found that the acidic sudden cardiac death prediction model was slightly better in predicting sudden cardiac death in general population than 2013 ACC or AHA pooled cohort risk equation. They also found that low albumin concentration as an independent sudden cardiac death risk factor in both cohorts, suggesting that it is an important marker for arrhythmic motility. There are certain tools for the investigating the patients of sudden cardiac arrest. From the history, we can observe that the absence of vagal prodrome indicates the sudden cardiac arrest due to the arrhythmic cause. There can be history of family history of premature death or sudden cardiac death. There will be history of deafness, mitral valve prolapse, or hypertrophic cardiomyopathy. On examination in the patient from the lupus pernio or erythema nodosum, we can think of sarcoidosis. If we found angiokeratomas, we can think of Fabry's disease. If we see the palmoplantar keratosis in ARVC, and dysmorphic features orient towards the Anderson-Tawil syndrome and Timothy syndromes. On investigation for the sudden cardiac arrest patient, first we do ECG, and standing ECG is also helpful for the evaluation of long QT syndrome. As we suddenly stand, that there is a rapid increase in heart rate and QT interval should be shortened. But in the patients of long QT syndrome, the QT stunning or QT stretching is happening, and the QT does not shorten as we stand up, and this indicates the patient can have the long QT syndrome. For the further evaluation, Holter and implantable loop recorder are needed. In signal averaged ECG, three important parameters are helpful for the assessment of sudden cardiac death. That is filtered QRS duration, which is more than 114 millisecond, and low amplitude signal duration if more than 38 millisecond, and root square voltage of terminal 40 millisecond QRS. If less than 20 microvolt, it indicates abnormality, and audience, these are the minor criteria of ARVC diagnosis. On TMT, if exercise-induced monomorphic VT or polymorphic VT and bidirectional VT is present, that it orients toward the catecholaminergic polymorphic VT. And for the evaluation of long QT syndrome, the assessment of QTC prolongation 4 minutes after recovery from the stress test helpful in the investigating long QT syndrome patient. On imaging side, we can easily available imaging echo and CT angiogram, and after that is final is cardiac MRI. These are the certain provocative tests in which the patient of unexplained syncope, and on further evaluation we could not find anything. And for further evaluation for the arrhythmias like Brugada syndrome, the asmelin and flecainide are two important drugs for the provocative evaluation of the unexplained or arrhythmic syncope. Asmelin use should be dose of 1 milligram per kg over 10 minutes. Maximum dose is 100 milligram, and infusion should be 10 milligram per minute. And if we found the Brugada 1 type ECG, that indicates positive test. And but it is contraindicated in the, if obvious Brugada type 1 ECG is found or heart failure. The criteria of stopping the asmelin test is VTVF or presence of type 1 Brugada syndrome ECG, or the QRS widening more than 150%. After giving asmelin, we should observe these patients for 30 minutes if the test is negative, or 4 hours if the test is positive. Like this, adenosine is used for the exclusion of latent pre-excitation, and because some patients of AVRT on after reversion we found a normal ECG, we can use adenosine as for the exclusion of latent pre-excitation. There are certain drugs, epinephrine and acetylcholine. These epinephrine is used in patients suspicious of CPVT, but this is not feasible to exercise. And acetylcholine are used for the evaluation of coronary vasospasm for the evaluation of sudden cardiac arrest, in which normal coronary angiogram are found, and we are suspecting coronary spasm as a cause of sudden cardiac arrest. But acetylcholine should not be used in the patient who are having left vein stenosis of more than 50% or triple vessel disease or 2 vessel disease in which 1 vessel is 100% occluded. Even in the patients of NYHA 3 or 4 heart failure functional status, renal failure and severe bronchial asthma. After that, even after these investigation, we could not find any evidence of disease, we could progress toward the electrophysiological study, in which we stimulate through the programmed electrical stimulation, in which the 2 basic cycle length stimulation done in the RV at the 2 sites, and after that 3 extra stimulus will be given, and induction of monomorphic VT indicates positive test. If on inducible VT we found and there is a history of unexplained syncope, then ICD should be indicated. Endocardial mapping is also helpful for the differentiation of ARVC from the benign outflow tract VT, because outflow tract VT are benign thing, but the ARVC is very malignant and degenerate to VF, and we should manage very cautiously. Endocardial mapping also helpful for the taking of biopsy in cardiac sarcoidosis and myocarditis patients. This is the evaluation chart when we found a patient who said that he revived through the cardiac CPR. On first we came on the emergency. First we do the 12-lead ECG. If we found ischemia, then this patient should go for the urgent coronary angiography. But if we do not found ischemia, but there is evidence of electrical instability which is suspicious of ongoing myocardial ischemia, then we should go for the coronary angiogram. But if there is no suspicion of ongoing myocardial ischemia, then first do echocardiogram, and if there is suspicion of extracardiac cause, then do brain CT and chest CT. If the evidence of brain or chest disease, then go for the non-cardiac evaluation. If there is no evidence of non-cardiac disease, then collect the sample for toxicology or screening, drug overdose screening, and genetic testing. review and repeat ECG. If there is evidence of pre-excitation or suggestion, the ECG suggestive of primary electrical disease like Brugada syndrome, treat accordingly. If even on evaluation with ECG or echocardiography we could not find any evidence of structural heart disease, then go through the cardiac CT angiography or coronary angiography. On if CT angiography found that there is a coronary anomaly, we treat accordingly, like surgery if needed. Even after CT coronary angiography, we could not find anything, then go, next investigation is cardiac MRI. If on cardiac MRI, we could find late gadolinium enhancement and exact cause of structural heart disease like sarcoidosis or dilated cardiomyopathy or Fabry disease or many cardiomyopathies, then treat accordingly. If even after cardiac MRI, we could not find anything, then next investigation is sodium channel blocker test. As I previously told that azmaline and flecainide is used for the evaluation of the primary electrical disease in which the all investigation could not giving perfect result. And for the further evaluation, exercise test is also mandatory. If even after sodium channel blocker test we could not find anything, then test for the coronary vasospasm. Coronary vasospasm testing through the acetylcholine. And if we found the cause of cardiac arrest as coronary vasospasm, we should implant implantable cardiac defibrillator. For the evaluation of patients who are big relative of sudden cardiac death, we should evaluate history, physical examination, ECG and echo. And even after these findings, we should go for the genetic evaluation. And if we found evidence of electrical disease, we should advise sodium channel blocker test and epinephrine test. These are the certain indication of ICD in DCM. We all know that the EF less than 35% with NYHA 2 to 3 is a clear-cut indication of ICD. But in DCM, if EF less than 50%, but additional 2 risk factors like syncope or late gadolinium enhancement on cardiac MRI or inducible monomorphic VT on programmed electrical stimulation or pathogenic mutation, then we also advise for the ICD. In ARVC, if the patient having arrhythmic syncope or severe RV-LV systolic dysfunction or moderate RV-LV dysfunction along with either NSVT or inducible monomorphic VT on programmed electrical stimulation. In case of SCM, if the age more than 16 years with 5-year risk of sudden cardiac death more than 6% is the obvious indication of ICD, but if the risk is 4 to 6% along with the LG more than 15% of LV mass or LVEF less than 50% with abnormal BP response, that is increase of BP less than 20 millimeter of mercury or sudden fall of peak BP by 20 millimeter of mercury, it indicates positive BP response on exercise test. And if there is a presence of LV apical aneurysm or presence of sarcomeric pathogenic mutation, these are indication of ICD implantation in hypertrophic cardiomyopathy. In case of CPVT, if there is a history of aborted cardiac arrest, we should advise ICD. But if there is no history of aborted cardiac arrest, a patient having only bidirectional VT or polymorphic VT or arrhythmic syncope, we should advise first beta blocker and flecainide. Even after highest tolerated dose of beta blocker or flecainide, if patient having recurrent symptoms, then we should advise ICD. In Brugada syndrome, aborted cardiac arrest or ventricular arrhythmia is the obvious indication of ICD. But if the type 1 Brugada pattern along with arrhythmic syncope is a clear indication of Brugada ICD. Management of SCD in coronary anomaly patients. The surgery should be advised in a patient which are having cardiac arrest or syncope suspected due to the ventricular arrhythmia or angina when other causes has been excluded. Even in asymptomatic patient, if there is evidence of myocardial ischemia or abnormal aortic origin of left coronary artery with the high risk anatomy. These are the flowchart of management of cardiac sarcoidosis patient. If there is a EF of less than 35, we obviously advise ICD. But if there is an indication of current permanent pacing or the evidence of significant late gadolinium enhancement of more than 22%, or if there is a EF of 35 to 50% with minor LG, all these should advise ICD implantation. And after ICD implantation, if there is a recurrence of VT, then we should go for the catheter ablation and amiodarone. In patient of early repolarization syndrome, if the patient having obvious cardiac arrest, we should advise ICD. But if there is a arrhythmic syncope, and along with that, if there is a high risk early repolarization pattern ECG with history of early repolarization syndrome in the family and juvenile unexpected death, we can advise ICD as a class 2B indication. The high risk early repolarization pattern in ECG is the J-wave elevation more than 2 millimeter with a dynamic change in the J point elevation of more than 0.1 millivolt, or with J-wave associated with horizontal or descending ST segment. For the long QT syndrome management, aborted cardiac arrest is a clear-cut indication of ICD, but the patient having asymptomatic or syncope prior to medical treatment, first we treat through the beta blocker. Even after treatment of beta blocker, a patient having arrhythmogenic syncope, then we go for the ICD implantation. If the patient having a pathogenic mutation but without QT prolongation, we should only advise beta blocker. Finally, there is a cautious use of antiarrhythmic drug is needed in the patient management of arrhythmia. Don't use QT prolonging drug if the QTC interval is more than 500 milliseconds. If we are using QT prolonging drug, then monitor ECG at the baseline, then after 1 day and after 1 to 2 weeks of initiation or dose increase. If the QTC is more than 500, then the drug should be stopped or decreased in dose. After that, sodium channel blocking drug should be contraindicated in Brugada, prior MI, severe LV dysfunction, severe valvular disease, or severe bradycardia, any degree of bundle branch block, or any degree of heart block. Sodium channel block should be sodium channel blocking drug should be monitored if the QRS duration is prolonging by more than 25%, or QRS duration more than 130 milliseconds, or any degree of bundle branch block, then sodium channel blocker drug should be stopped. Thank you.
Thank you, Dr. for the beautiful presentation. Now we'll invite Dr. Upendra Narayan for important, for interesting diseases.
A very good evening to all of you, senior friends, colleagues, respected chairpersons. ECG is a basic tool which is very, very useful, not only in diagnosis but also in prognosticating and for the treatment purpose. So we daily encounter ECG in our CCU. One of such ECG, a 65-year-old male who presented with acute onset dyspnea for last 2 days. The residents already put on antiplatelet drugs and bolus of heparin. So those who are sitting in the back can come forward and can participate in this ECG. This will be interactive session. So can someone comment? What are the differentials? Yes, very good. So, right, Dr. Samsad. So there is a Q waves, narrow Q waves. Yes. This is the several findings which are consistent with acute pulmonary embolism. There you can see the Q waves in lead 3 and ABF and not present in lead 2. This is called the pseudo-infarct pattern, as well as S1, Q3 and T3. Q wave in lead 3 and T wave inversion in lead 3. This is also very specific. This is known as, this is also known as McGinn sign. As well as T wave inversion in anterior precordial leads from V1 to V4. These are the right-sided leads. So the next investigation I did was echo. Until before the echo, I was also thinking of coronary. But after echo, the one finding which led me to think otherwise, what was that? RV dilatation can be also in RVMI. What was that? Was that hypertensive TR, which is not present in the RVMI. TR will not be hypertensive. The RV pressure was 60. That was very much suggestive in a case of such type of ECG. So this was, we gone for CT pulmonary angiography, and diagnosis was confirmed. Both the right pulmonary artery and as well left pulmonary artery was choked. The patient was very unfortunate. He has also paradoxical embolism also. He has cerebral infarct. So we cannot give him the benefit of thrombolytic therapy. We have to go for some optional therapies. The ideal options would be mechanical thrombectomy. No, catheter also goes in the circulation, can increase the hemorrhage, and such a vital position in cerebellum that can lead to sudden death. Because whenever acidity we can give, but ultimately that will go in the circulation. So mechanical thrombectomy or thrombosuction is a good option, but I did not have option of that. So I did thrombus fragmentation with the pictal catheter in the pulmonary artery. And the patient gradually improved and discharged from the hospital. And the 6-month follow-up was okay on the follow-up. Although pulmonary artery pressure was slightly high, around 50, but doing well. Yes, infarction was there. Must, okay. So T-wave inversion is found in 40% cases. S1, Q3, T3, 10%. ST depression in the right precordial leads. And there could be transition of zone shift from to the V5. There can be incomplete or complete right bundle branch block. Other findings are pseudo-infarct pattern, low limb voltage. Although sinus tachycardia is a very frequent finding, but this is not very specific. This is another ECG. This is a ECG of 50-year-old male who presented with palpitation and chest discomfort for 18 hours. BP was slightly in the lower side, but okay, it was 100/70, and ejection fraction was around 50%. There was global hypokinesia. So what does this ECG is suggestive of what? This is a neuro-QRS tachycardia. Atrial flutter. What are other differentials? It can be AVRT or AVNRT or atrial fibrillation. Would be AVRT also. Yes. So we have the several options, several differentials in our mind. So what should be done? Yes, sir. Yes, sir. Long RP. What are the atypical AVNRT or AVRT? Yes, these are options. So what should we do? Should first go for carotid sinus massage, but was not effective. So IV bolus adenosine was given, 12 milligram. So what is this? Now, was it a AVRT or NRT? Yes, sir. Right, sir. Yes, CVQRS alternance is a feature of what? Yes, rightly picked up. So what does this ECG reads? Yes, there you can see this as a sinus beat with little QRS widening, and these are the maximally widened QRS complex. Why is this happening? One is the sinus excited lead, and basically what happens in a pre-excited lead and the sinus leads. In the this lead, this complex, you can see the PR is shortened, but QRS is not very widened. And this, why this is widened? Yes, this is not fully excited. What happens in this? Basically, first is the some part of the ventricle is excited by the pre-excited part, accessory pathway, but at the same time, the normal conduction passes, and this is a fusion type of ECG. That's why it's not very wide. And this is a fully excited complex. The same patient, since this patient has a pathway, so what should be done? We put on basically on Cardicon bolus and infusion dosage are given, and you can see this type of ECG. Yes, cardioversion was tried with Cardicon and was cardioverted into sinus rhythm. We also have option of flecairide class 1C drug, but coronary status was not known. The patient might have some structural heart disease. Yes. Procainamide is not available, and flecairide we cannot give because it increases.
What is the scientific rationale of trying these whole array of drugs? You have a DC water available.
Yeah, of course.
The simple logic.
But also you have to give in the follow-up, sir. You have to give in the follow-up also, because you can see here, after giving the bolus and maintenance doses of amiodarone, what is happening? What are the two type of again complexes?
Can we maintain this patient on a medical management? The answer is no. If I am
Yes.
giving proper medical advice.
Yes, for the maintenance purposes. Why
He should be shifted to a place where he gets RA ablation.
Yes, RA ablation should be done.
It's not about trying out different drugs and just setting a patient.
No. This is basically happening in one hospitalization. All the finding you are seeing is various type event you are seeing in the one hospitalization also. Definitely the case of RF ablation, we understand. So why there are two type of congestion?
We are prolonged, the AV conduction prolonged, the excitation through the excessive pathway happened, which leads to a prolongation of QRS. When PR prolongation happened, the same thing happened. Prolongation of QT PR interval.
Has a widespread effect on the conduction.
So what are these complexes? What are these radical complexes? What you are seeing by Gemini? This is the atrial by Gemini actually.
No, this is the abnormal conduction through the excessive pathway.
Yeah.
Due to the slow conduction through the
But these are, this is a sinus, these are, see, this is a sinus, this is upright into this, so this is the sinus. And this is, this is conducting with the inverted. That is, PSC is, is getting into the ventricle through accessory pathway. That I want to show you. Okay?
It's an ectopic
Ectopic. PSC is conducting through the accessory pathway. That's why you are getting such type of complexes. So what should be the next line of therapy? Beta blocker. I added the beta blocker and the patient converted into the sinus rhythm. And ultimately, such type of patient should be sent for the radiofrequency ablation. This is the option. This is the sinus rhythm with slight pre-excitation. So that is how localization of the accessory pathway is done. This is the ECG of another patient. What time is up? Already to ECG. Okay, this is a young lady which has 6 sinus syndrome, has several syncope, was implanted dual chamber pacemaker. So this what we do the routine ECG in our CCU after the shifting from the cath lab. This is the what does this ECG show? What?
Atrial pacing is normal conduction.
But you are seeing the ventricular complex.
No, only atrial pacing happens.
You can see the complex. You can see there is a small spikes. Spikes is also there. You can go closer and you can see that there are spikes before the ventricle also. There is but a spike also basically, sir. And this is after the magnet. Basically, that a spike, that was a fusion complex because the pace AB delay was almost equivalent to the normal intrinsic AB delay. That's why the pacemaker is pacing, but that is not captured. Yes, what should be done now? The AB delay, the pace AB delay should be increased in such type patient to avoid the pacing. Avoid intrinsic pacing should be done. This is a 50-year-old male having chest pain 4 days back. What does the ECG show? Now there is variation of opinion, basically, Yes, there is in POL MI, and you can see the P wave is inverted in both lead 1 and AVR also, and upright in AVR, and you can see the QRS complex is gradually decreasing when you go toward the left, and this is the right-sided lead. Now, what you can say? Yes, this is dextrocardia with inferior MI. Yes. We did the angio. There was very much problematic in doing angio, and RC was choked. This is the chest X-ray of that. What is this phenomenon is known as? This is the PR alternance. This you can see in the previous complexes, PR interval is prolonged. But after a PSC, you can see short. This is suggestive of dual pathway, dual AB pathway. That is conducting through the slow pathway, this is conducting through the fast pathway. 35-year-old female having progressive dyspnea for 10 days. Yes, total electrical alternance suggestive of the massive pericardial effusion. That is 38-year-old male CVN ICU having prolonged ICU stay. What is this known as, sir? You can see there is ST elevation and T wave inversion from V3 to V6, and there is also present in lead 1. This is called a spike helmet sign. This is found in the several type of disease condition, that is cerebral anoxia. Then there is also in case of acute coronary syndrome, some type there is sting bite. There is a good article published by A.N. Raya, sir. Sting. This is also the so actually this is also published in okay. Metabolic. So this is known as the Prussian helmet sign. This is known in this is spike. This what this is? This is the white QRS tachycardia. What this is AVRT? This is your VT or PSVT? Ventricular or supraventricular tachycardia? Yes, you can see this is not narrow QRS in between. This is the capture beat. Yeah, you can see there is a P waves here. This is the P wave, and one is sinus which is conducting. So this is a VT. No doubt. So this is after the giving a bolus dosage of Cardicon, same patient. 65-year-old hypertensive male with the giddiness. What is the sinus arrest with what? With a junctional excitation. You can see the inverted P waves. Retrograde conduction. Yes. Right. As 45-year-old diabetic male who presented with the acute chest pain. So what does it suggest, sir? This is also called the sharp fin or lambda ECG sign. There is a fusion of, it is formed by the fusion of the QRS, ST and T wave and is associated with the high motility, may be confused with
Dr.
ECG
Upendra?
of wide complex tachycardia. Yes, but just concluding, sir. I know you all people are very hungry and there is yes, there is ST segment ellipse. Yes, sir. This is very ST elevation in AVR as well as AVL, and there is a multiple ST depression in multiple. This lady has a left main ostial stenosis. बंद कर दें कल्चरल ओके थैंक यू
Thank you so much, everyone. May I now request our chairperson to felicitate our speakers. And Dr. Ajay is saying for Chadar Poshi, we have to wait here for, yes, of course. And your placing does matter, sir. So we have started our session by 9 a.m., our day one session, and it's 8 p.m. Thank you so much, ladies and gentlemen, all distinguished guests, for your valuable time and, of course, your patience. It was a meaningful yet impactful session, and it's a dinner time. So I would request all of you kindly take dinner. And last, I would request all of you kindly a huge round of applause for this beautiful yet meaningful session and for this beautiful moment as well.